A very good morning to all the esteemed faculty and all the delegates present over here. I welcome on behalf of Department of Anesthesia, ABVIMS, Dr. RML Hospital on day 4 of this academic fiesta, the Enriching Academic Fiesta, Appec 2025. I'm sure all the delegates and everyone, each one of us would have really learned a lot in the past days that have been going on. And I'm sure it's going to be another enriching experience, another enriching day for all of us today again. So without wasting any time, let's gear up for the day and start with our first session. So our first session, we have our speakers, Dr. Arushi Gupta and Dr. Perin Lalwani. And we have the moderator of the day, Dr. Sanjeev Palta. I would kindly introduce Dr. Sanjeev, sir. He is Professor and Head, Department of Anesthesia, Government Medical College Hospital, Chandigarh. His US level provider, FCCS instructor, State Award for Outstanding Work in COVID. He has also developed a prototype ventilator and he has 85 national and international publications and 17 book chapters. His areas of interest are critical care, a USG-guided regional anesthesia, and focus. A very warm welcome, sir, to this academic program. And I would request you to kindly introduce our first speaker of the day, sir. Thank you so much.
May I have the slide, please? Good morning to all.
Sir, your audio is not on.
My audio is on.
Yes, ma'am, it's on.
Am I audible? Good morning, all.
Yes, sir.
Yeah. May I now introduce Dr. Arushi Gupta, who is professor from VMC and Southern Hospital. She's an author of several international national research articles, and she has got Best Paper Award in NAC 2020 and Best Poster in ISACON 2019 as well as in 22. And her area of interest are regional and renal transplant. Dr. Arushi Gupta, the screen is all yours.
Thank you, sir. Good morning, everyone. Today, we'll be discussing about arterial monitoring and waveforms. Intra-arterial blood pressure is considered to be gold standard for blood pressure monitoring. It allows continuous beat-to-beat measurement in critically ill patients. It is very useful when NIBP measurement is difficult or probably inaccurate. So the indications would include whenever continuous real-time blood pressure monitoring is required. In an ICU, when the patient is on inotropes or vasopressors and pharmacological intervention is based on the blood pressure, it is always a good idea to put the arterial line. Arterial line can also be used for repeated arterial blood sampling. So where would you like to put your arterial cannula? Of course, the radial artery, which is the most common site, as it is easy to cannulate using the Seldinger's technique. Complications are rare. If you fail to cannulate the radial artery, you can always go for the ulnar artery. But always remember to do an Allen's test for collateral circulation before attempting to cannulate these two arteries. The femoral artery and the dorsalis pedis arteries are also common sites. Complications of arterial cannula include distal ischemia, pseudoaneurysm, and arteriovenous fistula. Arterial embolization has been widely reported. Moreover, the administration of drugs into the arterial lines when it is not labeled properly is a serious issue. Coming to the components of IABP system. The IABP system consists of an intra-arterial cannula, which should be short, narrow, and made up of polyurethane or Teflon. The diameter should be small so as to avoid the risk of embolization, as one can appreciate that the arterial cannula is connected to the transducer with the help of a tubing. This tubing is filled with fluid which is transparent and bubble-free and clot-free. The transducer is also connected to a pressurized saline. The pressurized saline consists of 0.9% normal saline, or heparin may be added, but heparin is avoided these days to prevent thrombocytopenia. The main function of the transducer is to convert the pressure signal into an electrical output. The electrical output is then relayed onto the microprocessor, where the signal is filtered, amplified, analyzed and displayed on the screen as a waveform of pressure versus time. From the morphology of this waveform, various cardiovascular parameters such as cardiac output, etc., can be calculated. We'll be coming to that a little later. Moving on to the technical aspects of IABP. The arterial waveform is a series of many component sine waves. The arterial pressure wave consists of fundamental wave, that is the pulse rate, and a series of harmonic waves. The process of analyzing complex waveform in terms of these simpler constituent sine waves is known as Fourier analysis, which is used to calculate the IABP. There are some very important terms for IABP measurement: the natural frequency, resonance, and damping. So what is natural frequency? Every material has a frequency at which it oscillates freely. This is called the material's natural frequency. Consider a pendulum of set weight and length. Whenever a push, no matter how big or small, is applied to the pendulum, it will oscillate with a fixed frequency. However, the amplitude may vary. Now, in case of a IABP system, if natural frequency of the IABP measuring system lies close to any of the sine wave components of arterial waveform, such as the pulse rate, also will cause excessive amplification and distortion of the signal. So, when a force is applied with a similar frequency to the natural frequency of the system, it will begin to oscillate with a very increased amplitude. This is known as resonance, which leads to over amplification and erroneous readings with wide pulse pressure and elevated systolic pressure. For this reason, we always choose an IABP system which has a frequency which is at least 8 times the normal heart rate, or say a heart rate of around 180, at which you want accurate readings. The natural frequency of a system is determined by the properties of its components. It may be increased by reducing the length of the cannula or tubing, reducing the compliance of the cannula or diaphragm, reducing the density of the fluid used in the tubing, and increasing the diameter of the cannula or tubing. Damping is anything that reduces energy in an oscillating system that will reduce the amplitude of the oscillations. Damping is nothing but friction, and friction is a necessary evil. In the IABP system, most damping is provided by the fluid pathway. Some amount of damping is required for the efficient functioning of the system. This is known as critical damping. However, if the friction or the damping is more, it leads to over-damping of the arterial waveform. This occurs due to air, blood clots, or kinks in the tubing. This results in an underestimation of the systolic blood pressure, overestimation of the diastolic blood pressure. However, the map remains unchanged. In an underdamped system, it leads to a rapid systolic upstroke, which causes overestimation of the systolic blood pressure, underestimation of the diastolic blood pressure, but the map again remains unchanged. For any system to be critically damped, the damping coefficient should be 1. So how would you know that your system is adequately or critically damped or not? When a fast flush is applied to the transducer and the IABP system, it causes a square wave, and those waves then oscillate and returns to the baseline without any overshoot. Then that would mean that your system is adequately damped. This is known as the fast flush test. It provides a convenient method for determining systemic dynamic response and detecting any system signal distortion. The fast flush test can also be employed for measuring the natural frequency and the damping coefficient. If the fast flush test is applied and the waveform is traced on a tracing paper, then the natural frequency can be calculated as the paper speed divided by the time of 1 cycles in millimeters. The oscillations have a definitive amplitude. If the amplitude of 2 or successive oscillation is noted and the ratio is calculated, that would give you the amplitude ratio. From the amplitude ratio, the damping coefficient can be extrapolated. Coming on to the working of transducer. As I mentioned earlier, that the transducers are connected to the arterial cannula via tubing which is fluid filled. The fluid faithfully transmits the pressure changes in the arterial system. The pressure changes leads to changes in the diaphragm which is present in the transducer. The diaphragm in turn is connected to a strain gauge. Now, when the diaphragm moves, the strain gauge is either compressed or stretched. The stretching or compression of the strain gauge leads to an alteration of the resistance offered by it. This strain gauge is incorporated into a Wheatstone bridge, where R1, R2, and R3 have a known resistance value. When there is alteration in the resistance of the unknown strain gauge, this leads to a potential drop across the system and the current flows. The potential drop is measured by the galvanometer. So our purpose of achieving a pressure change into an electrical output is hereby achieved. Coming to zeroing and leveling. This is routinely done in our OTs. For zeroing a pressure transducer, the atmospheric pressure must be discounted from pressure measurement. How do we zero a system? We expose the transducer, or more accurately, the tubing fluid, to atmospheric pressure and calibrate pressure reading to 0. This is done to establish a reference point as the ambient atmospheric pressure. Zeroing should be done repeatedly so as to avoid errors which occur due to baseline drift. Leveling. Where do we place the transducer? At what level? Well, the answer is very simple. We should place the transducer at the level which is our area of interest. Usually, we want to measure the pressure changes in the aorta and in the central compartment. So for that, we place the transducer in line with the fourth intercostal space in the mid-axillary line. This is known as phlebistosis axis. From here, we can faithfully, from here, if we place the transducer, we can get a fair idea about the arterial blood pressure in the heart and the aorta. But suppose your area of interest would be measuring the cerebral perfusion in neurosurgery OT. So your area of interest would be the circle of Willis. So where would you place the transducer? It would be next to the patient's ear, so that it will give you a fair idea of cerebral perfusion. Coming to the components of arterial waveform, the cardiac cycle can be divided into systole and diastole. In the systole, the blood is pushed from the left ventricle into the aorta, which causes a systolic upstroke, which can be seen here as 1. At the peak of contractility, the systolic blood pressure is measured, which is followed by a systolic decline. However, at the end of the systole, there is closure of the aortic valves, which is reflected as number 4, which is the dicrotic notch. From the dicrotic notch, the systole ends and the diastolic phase starts. Following the closure of the AV valves, there's diastolic runoff. The left ventricle relaxes, and this decrease in pressure of the left ventricle. The lowest point is known as the end diastolic pressure. An important point, the R wave of the ECG always precedes the systolic upstroke because there is always electrical depolarization which precedes the mechanical contraction of the left ventricle. This is another waveform showing the components of the arterial waveform. As I mentioned earlier, the systole extends up to the starting of the dicrotic notch. So the area under the systolic curve will give you the stroke volume. When the systolic stroke volume is multiplied by the heart rate, that would give you the value of cardiac output. The area under the diastole accounts for the afterload. When we calculate the area under the total graph, that would give you mean arterial pressure. The pulse pressure is calculated as SBP minus DPP, which gives you an idea about the volume status of the patient. Now, suppose in a patient you were to cannulate the dorsalis pedis, radial, and the femoral arteries. What do you find? That the waveform has a different morphology at all the three sides. Why is that? That is because of distal pulse amplification. In distal sides, the sum of pressure waves exerted by the forward flow and the pressure waves that are reflected by the blood vessels contribute to the total pressure. The more distal the sides, more the reflection. That is why in the distal sides, due to more reflection by the pressure waves, there is a steep upstroke and an increase in the systolic pressure. Remember, the map remains the same in all the three sides. Similarly, in elderly patients, there is reduced arterial compliance, which results in early return of peripheral reflected waves. This causes a late systolic pressure peak. Coming to abnormal arterial waveforms, in aortic stenosis, there is fixed cardiac output due to which the left ventricle is ejecting blood against an obstruction This leads to a slow and lazy upstroke in the waveform, which is known as pulsus tardus. In aortic regurgitation, there is excess of volume present in the left ventricle due to diastolic runoff. So, the pulse has two peaks. The first peak is due to ejection of the extra volume present by the left ventricle, and the second peak is there because of the pressure waves that are reflected from the periphery. This characteristic two-peak waveform is known as pulsus bisferens. Another condition, hypertrophic cardiomyopathy, you get a spike and dome fashion waveform. The early peak or the systolic upstroke is due to the contraction of the left ventricle. Then there's a downstroke due to contraction against an obstruction, followed by an upstroke, which is due to late reflected systolic waves. This is known as a spike and dome waveform. So we have covered all waveforms and arterial blood pressure monitoring. Thank you.
Yes, thank you, Arushi. The physics, which is the most complicated thing, has been very much simplified by you. And it's a very important topic with respect to the theory also, as well as from the practical aspect within the Viva. And I think after completing the CVP lecture, we can have any questions from the residents who have participated in this meeting. And can we have the next speaker, please, and the slide over there?
Thank you, sir.
Now we have Dr. Parin Lalwani. She's an associate with 5 chapters in the book, and IDEC and IDR qualifications, and our area of interest is Dr. Parin. Screen is yours now.
Hello, good morning, everyone.
Good morning, Dr. Parin.
Yes, sir, my topic is CVP monitoring and CVP waveforms. Hello, everyone. The topic of my today's presentation is CVP monitoring and waveforms.
Start.
Myself, Dr. Parin Lalwani. I am Associate Professor at AIIMS, New Delhi. First of all, let us see the various indications for CVP monitoring. It includes it may be used for the insertion of pulmonary artery catheter and monitoring pulmonary pressure waveforms. It can also be used for transvenous cardiac pacing, for temporary hemodialysis, for various type of drug administrations like concentrated vasoactive drugs, total parenteral nutrition, or chemotherapeutic agents which are irritating to peripheral veins. It can also be used for rapid infusion of large volumes of fluids in case of trauma and major surgery. It can also be used for aspiration of air emboli. And in case of inadequate peripheral IV access, one can also invert central venous catheter, and it can also be used for sampling blood in various type of clinical settings. So the normal CP value is between 4 to 10 centimeter of water, and in case of mechanical ventilation, it further increases by 3 to 5 centimeter of water. So the central venous pressure actually it reflects the right atrial pressure, which is almost equal to right ventricle end diastolic pressure. And this right ventricle end diastolic pressure actually it reflects the right ventricle end diastolic volume or the preload. So the central venous pressure or the right atrial pressure it provides information about the patient's intravascular volume and right ventricular preload. So now let us see what are the various sites for the central venous cannulation. Uh, there are various access sites for placement of central venous catheter, and these include internal jugular vein or subclavian vein or common femoral vein. These are the preferred sites for temporary prominent venous catheter placement, whereas the basilic vein and the brachial veins are primarily utilized for midterm and long-term central venous access in the form of peripherally inserted central catheters. Now, where should the tip of the CVC lie? It should lie at the junction of the superior vena cava and the right atrium. And why it is so? It is because these are the valveless system. The pressure generated in the right atrium will be then reflected through the central venous catheter, and ultimately it will measure the right atrial pressure. So before the insertion of central venous catheter, it is very important to understand the relevant anatomy and the adjacent structures. Then the decision of where to place a central line is typically based on clinical parameters and individual clinical experience and preference. Each anatomical site has relative advantage and disadvantages. The placement selection is largely driven by an individual patient's clinical history. So, most of the times, the internal jugular vein is preferred because of its reliable anatomy, accessibility, and the low complication rates, and the ability to employ ultrasound. It allows a more direct path to superior vena cava and the right atrium. It is wider and more superficial, thus easier to cannulate. Uh, but in case of various scenarios, like in case of trauma, history of head and neck cancer, or present or a history of other invasive devices or catheters, one may choose other site. So now let us have a brief look at the anatomy of the IJV. It is anterolateral to the common carotid artery in the superior portion of the triangle created by the two heads of sternocleidomastoid and the clavicle. IJV joins SC subclavian vein to form the brachiocephalic vein. And on the right and left brachiocephalic vein, they join to form the superior vena cava. Then the internal jugular vein, it can be accessed either through the anterior, if you want to do a landmark insertion, then it can be accessed through the anterior approach or centrally or posteriorly at the about the bifurcation of sternocleidomastoid muscle. The central approach is most commonly used, and the posterior approach it is safest as at this point, the vein is away from the lung apex and the carotid artery. Then anterior approach is also preferred as the carotid artery forms a readily palpable reference landmark. Then subclavian vein has the advantage of low rates of both infectious as well as thrombotic complications. It is accessible in case of trauma when a cervical collar negates the choice of internal jugular vein. But it has certain disadvantages like there is a very high risk of pneumothorax and it is less accessible for ultrasound and because of the non-compressible location posterior to the clavicle, it is a less preferred site as compared to the internal jugular vein. Now let us have a brief look at the anatomy of the subclavian vein. The site of the puncture of the central venous cannulation at this position is like it just lies posterior to the clavicle, and it has a tortuous extent, and it extends medially from the axillary vein. It progresses from the lateral border of the first rib, and it slopes cephalad at the middle third of the clavicle, and then caudally it merges with the internal jugular vein just posterior to the sternoclavicular joint. The vein is typically anterior and superior to the subclavian artery at this position. And the lung, it is just inferior. The lung is just inferior-medially to the subclavian vein and in close approximation to the lateral to the first rib. And the phrenic nerve also courses just deep to the brachiocephalic vein at the confluence of subclavian vein and internal jugular vein. The brachial plexus and the right side of the thoracic duct are also nearby structures here and are vulnerable for injury. Now let us see what are the various complications of central venous catheter. So during the procedure, it may cause various types of arrhythmias, typically ventricular bundle branch block due to the guide wire irritation of the atria or ventricles. It may cause arterial puncture or pulmonary puncture, which may lead to pneumothorax or hemopneumothorax. It may also lead to bleeding or hematoma formation, which can obstruct the airway also. It may lead to tracheal injury and air emboli during venous puncture or removal of catheter. There may be post-procedural complications like catheter-related bloodstream infections, bacterial or fungal infections, central venous stenosis, thrombosis, or delayed bleeding with multiple attempts in a coagulopathy patient. Now, after cannulating the vein, one of the lumens should be connected with the transducer, and it should be leveled roughly to the fourth intercostal space in the mid axillary line, and this is called the flavostatic axis. The peaks and troughs of the CAP waveform represent changes in the right atrium. So the CAP waveforms are actually a graphical representation of this pressure waveform, and it is composed of 5 key events: 3 peaks A, C, and B waves, and 2 descents X and Y descent. Analyzing these waveforms helps clinician to assess fluid status, right heart function, and overall circulatory volume. So now let us see the correlation of ECG waveform with CAP waveforms. Here we can see that A wave is produced by the right atrial contraction and it correlates with the P wave in the ECG. Then the C wave, which is also a positive wave, it is produced by the tricuspid valve closing in the early systole, and it correlates with the QRS complex. Then comes the X descent, the first descent. It is caused by the right atrium relaxation and the filling of the atria. It lies in the mid of the systole. Then comes the V wave, which is another positive wave, and it correlates with the T wave, that is the end of the systole or the ventricular repolarization. Here it is generated as the blood flows into the right atrium and there is an increase in pressure in the right atrium. Then comes the second descent, that is the Y descent. It correlates with the diastolic phase of the ventricle, and here the right atrium empties, the tricuspid valve opens, and the right atrium empties into the right ventricle. So here it correlates with the diastole, early diastole, and it just lies after the T wave. Now we will have an individual look at all these waves and understand in detail about all these waves. So as we saw that A wave is a positive wave and it correlates with the P wave in the ECG. It is generated by the right atrial contraction and it disappears with the atrial fibrillation. So it is produced at the end of the diastole of the diastole in the cardiac cycle. Then C, it is for the cusp. It is another positive wave in the CEP waveform. And C is for cusp. This is the cusp of the tricuspid wall. And it is generated at the time of the right ventricular isovolumetric contraction. The tricuspid wall starts protruding back through the atrium and it correlates with the end of the QRS complex in the ECG. Here again we can see the C wave and can see that the tricuspid wall at the end of the isovolumetric contraction, it is protruding back into the right atrium and causing increase in the right atrial pressure, which leads to the generation of C wave. Isovolumetric contraction of the right ventricle produces the QRS complex in the early systole. Now comes the X descent. After the isovolumetric contraction, this pulmonic wall, pulmonic wall opens. The right ventricle contracts further in the systole, and then the tricuspid valve annulus, it is pulled towards the right ventricular apex, and this movement of tricuspid valve further decreases the pressure in the right atrium, and there is also atrial diastolic relaxation, which further decreases the pressure in the right atrium, and it happens before the T wave on the ECG. So here we can see that there is decrease in the right atrial pressure, right atrium relaxes, and it leads to X descent. Now coming to the another third wave of the CV waveform, third positive wave, which is known as the V wave. It generates with the increase in the right atrial pressure at the end of the right ventricular and systole, and the blood comes inside the right atrium, which increase in its pressure, and as it hits the tricuspid wall, there is generation of back pressure wave, and it happens after the T wave on the ECG. After the ventricular repolarization, it also gives an impression of the tricuspid competence. Then comes the second descent of the CEP waveform, that is called Y descent. This is a pressure decrease caused by the tricuspid valve opening in the early ventricular diastole. So now let us see the various abnormal CEP waveforms. So there is loss of A wave in case of atrial fibrillation. Loss of A wave is because of the failure of atria to contract properly in case of atrial fibrillation. Then the Canon A waves. We can see here the huge Canon A waves, and it is caused. It is observed in case of junctional rhythm, where atrial contraction occurs at the same time as the ventricular contraction, which results in the fusion of the A and C waves. In the monitor, it looks like this in case of junctional rhythm. This is again the normal sinus rhythm. And here you can appreciate this, that these are the huge Canon A waves. These are also observed in case of retrograde conduction of ventricular depolarization, as in case of ventricular tachycardia, as well as in case of asynchronous atrial activity, like in case of complete heart block. Then accentuated A waves. These are seen in conditions such as tricuspid stenosis, where the atrial pressure increases to overcome the obstruction. So there accentuated A wave, and these are found in conditions like tricuspid stenosis, right ventricular hypertrophy, or pulmonary hypertension. Then comes regurgitant CV waves. These are observed in case of in conditions like tricuspid regurgitation, where there is backflow of blood out of the right ventricle, which obliterates normal ax descent. The C wave become accentuated and fuses with the V wave, as both are the results of right ventricle contraction, and the V wave peak pressure is often the same as right ventricle peak systolic pressure, and they usually fuse completely to produce huge mutant waves. Then bifid CEP waveform. Under normal conditions, the X descent is more prominent than the Y descent. But in case of constrictive pericarditis, the unyielding pericardium causes elevated atrial pressure and limits ventricular filling to early diastolic period. It leads to brisk and enhanced early diastolic filling, produces a sharp and deep Y descent, which is known as Frederick sign. The prominent Y descent often occurs in combination with prominent X descent and creating two steep troughs known as the W sign. So here, as we can see, this Y descent has it has become more deeper. It is because of the atrial contraction to overcome the pressure or the resistance which is caused by the constrictive pericarditis, which is not allowing the ventricle to fill. So the atria is contracting forcefully, and which leads to deep Y descent. Then attenuated Y descent. It occurs in conditions like cardiac tamponade. It is an acute condition where there is an abnormal amount of fluid accumulated in the pericardium. This abnormal buildup of fluid causes a compressive effect on the heart muscle, and actually this is a medical emergency. So the compression effect of the cardiac tamponade decreases the diastolic filling of heart and attenuates this Y descent. This also leads to compromised cardiac output.
I'm sorry, Dr.
I
Parin.
hope I
Really
have
getting late by 10
briefly
minutes.
described
Yes.
the various waveforms, and these are my references.
Okay,
Thank you.
that's good. That's good. Thank you, Dr. Parin. And what I can see over here is I don't know whether all these people who are sitting over here, other than the consultants, are there any participants? Right now, I have written twice over there in the chat if there are any questions, but nobody has responded.
Sir, we checked and there are no questions in the chat box. We have the participants and we have no questions in the chat box as well, sir. Sir, your voice is cracking. We're not able to hear you. Sir,
If there are no
voice is
residents
cracking.
or if the residents do not want to ask any questions, okay, and then there are no questions over here, and let the other people take over. Am I audible?
Yes, sir.
Hello?
Yes, sir, you are audible, sir. Sir, you are audible. Sir?
Hello?
You are audible.
Am I
sir.
audible?
Yes, sir, you are audible. We can hear you.
Okay, thank you. If I'm audible, I just want to request that we can, and what I'm saying is that we can conclude the session now, since there are no questions. But as such, Dr. Parin has also presented very well and simplified the topic of CVP. And maybe hand over the reins to you again for the next speakers. Thank you very much.
Thank you so much, sir. Thank you so
Thank you
much
very
for
much.
giving your
Allow me
precious
to
time to
leave.
us.
Good day
Yes,
to
sir.
all. Good morning. Good day to all. Bless you all. Thank you very much.
Thank you,
Thank you
sir.
so much, sir.
Thank you, Team Appec. Thank you, Dr. Itishri
Okay.
and Dr. Didi.
Thank you, Dr. Prerin. Thank you, Dr. Arushi, for your
Thank you.
and wonderful presentations.
Thank
So
you.
we'll
Thank
move
you.
ahead. We'll move ahead with our next topics. And this session will be moderated by Dr. Jaswinder Kaur Kohli ma'am. And the speakers for the session are Dr. Nityanandan Palaniswamy and Dr. Ira Balakrishnan. So Dr. Jaswinder ma'am, she is our esteemed professor and head of the Department of Cardiac Anesthesia, ABVIMS, Dr. RML Hospital, New Delhi. And she has various publications in national as well as international journals of repute to her credit. Her areas of interest are cardiac anesthesia and transesophageal echocardiography. Over to you, ma'am. Kindly please take over the mic and introduce our speakers. Thank you so much.
Thank you, Dr. Itishri, for your kind introduction. And today, I am very much honored that today I have to give introduction of my student, one of my students, Dr. Nityanandan. He is MD anesthesia and DM cardiac anesthesia. And he is consultant and he is affiliated to the Erode Medical Center Hospital, Tamil Nadu. Dr. Nitya was very honest, very sincere, and very hardworking PG students of Dr. Ramanohar Lohia Hospital. At that time, it was called PGIMER. And he has more than 30 publications in indexed international and national journals. He has won quiz competition in ISECON Delhi conference 2 times, 2015 as well as in 2016. He has also won the echocardiography quiz competition in PGI Chandigarh in 2020. Academic chairman of O2 ISECON Tamil Nadu State Conference in 2025. His area of interest are cardiac anesthesia and transplant anesthesia. Over to Dr. Nityanand and welcome to RML PG Assembly, Appec 2025.
Thanks a lot, ma'am. Good morning, ma'am. Good morning.
Nice seeing you.
Good morning, everyone. First, I want to thank academic team for giving me this opportunity to present Appec. To start with, what are things I'm going to cover in the next 15 minutes? First one is some definitions of cardiac physiology. Second thing is how it is significant cardiac output monitoring. Third thing is what is the principle involved in cardiac output monitoring. Fourth is what are the methods available. Next is clinical parameters that are going to help in hemodynamic management. First, what is cardiac output? Cardiac output is the volume of blood ejected from each ventricle of the heart per minute. It is nothing but stroke volume into heart rate. Then what is stroke volume? It is the volume of blood ejected by each contraction of the ventricle. It is determined by the preload, afterload, contractility. The stroke volume is usually 60 to 80 ml for an average size adult. Then there is contractility and inotropy. What is contractility? Contractility refers to the amount of work the heart can generate at given levels of preload and afterload. Whereas inotropy is an increase in work done by the heart that is independent of heart rate, preload, and afterload. What is preload? Preload describes the tension developed in the ventricular wall at end diastole End-diastolic pressure is taken as a surrogate measurement. It gives an indication of the filling pressure of the ventricle. Upload is, it is a tension that needs to be generated in the ventricular wall in order to eject blood into the arterial system during systole. Then what are the clinical indicators of cardiac output? Hemodynamic and end organ indicators. Hemodynamic indicators are heart rate, blood pressure, pulse strength at various sites, patient color, respiratory rate, core to peripheral temperature gradient. End organ indicators are urine output, capillary refill time, cognitive function. Always remember that no single clinical sign can be used to make an accurate assessment of cardiac output. Now comes a fixed principle. It forms the basics of cardiac output measurement. It says that uptake or excretion of substance by an organ is equal to the difference between the amount of substance entering the organ and the amount leaving. Blood flow to an organ, that is cardiac output, roughly equal to oxygen consumption, that is VO2 by concentration difference. You can see in the A and B picture. A picture says a big principle. B picture says Stewart-Hamilton equation, which says that, which is some slight modification of fixed principle, which says that volume of the molecule equal to the mass divided by concentration. So if concentration is measured over time, the flow can be calculated from the flow, that is the cardiac output equal to mass, that is the volume of injectant, divided by the concentration gradient, that is the temperature difference from the injector to the thermistor. The Stewart-Hamilton equation is nothing but volume equal to mass by concentration. So if concentration is measured over time, then flow can be calculated as flow, that is cardiac output equal to volume, that is the amount of drug injected, divided by temperature difference from the thermistor and injectant site. What are the methods? Methods are invasive, minimally invasive, and non-invasive. In invasive, you will see pulmonary artery catheter technique. In minimally invasive, you see LITCO, PICO, PRAM, flow track, TE, and esophageal Doppler. In non-invasive, bioimpedance, bioreactance, partial rebreathing, USCOM, TT. Next is the Windkessel, that is significant. What is Windkessel? Dr. Otto Frank, the German physiologist, likened it at the time to the Windkessel air chamber seen in the fire engines. You can see in the diagram. In the fire engine, you will see the air chamber that will generate a sinusoidal pressure that helps in generating the constant pressure throughout the pipeline. Okay. Similarly, whenever the fluid ejects the blood into the aorta, the aortic wall, to accommodate the excess 70 ml ejected by the stroke volume, it will expand and recoil. This is propagation throughout the arterial tree and it reaches the terminal tissues, thereby maintaining the constant and positive flow of blood along with the pressure maintenance throughout the peripheral arterial tree and the tissues. This is seen in the normal human individuals. This is likened by the Otto Frank compared to the fire engine thing. This is important because this Windkessel effect is lost whenever there is elastin and collagen is lost in the elderly patient. This is because of that elderly patients more prone to have systolic hypertension. Then invasive method, pulmonary artery flotation catheter is the gold standard worldwide. We can see that from the graphs. Right atrium, you will see the CVP waveform. Once it enters the right ventricle, systolic upstroke. When it reaches the pulmonary artery, you will see the diastolic dicrotic notch and diastolic beam appearing. Once it reaches the pulmonary capillaries or pulmonary arterioles, you will see the wedging. Once it is wedged, you will see the LV, end-diastolic or LA pressures. When you will place a PA catheter, main things are cardiac output measurement to measure and preload and volume state to assess and to measure the PA process and to look for right atrial and right heart and left heart functions and to look for the etiologies of pulmonary edema and to check the oxygen utilization and tissue perfusion. Why we are not using oxygen in cardiac output measurement? To ensure accurate measurement of oxygen, a sealed hood is required for measuring the gases. Subsequently, these lead to the development of dye or thermodilation techniques. In dye dilution technique, most common thing used traditionally was indosine and green. Why it is most commonly used? Because of low toxicity and short half-life time. Because of short half-life, the recirculation time is very much minimal, and there is a chance that it won't affect the concentration gradient later if it is not eliminated in shorter time. Lithium is next, that is not an ion in plasma, so it is next commonly used. What is the advantage is that small doses are enough to gain a high signal to noise ratio. Next comes the thermodilation. This has come into existence because to avoid the recirculation issues. Here we will inject 10 ml of cold saline through a PA catheter. The change in blood temperature is then measured from the proximal port where it is injected to the thermistor in the terminal distal portion of the catheter. Advantage of thermodilation is no blood sampling needed, no recirculation issues, accurate in blood balloon pumps and arrhythmias. The complications are because of PA catheter insertion, arrhythmias, infection, valve damages, PA ruptures. And here you can see the two diagrams. A is the indicated dilation PA catheter, second one is the transpulmonary technique. A, you will see pulmonary catheter is inserted, it is going into the zone 3 of the lung. Whereas in B, indicate dilation by transpulmonary technique. Transpulmonary technique is the central venous line will be there, and peripherally you will see arterial line. Through this, you will measure the cardiac output. Calibrated systems include pulse cardiac output. This uses transpulmonary thermodilation method. What it requires a standard central line, and therm is the tipped arterial line, which is placed within the femoral brachial artery. Whole saline is injected into the central line, and the temperature is measured at the arterial line. Whereas limitations are inbuilt margin for error as heat is lost and dissipates as it passes through the pulmonary circulation. Lithium dilation cardiac output. Lithium chloride is injected into a central or even peripheral vein, and the change in concentration is measured by an electrode sampling at the arterial line site. No loss of heat in lungs as experienced by PICO. The limitations are patients on therapeutic lithium will have the limitations, and cross-section muscle laxity, that is acrokernium and acromion, and frequent calibration is needed. Next comes the flow track and vigilo. These are specialized sensors known as flow track is used in this. Flow track sensor is attached to a standard arterial line, which is connected to the vigilo monitor, which uses data based on the population demographics like age, weight, height, and sex to estimate the aortic compliance. This information is then input into the flow track and vigilo pulse pressure analysis algorithm to calculate cardiac output. Limitations are this uncalibrated and relies on population demographic data. Under or overdamped arterial line traces will cause issues. Cardiac arrhythmias won't give correct values. Aortic regurgitation will impure. Presence of intra-aortic volume also interfere with the result. Next comes the benefits of it. These are fairly accurate measures that reflects well accuracy of thermodilation while avoiding the invasive complication of PA catheter. Then ECG accessible in theater or critical environments. It utilizes equipment that is already often in place, namely an arterial catheter, making it most cost effective. Next comes the aortic Doppler. It uses two principles, ultrasound and Doppler principle. Ultrasound probes contain piezoelectric crystals that emit sound waves at a set frequency when electricity is applied to them. These high frequency sound waves penetrate tissues, and the proportion are then reflected back and reach the piezoelectric crystals in the probe, which convert the kinetic energy into back to an electrical signal. This is measured by the ultrasound machine and converted into an ultrasound image. Next comes the Doppler principle. Here, when a material contains moving parts related to the source, such as blood flowing past the probe, then a frequency shift occurs, known as the Doppler principle. Reflected waves are at a higher frequency if the object is moving toward the probe, and lower if it is moving away. Actually, that is the received frequency equal to the 2 times transmitted frequency into V is the velocity, cos delta divided by C, that is the speed. Cross area is copied from the nomograms, and from this stroke volume and heart rate, you will copy this cardiac output. Here you can see the two graphs. Left side you will see the normal esophageal Doppler trace, and the right side you will see three pathologies. Top one is the reduced preload. You can see the underfilled narrow arterial waveform. Second one, mid one is the height is reduced. This is in the myocardial depression patient. Third one is you will see both height is reduced and the waveform also reduced in size widthwise. So this is high afterload patients. The limitations are position of the probe is crucial or operator dependent. An estimation of aortic cross-section area has margin for error. Turbulent flow invalidates the equation used to estimate flow from velocity and cross-section area, and difficulty in awake patients. The benefits are it is well utilized and studied in various studies, less invasive. Complications are esophageal trauma, stricture formation, and probe displacement. Next comes the bioimpedance. This is based on Ohm's law. Ohm's law describes the relationship between the potential difference, current, that is flow of ions, and resistance to the flow. Potential difference equal to current into resistance. Therefore, this can be written so that current, that is flow of ions, that is cardiac output, equal to potential difference divided by the resistance. Here, high frequency, low amplitude current is passed from the outer electrodes of the neck through the thorax to a level with the diagram, while inner electrodes measure the changes. Current will find a part of least resistance. Here, blood will have the least impedance and air has the maximum impedance. So, cylinder, imagine thorax as cylinder. Whenever cylinder expands during systole, as aorta distance, this increase in volume leads to a drop in impedance and increase in electrical conductivity, as blood has a low impedance. In transducing electrodes, measure both the baseline impedance and change in impedance. Stroke volume equal to volume of electrically participating tissues, that is calculated from the nomograms, and ventricular ejection time, that is calculated from the ECG, and ejection phase contact length, that is calculated from the dz by dt. You can see in the right side, the green and the blue one, you can see the slope dz by dt. From that, you will calculate the ejection phase contact length. Altogether, will give stroke volume, and from the heart rate and ECG, you calculate the cardiac output. Next comes the bioreturn. It is an improved technology when compared with bioimpedance because it analyzes relative phase shifts of oscillating currents and the resulting voltage signal impacted less by movement artifacts, patient body variance, and electrode positioning, and has a better results in comparative studies. Here, 8 electrodes are placed to either side of the neck, thoracic inlet, and to either side of the diaphragm. Proximal inner transducing and distal outer current electrodes. Between these electrodes, a high frequency, low amplitude current is then passed while the potential difference is ensured. The limitations are dependent on placement of electrodes, prone to interference and artifact like movement artifact and pottery, abnormal feeding thoracic cavity gives erroneous results like pleural effusion, variable correlation when compared with gold standard, improved with bioreactance technologies. Benefits are non-invasiveness and complications are nil significant reported. Next comes the echocardiography. Ultrasound probe is placed either on the chest wall for transthoracic echo or within the esophagus for transesophageal echo. These images are transthoracic images. You can see the BTI can be calculated by putting pulsed depth across alveoli in apical 5-chamber view. And for measuring the cross-section area, you will get from the parasternal long axis view. Alveotic cross area can be calculated. From this, stroke volume can be calculated. When you multiply with heart rate, you will get the cardiac output. In case of T, you will get the cross-section area in the mid-esophageal alveoli long axis view. You will get the pulse rate Doppler when you put across alveoli in the deep transverse view. You will get the BTA. From that, you will get the stroke volume. Finally, the cardiac output. Benefits are it is rapid, effective, and relatively non-invasive. Interchangeable thermodynamics in certain circumstances, whereas limitations are transthoracic echo may not be get adequate imaging in obese patients. Significant degree of training is required. Only gives a snapshot cardiac output. It may not give a continuous one. And in case of TOE, you need a sedation. Complications mostly related to TOE. It causes chance of arrhythmias, chance of bleeding in the airway or in the GI tracts, perforation, esophageal perforation, and rupture. Other modalities are PRAM, that is a pressure recording analytic method. Advantage is that it can be used in ion irrigation on IABP. Next thing is inert gas rebreathing techniques. Those are xenon, nitrous oxide, acetylene is under study now. Acumen IQ cuff and ultrasonic COM, that is ultrasonic cardiac output monitor. Clinical application. Why we have to monitor the cardiac output? Because it helps in guiding the fluid management. It helps in deciding which inotrope to start or vasopressor to stop, and also helps in hemodynamic optimization, critical current, high risk surgery. This is the monitoring range from low to high risk. Low is in the left side, high risk surgery in the right side. You will see in low risk surgery, pulse oximeter, capnometry, plethysmography is enough. In case of medium risk, you have to place arterial catheter, you have to see transfusible echocardiography, pulse counter. In case of high risk surgery, you have to go for indicated direction cardiac output, mixed venous oxygen saturation, pulmonary artery catheter. In case of high risk surgery for adequate cardiovascular monitoring. What are things we have to do proactively? Means we have to, in order to avoid hemodynamic compromise, we have to act before it happens. So what are things you have to maintain? First is maintain arterial pressure and heart rate within acceptable ranges, maximize the stroke volume, maintain pulse precipitation, stroke volume variation at less than 12%, or depth variability index at less than 14%, maintain cardiac index or oxygen delivery in desired range, maintain mixed venous oxygenation at more than 68%. What are the reactive things? Means hemodynamic compresses happen, means what are things we have to do? We have to correct hypotension, tachycardia, give fluids in presence of hypovolemia indicators like PPV or SVV less than or more than 12%. Iron feed reduction, cardiac output react promptly with fluid challenge. Iron feed reduction, central venous oxygen saturation react promptly with fluid challenge. In a nutshell, cardiac output is nothing but heart in the stroke volume. It's normal of 48 liters per minute and vital for tissue perfusion. Hip principle, although gold standard, because of invasive, it is rarely used nowadays. Thermodilution, it's accurate but invasive. Use polar normal saline, ear catheter. Pulse analysis, PICO, LITCO, flow track, semi-to minimally invasive things are used. Esophageal Doppler is minimally invasive, good for intraoperative use. Bioimpedance and biotrends are non-invasive, quick, less reliable in fluid overload and arrhythmias. Echocardiography estimates cardiac output via alveotivity, bedside and versatile. Mixed venous oxygen saturation will activate indirect markers of perfusion but not direct CO monitors. Clinically, it can help in using it can help in guiding the fluids, inotropes, and vasopressors in ICU and surgical intraoperative things. Limitations are no perfect tool, use trends plus clinical context. Always remember that no device is perfect. Always interpret values in clinical context and trend over time rather than single readings. Thank you. Good day.
Thank you, Dr. Nitya. It was wonderful and crisp presentation, and you have shown all the indication and contraindication of the specific method and what are the uses in clinical clinical uses of these cardiac output monitoring. Thank you very much, Dr. Nitya. I think we are running late. So our next speaker is Dr.
I would like to, just a moment, Dr. Jaswinder. Thank you so much for joining. It's really, it's a moment of great pride that both of you are faculty. Nitya is from here. I would like to tell our postgraduates that Dr. Nitya was with us. He was a postgraduate here, and it's
Yeah.
really, it feels, it's a proud
We
moment
really
for
feel
us
proud.
to call him as a faculty here.
Yeah.
And thank you so much, Dr. Nitya, being part of this. And we'll continue to involve you in coming years also. Thank you, Dr. Jaswinder. Abhi, you'll be conducting another one also. Thank you, Nitya.
Ma'am, can I have 1 minute, ma'am?
Sure.
Next time, definitely.
Okay, sure.
But otherwise, we'll involve you.
Thanks a
Definitely.
lot, ma'am. Only thing
I'll
is-
keep this in mind. Definitely.
Thanks a lot. Yes.
Thank you. Thank you so much, Nitya. Thank you, Jaswinder.
Our next speaker is Dr. Ira. Dr. Ira is Associate Professor in VMMC and Safdarjung Hospital, New Delhi. She has numerous publications in national and international journal, and she has written several chapters in the books. Her area of interest is cardiac anesthesia, thoracic anesthesia, and pediatric anesthesia. And here I would like to say Dr. Ira is very sincere and hardworking and dedicated cardiac anesthetist, and she is working in Safdarjung Hospital, VMMCC. Over to Dr. Ira. Dr. Ira, good morning.
Thank you, ma'am. Good morning, ma'am. Good morning, everyone.
Good morning,
Hello,
Dr.
everyone.
Ira.
I'll be talking about transesophageal echocardiography. First report of intraoperative echocardiography was over 30 years ago by Barash and colleagues in 1978. Real-time TEES emerged as an intraoperative monitoring tool for myocardial, valvular, and hemodynamic performances. It has shown to have benefits in both cardiac and non-cardiac surgical populations. TE imaging is based on the piezoelectric effect principle. Transducer uses piezoelectric crystals to emit brief pulses of sound, which propagate through and is subsequently reflected from the cardiac structures encountered. The returning sound waves are converted into electrical energy, which generates an image. The omniplane angle is used to rotate the ultrasound beam from 0 to 180 degrees. Familiarity with nomology, probe selection, and various modalities like 2D, color flow Doppler, spectral Doppler, and M mode needed to provide accurate hemodynamic assessments. The wave depth and 2D gain should be adjusted to get good quality images, and color scale adjusted to an IKIS limit of 50 to 60 cm per second for detecting high flow lesions, and a lower color scale of 20 to 30 cm per second for lower flow areas such as the interatrial septum. Coming to the probe manipulation, the main movements are advancement and withdrawal, and turning to the right and turning to the left. And using the larger knob, we can do anti-flexion and retroflexion, and using the smaller knob in front, we can do flexion to the right and flexion to the left. And this electronic switch is used to change the omniplane angle from 0 to 180 degrees. Coming to the probe position, depending upon the position, we get different views. Upper esophageal views at 20 to 25 cm, mid esophageal views at 30 to 35 cm from the incisor, transgastric views at 40 to 45, and deep transgastric at 50 centimeters. Contraindications for TE, absolute contraindications include perforated gastric or esophageal perforations or lacerations, esophageal stricture and tumor, esophageal diverticulum, and active upper GI bleed. Whereas relative contraindications include previous GI surgery, upper GI bleed, symptomatic hiatus hernia, dysphagia, esophageal varices, coagulopathy, Barrett's esophagus, radiation to neck and mediastinum, and cervical immobility. Coming to the complications related to TE probe insertion, it's reported to be about 0.2 to 2.5%. Oral or lip damage is the most common. GI or pharyngeal hemorrhages, dental damage, airway compromise, esophageal or gastric perforation, and distraction from patient care are also reported. Coming to the indications of perioperative TE, open cardiac surgery is a class 1 indication. And non-cardiac surgical settings also, the TE is commonly used in liver transplant surgery, in neuroanesthesia where sitting craniotomy is performed, vascular surgeries with major volume shifts, critical care and emergency room with patients presenting with hemodynamic instability. The emergency use of perioperative TE is reasonable in patients with hemodynamic instability undergoing non-cardiac surgery to determine the cause of hemodynamic instability when it persists despite attempted corrective therapy if expertise is readily available. Now coming to the comprehensive TE, there are up to 28 TE views which are there for advanced hemodynamic monitoring. These are the views. But as an anesthesiologist, we can do with the basic perioperative TE, which are there are 11 recommended basic windows for the hemodynamic monitoring, which can be used for left and right ventricular function assessment, wall motion abnormality, volume status, gross valvular pathology, vessel integrity, tumors or intracardiac masses, pericardial effusion, and tamponade. These are the 11 views. Now coming to each, in the mediasophageal four-chamber view at 30 to 35 centimeter and at an angle of 0 to 20 degrees, you get 4 mediasophageal four-chamber. You get the RA, LA, RV, LV, the tricuspid valve and the mitral valve, the interatrial and interventricular septum, RV free wall, the inferoseptal wall of the LV, and the anterolateral wall of the LV. This part is supplied by the RCA. This is LAD here, and this is LCX. We can see the RA, LA, RV, LV sizes, LV contractility and regional wall motion abnormality, RV free wall contractility, RV LV ratio, volume status, pericardial effusion or tamponade, color Doppler across the valvular abnormalities, diastolic function of left ventricle, presence of any ASD or VSD. Now from the mediasophageal four-chamber view, increase angle to about 80 to 90 degree, where you will get the mediasophageal two-chamber view. You can see the LA, the mitral valve, A1, A2, A3 and P3 scallop, the LV and the LV apex, and the LA appendage. You can assess the regional wall motion abnormality. This is the inferior wall supplied by the RC, and this is the anterior wall supplied by the LAD, and also see the mitral valve pathology, assessment of LA appendage for clot and LV apex for clot. The third thing is a mediasophageal long axis view, which is obtained by increasing the angle from the two chamber to about 120 to 140 degree. You get the LA, mitral valve, LV, LVOT. This is aortic valve here. This is a ascending aorta, aortic root and ascending aorta, and small part of RV seen. This is your inferolateral wall, and this is the anteroseptal wall. This is supplied by your LCX. This is the LAD, and this will be the RCA. So you can again see the LV size and function, regional wall motion abnormality, gross valvular abnormalities or of the mitral and aortic valves, and the LVOT measurement for the measurement of cardiac output, aortic root assessment, presence of any LVOT obstruction like in HOCM, positioning of mechanical assist devices. From the mediasophageal long axis view, slightly withdraw the probe so that you get the ascending aorta in the long axis. Here you can see the ascending aorta in the long axis, and the right pulmonary artery is seen in the short axis behind the ascending aorta. You can assess the aortic pathology like atheroma or dissection or aneurysm, and any embolus in the right pulmonary artery. From this view, rotate the angle to about 0 to 45 degrees so that the ascending aorta comes in the short axis, and you can see the SVC on the left side and the main pulmonary artery in its long axis on the right side of the ascending aorta, and the main pulmonary artery dividing into the right pulmonary and the left pulmonary arteries. What all you can assess here? The ascending aortic pathology like atheromas, dissection, aneurysm, pulmonary artery pathology. There can be any presence of embolus or clot, pulmonary valve interrogation, presence of pulmonary artery catheter, and PTA. Now, after this, what you can do is go back to mediasophageal four-chamber view and slightly withdraw the probe and increase the angle to about 25 to 45 degrees so that you get the aortic valve in the short axis. This is the Mercedes-Benz sign. You get the non-coronary, left coronary, and the right coronary, and there is an interatrial septum. So basically what you can see here is aortic valve anatomy and pathology, any AS or AR with color Doppler, aortic valve area with planimetry, and interatrial septum for ASD or PFO. From this view, slightly advance the probe and increase the angle to about 50 to 70 degrees so that you get the RV inflow-outflow view. Here you can assess the tricuspid valve anatomy and function, the RV inflow and outflow tract structure and function, pulmonary valve pathology, presence of any VSD. Here you get the subaortic VSD, here you get the subpulmonic VSD, and RVSP and pulmonary artery systolic pressure measurement by Doppler interrogation of the tricuspid regurgitant jet if it is there, and presence of or the guiding the placement of PA catheter. Now from this view, again, I increase the angle to about 110 degree and rotate the probe towards right. Then you will be getting the midesophageal bicaval view, where you will be able to see the left atrium, the interatrial septum and the right atrium, and the SVC and IVC opening to the right atrium, and right atrium giving rise to tricuspid valve and the RV. You will see the RA size, the interatrial septum, presence of any ASD or PFO, tumors or masses, SVC and IVC assessment, fluid responsiveness, SVC and IVC diameter changes, presence of CVP line, and useful for cannulating the cannulation during ECMO or robotic surgeries or minimally invasive cardiac surgeries, and interrogation of the tricuspid valve and calculation of RVSP. Now again, go back to your midesophageal 4-chamber view at 0 degree. Now rotate the probe, turn the probe totally towards left side so that you get the descending aorta in the short axis view. And by advancing or withdrawing the probe, you'll be able to assess the descending aorta in the whole length, and you will be able to see the descending aorta as a circular structure. And what you can assess is aneurysm, dissection, or any atheromas. And during placement of IABP or percutaneous LVAD and ECMO cannula, this view is useful, and also for the assessment of left pleural effusion. Descending aorta long axis is obtained from the short axis by increasing the angle to about 90 degree. Same information can be obtained in that. Now again, go back to your midesophageal 4-chamber view. From the midesophageal 4-chamber view, advance the probe to the transgastric level about 40 to 45 centimeters, and then slightly antiflex so that you will get the transgastric short axis mid-papillary view, which is one of the most important views in the TE, where you can assess the LV as a whole. This is the posteromedial papillary muscle at the 2 o'clock position, anterolateral papillary muscle at the 5 o'clock position. This is the anterior wall, inferior wall, anteroseptal, inferoseptal, anterolateral and infralateral wall. This is the inferior wall. This is supplied by the RCA here, supplied by the LAD here, and this is supplied by the LCX here. So what is the information you get here? LV size and thickness, LV contractility and regional wall motion abnormality, LV volume status, interventricular septum shape and motion, RV-LV interdependence, fractional area change for LV systolic function, and pericardial effusion. So the 11 views are almost over, but I'll be just talking about a deep transgastric long axis view. That is, from the transgastric view, keep the probe neutral and then advance further up to the deep transgastric level and slightly antiflex and flex the tip towards left. You will get the aortic valve in the long axis, aorta in the long axis, and this will be your LVOT. Put the pulse wave Doppler interrogation here to calculate the velocity time integral for calculation of stroke volume. Okay. This is for deep transgastric long axis view. Now another important view is transgastric IVC view, which is obtained about 50 to 80 degree by rotating counterclockwise, clockwise towards right and slightly antiflexing. You will be getting the IVC in the long axis, and you can see the right hepatic vein opening to the IVC. You can see the IVC diameter, IVC collapsibility or distensibility, fluid responsiveness, and also for guiding the cannulation or guide wire during robotic surgeries or mixed surgeries or ECMO cannulation. Now, T for hemodynamic assessment, it is required for the differentiation of etiology of various shock states and fluid, to see the fluid responsiveness, myocardial dysfunction, and identifying acute life-threatening conditions. So when patient comes in shock, first thing is hypovolemic shock. How do you identify? T can be an assessment for, it is useful for assessment of volume status and also for goal-directed fluid therapy. Most important view is transgastric LV short axis mid-papillary view. In hypovolemia, there is reduction in the LV cavity. Both LV and diastolic area and end-systolic area are reduced from the baseline, or there is obliteration of the LV cavity during systole, that is kissing papilla. You can see here, there is LV end diastole and end systole. Both are reduced in this. And the second thing is IVC diameter. As already said, we can see the IVC diameter may be small, and also collapsibility or distensibility can vary depending upon the ventilated status. And there is respiratory variation in the VTI. The LVOT can also evaluate the stroke volume and fluid responsiveness. So this is how you identify the hypovolemia. And stroke volume estimation can be done from the left ventricular outflow tract and using the formula cross-sectional area into velocity time integral. The LVOT diameter is measured from the LV long axis view And velocity time integral is measured from the deep transgastric long axis view. By multiplying the cross-sectional area into VTI, you will be getting the stroke volume. The normal LVOT VTI is between 18 to 22 centimeters, and multiple VTI measurements are done and averaged to accommodate fluctuations in conditions like atrial fibrillation, hypovolemia, or tamponade. Serial VTI can be used for assessing the fluid responsiveness. Now, once a hypovolemic shock is ruled out, second thing is your distributive shock. It is usually seen in inflammation or infection or sepsis, or in post-cardiopulmonary vasoplegia, etc. In that case, what happens? There is very low SVR. The cardiac output is very high. There can be normal or high cardiac output. So the end systolic area will be small, but end diastolic area may be normal. This is how you differentiate from a distributive shock from a hypovolemic shock. Okay, you can see the ADA is normal, but the ESA is small, and the LV is very hypercontractile. So you may have to add the volume status and vasopressors have to be added appropriately. Okay, next is the cardiogenic shock. In cardiogenic shock, it could be due to multiple reasons. One could be ventricular dysfunction or failure, myocardial ischemia or infarction, complications of MI like acute MR or ventricular septal rupture, valvular heart disease, pulmonary embolism, or arrhythmia. So for the ventricular function, for the LV systolic function, qualitative assessment of LV function is done using eyeballing technique in the transgastric mid-papillary short axis view. See here, during the systolic phase, it is thickened and it is moving inward and the cavity is coming down. Whereas in this case, if you see, the thickening is not that much and the cavity is not coming down. So there is dysfunction here, there is no dysfunction here. The quantitative assessment is done using 2D Simpson's biplane method and in 4-chamber or 2-chamber, and fractional area change in transgastric mid-papillary short axis view. So the Simpson's method is the only method currently recommended for the calculation of LV volume and ejection fraction using 2D echocardiography. This employs a principle of summation of 20 cylindrical disc of equal height. So during diastole and during systole, we have to calculate this. Volume of each of these 20 discs is summated separately in the two orthogonal planes in 4-chamber and 2-chamber and average to get the LV volume. Normal ejection fraction is 55 to 70%. The another method is fractional area change, which is done in the transgastric mid-papillary short axis view. The endocardial border of the LV is traced by planimetry without including the papillary muscle, and in the end diastole and the end systole. And using this formula, the fractional area change is calculated, which is about 56 to 65%. The first thing is the LV function is ruled out. Next is your regional wall motion abnormalities. It's a TE is a very sensitive monitor for detection of perioperative MI. Left ventricle is visualized in 17 segments, 6 at the base of the heart, 6 at the mid-papillary level, 4 segments at the apical level, and an apical cap. Allows identification of ischemia within specific coronary artery territories. LV segmental functions assessed from ventricular wall motion and thickening during systole. The transgastric mid-papillary short axis view is frequently employed to detect the regional wall motion. So basically, we know here this is the RCA portion, this is your LAD, and this is your L6. So transgastric mid-papillary gives an idea about the distribution of all the coronary arteries. And the normal motion is thickening of more than 30% and inward motion. Hypokinesia is 10 to 30% increase in thickness only, whereas in akinesia there is less than 10% increase in thickness. In dyskinesia, it thins during systole with outward movement during systole, seen in infarcts or aneurysm. And paradoxical motion is seen when there is thickening during systole with outward movement during systole, seen in pacemakers or in bundle branch blocks. Similar to the LV, RV systolic function is assessed in the by fractional area change in the midesophageal 4-chamber view. And if there is a less than 35% RV fractional area change, there is RV dysfunction. And another important thing is tricuspid annular plane systolic excursion, which is the excursion of the tricuspid plane towards apex. What happens? The movement is less than 17 millimeters. It is abnormal. Normally, it should be more than 20 to 20 millimeters. So here you can see the RV. The RV is not moving at all. There is RV dysfunction here. LV seems to be fine, but RV is not moving at all. Now, there is hemodynamic instability. The contractility is fine, the preload is fine. Still, the patient is having hemodynamic instability. So always think about LV diastolic dysfunction as a differential diagnosis. It can come as a short note in your exam. So please prepare on it. And another important cause for valvular lesion is cardiogenic shock. Another cause for cardiogenic shock is valvular lesion. So what happens is there is acute when there is acute hemodynamic instability, new onset valvular lesions should be interrogated with color flow and continuous flow Doppler to grade the severity. The color flow, it shows the direction and velocity of the blood flow. The red, matlab, the blood flow is towards the transducer, and blue means the flows away from the transducer. So you can just grossly find out whether there is a regurgitation or a stenosis in the valves, and if further interrogation is needed, then advanced echocardiographer can be called. And so we should be knowing about the basic grading of mitral stenosis, regurgitation, aortic stenosis, and aortic regurgitation for your exam purpose, and for otherwise also. Okay. Now the cardiogenic part is ruled out. Next is your obstructive shock. Obstructive shock could be because the filling is not happening, or once it is filled, it is a forward flow is not happening. So it could be either because of tamponade or because of pulmonary embolism. In cardiac tamponade, what happens? There is pericardial effusion with tamponade physiology. That is, there is diastolic RV collapse and there is systolic RA collapse, and the IVC plethora is there with minimal respiratory variation, and there is septal bounce. This is how you identify the cardiac tamponade. And in pulmonary embolism, the clot may be present in your pulmonary, main pulmonary, or in the distal pulmonary. Sometimes you will not be able to identify the clot, but there will be strain pattern on the RV. The RV is severely dilated with reduced RV free wall motion and septal deviation towards the left side and tricuspid regurgitation. And McConnell sign is highly specific for pulmonary embolism. So now the hemodynamic instability is still persisting. All these things are ruled out. You should see if there is any structural problem. Here you see here there is a flap here. So there's an aortic dissection in the ascending aorta. So instead of going to the true lumen, the blood is flowing to their false lumen. So dissection flap in ascending aorta is a acute emergency. Next is here you can see an LA thrombus obstructing the mitral inflow. It could be a thrombus or a clot. If it is obstructing, again we can go into low cardiac output state. Here, the third thing is, here you can see there is a septal hypertrophy, and there is systolic anterior motion of your mitral leaflet, which is causing LVOT obstruction. This is a case of HOCM. So whenever patient comes with features of shock, you have to see, identify the type of shock, whether it is hypovolemic or distributive or obstructive or cardiogenic. So always see these questions. Are the LV and RV contracting adequately? Are the regional wall motion abnormality? What is the patient's volume status? Is there a significant valvular lesion? Is there a ventricular outflow tract obstruction? Is there a significant pericardial effusion? Is there an intracardiac mass or clot? So TE as a real-time imaging technique offers better quality images than TT without disturbing the surgical field. Basic perioperative TE helps the anesthesiologist to assess the etiology of hemodynamic instability using fewer windows. Thank you.
Thank you, Dr. Ira. It was wonderful presentation. And within 15 to 20 minutes, you covered whole topic of TE, including its use in OT and its use in critical care, and how to check, how to assess the shock of the patient. If the patient is in shock, how to rule out the disease. It was wonderful presentation. Are there any questions? I don't think I'm not seeing any question in the chat box.
Yes, ma'am, there are no questions in the chat box.
Thank you. Thank you
Thank you
very
so much,
much.
ma'am. Thank you for taking out your precious time and being a part of Appec 25, ma'am. Thank you so much. Thank you, Dr. Ira. Thank you, Dr. Nitya. They were really very illustrative and informative lectures, and I hope our participants would have gained immensely from them. So if the teachers they have taught, they will ask us. So we have some questions for our delegates. Can we please get the questions displayed on the screen? Okay. So let's see. The first question is, A wave in the CVP waveform, it coincides with which part of the electrical activity of the heart? End systole, end diastole, early diastole, or mid systole? So let's see how many right answers we have. Then we have question number 2. A 65-year-old male undergoing major abdominal surgery has an arterial catheter placed in the radial artery. You notice the arterial waveform shows a steep upstroke, a narrow pulse pressure, and a rapid downstroke with an absent dicrotic notch. What is the most likely cause? an underdamped system, an overdamped system, aortic regurgitation, or hypertrophic cardiomyopathy. So let's see how many right answers we have. Now we'll break for a short for the tea, but since we are lagging behind, we'll try to make up and we'll meet within 5 minutes of the tea break. Thank you so much. So let's meet at 10:25, waiting for everyone.
Thank you. Thank you very
Thank you, ma'am. Thank you.
Thank you.
Thank you, Dr. Ira. Thank you,
you.
Dr. Nitya.
Thank you, Manu.
Very nice lectures.
Absolutely.
Really.
Thank-
Thank you, Dr. Eti. Thank you, Team Appec.
Thank you, Dr. Tishri and Team Appec. All the best.
I hope all our delegates are back. So let's continue with our sessions. And next in line, we have a long case presentation on chronic hypertension posted for modified radical mastectomy. This is a very important topic from the point of view of our anesthesia viva OC. But before this, we would want to have answers to our questions. Mr. Sudhir, can you please display the questions once again on the screen?
Yes, madam.
Yeah, please.
Here's the question.
Yes, so the question was, A wave in CPP waveform, it coincides with which part of the electrical activity of the heart, whether it's end systole, it's end diastole, it's early diastole, or it is mid systole. So the answer for the question is B, that is the end diastole. The next question was, a 65-year-old male undergoing major abdominal surgery has an arterial catheter placed in the radial artery. You notice the arterial waveform shows a steep upstroke, a narrow pulse pressure, and a rapid downstroke with an absent dichrotic notch. What is the most likely cause? And the answer over here again is B, which is overdamped system. So let's see, we'll see it later on how many of us has answered it correctly. And now we'll move ahead with our long case presentation. And for this, I would invite our esteemed director, Professor Ma'am, Dr. Lalita Chaudhary Ma'am. She has been associated with us and she's here in ABBIMS at Dr. RML Hospital, New Delhi. She has various achievements to her credits. She is a certified AHA ACLS instructor. She has several publications in international and national journals and several book chapters to her credit. She is specialist member in NBE. She has been an expert in inspection and conducted by the NMC, and she is a technical expert in UPSC selection board. Her areas of interest are the critical care and pediatric anesthesia. A very warm welcome to ma'am for taking out your time and enlightening our students, ma'am. Thank you so much, ma'am.
Thank you, Dr. Itishri. Thanks a lot.
Then we have Dr. Veena Chatrath, ma'am. She's professor and head, Department of Anesthesiology and Critical Care, GMC, Amritsar. And she has received ISA Diligent Award. We'll continue with our long case presentation. Thank you. Thank you, ma'am. Ma'am, please can we move ahead?
Yeah.
Thank you, ma'am.
Okay. Itishi, can you hear me? See, I cannot hear Itishi.
Dr. Nimit?
Yes, ma'am.
Dr. Nimit and Dr. Shireen to kindly join. Dr. Nimit is a third-year postgraduate student in ABBIMS Dr. RML Hospital. And Dr. Shireen is senior resident in Department of Anesthesia in ABBIMS Dr. RML Hospital.
Morning, ma'am. I'm presenting a case of chronic hypertension posted for modified radical mastectomy.
Dr. Nimit, be slow and clear, right?
Yes, ma'am.
I thought I would call you as
38-year-old resident of Mayapuri, West Delhi, housewife by occupation, belonging to upper middle class. She presented to OPD with a chief complaint of lump in left breast for 6 months and left nipple retraction for 3 months. History of presenting illness. Patient was apparently well 6 months back. Then she noticed a swelling in left breast, which was initially of pea size, and it has gradually increased in size to that of a tennis ball. Patient noticed retraction of left nipple 3 months back, and there is a history of retraction on skin overnight the swelling. The swelling is not associated with pain. There is no history of nipple discharge or nipple destruction, and there is no history of any other swelling in the opposite breast or axilla. There is no history of trauma, no history of loss of weight or loss of appetite, no history of back pain, no history of cough, breathing difficulty, chest pain, no history of jaundice or abdominal distension, no history of headache, vomiting, or seizures, no history of radiotherapy. There is a history of chemotherapy. My patient received 6 cycles of chemotherapy of adriamycin plus cyclophosphamide, and last cycle was 3 weeks back.
Dr.
Past-
Nemeth, Dr. Nemeth, why you have asked history of cough in this case?
Ma'am, cough, breathing difficulty, and chest pain can be due to metastasis of breast cancer in the lungs. So to rule out metastasis, negative history pertaining to cough.
Okay. Now you can proceed.
Yes, ma'am. Past
And what
history,
type of
my
chest-
patient known case of hyper.
Again, what type
Sorry.
of chest pain you have asked?
Ma'am, in this, I've asked chest pain while breathing, pleuritic
Chest pain while breathing.
Ma'am, pleuritic pain, sharp pain while breathing.
What else? To rule out any serious problem like CAD,
Ma'am, to rule out any.
heart disease,
Yes,
huh?
ma'am. Yes, ma'am.
Yes. And why breathing difficulty?
Ma'am, as our patient is in, as we are suspecting breast carcinoma in our patient, to rule out breast carcinoma metastasis in lungs, we have asked history pertaining to breathing difficulty, cough, or chest pain.
But you didn't ask about the history of breathlessness.
Ma'am, I have asked history about breathlessness
Is it
too because
important?
yes, ma'am, because my patient is also a known case of hypertension. So hypertension can result in heart failure, which can result in breathlessness and dyspnea.
What do you mean by breathlessness?
Ma'am, breathlessness is abnormal sensation while breathing, abnormal unpleasant sensation while
It's not a
breathing.
no. It's not a normal sensation. It is an unpleasant sensation.
Yes, ma'am.
It is an unpleasant sensation. Awareness of breathing.
Yes, ma'am.
Okay? Unpleasant. This is not pleasant, right?
Yes, ma'am.
Next.
Past history, my patient is a known case of hypertension for 6 years and on regular medications. Patient had history of mild to moderate headache and family history of hypertension. She was diagnosed as hypertension on checkup and she was started on medications for the same. She is compliant to treatment since then and she is on regular follow-up with physician. There is no history of chest pain, ghabrahat, palpitations, or breathlessness. No history of weakness or paralysis of extremities or sudden episodes of loss of no history of vision abnormality, no history of hematuria, recurrent UTI, or decreased urine output, no history of pedal edema or puffiness in face, no history of bleeding from nose or undue anxiety, no history of weight gain or weight loss, no history of previous hospital admission or any other chronic medical illness like diabetes, asthma, tuberculosis, or thyroid disorder, and no history of any drug illness.
So these history you have asked to rule out the secondary causes of hypertension?
Yes, ma'am, to rule out the secondary causes of hypertension as well as end organ damage due to hypertension.
What are the end organ damage?
Ma'am, it can affect cardiovascular system. It can result in left ventricular hypertrophy and arrhythmias, myocardial infarction, angina, and congestive heart failure. And it can also affect central nervous system, resulting in transient ischemic attack or hypertensive encephalopathy or stroke. And it can also affect kidney, resulting in nephropathy and end-stage renal disorders. And it can also result in hypertensive retinopathy.
And in eye, retinopathy.
Yes, ma'am.
Yeah, proceed.
Treatment history. My patient is on treatment for hypertension from past 6 years. She's on tablet amlodipine 5 mg and tablet telmisartan 40 mg once daily. She is compliant to treatment. Drug and dosages were confirmed by seeing the prescription.
Achha, can you classify antihypertensive?
Yes, ma'am. Antihypertensive drugs can be antihypertensive drugs belong to different classes. For example, diuretics. Diuretics will include thiazide diuretics, loop diuretics.
No. You start from the first line of
Now,
drug.
first line drugs include angiotensin converting enzyme inhibitors and angiotensin receptor blockers and calcium channel blockers and diuretics. And then beta blockers are added as second line drugs. And there are other drugs like alpha 1 blockers and alpha 2 agonists and potassium channel openers like hydralazine.
So these drugs belong to amlodipine belongs to which group
Ma'am,
of drugs?
amlodipine belongs to calcium channel blocker. Amlodipine is a calcium channel blocker.
And tell me certain.
Ma'am, it is an angiotensin receptor blocker.
Okay. Can you tell me the onset of action of amlodipine, the tablet oral?
Ma'am, it takes around 4 to 6 hours. The onset of action for amlodipine is 4 to 6 hours.
And duration of action?
Ma'am, 24 to 72 hours.
Yes. And what would the tell me certain?
Ma'am,
What
the
is the duration of action of
Ma'am, duration of action for telmisartan is 24 hours and onset of action is 2 to 3 hours.
Yes. So your patient is compliant to treatment?
Yes, ma'am.
Okay, next.
Personally, my patient is housewife by occupation. She is a vegetarian by diet, non-smoker, non-alcoholic, and bowel and bladder habits are normal. Family history, my patient has been married for 22 years with one child. Her father has a history of hypertension, no history of breast cancer in any family member, and no history of any other known comorbidities in the family. Menstrual history, my patient attained menarche at the age of 12 years. The cycles were regular, normal flow lasting for 3 to 4 days, and patient attained menopause 2 years back. There is no history of hormone replacement therapy. On general physical examination, my patient is
On the basis of history, what is your provisional diagnosis?
my patient, 48-year-old female, a known case of hypertension, diagnosed 6 years back, presented in OPD with a complaint of lump in left breast.
Acha, now we discuss about the hypertension. Classify or define hypertension.
Ma'am, according to American College of Cardiology or American Heart Association 2017 guidelines, hypertension is defined as systolic blood pressure more than 130 millimeter of mercury.
No, first you tell me the normal blood pressure range.
Ma'am, normal blood pressure according to ACC AHA guidelines is less than 120 mmHg systolic blood pressure and less than 80 mmHg diastolic blood pressure.
What would the mean arterial pressure? Normal mean arterial pressure.
Ma'am, normal mean arterial pressure is 65 less than 65 mmHg.
Normally we take 60 to 80 or some books say it is 80 to 100 millimeter of mercury. What about pulse pressure?
Ma'am, pulse pressure is around 40 to 50 mmHg.
40 to
50.
around 40.
Yes.
If it is more than 50, then it indicates there's something wrong with the heart.
Yes.
Right? Now you classify.
Ma'am, according to ACC AHA 2017 guidelines, hypertension is classified as normal blood pressure of less than 120 millimeter of mercury and diastolic blood pressure of less than 80 millimeter of mercury. Then elevated blood pressure is systolic blood pressure of 120 to 129 millimeter of mercury and diastolic blood pressure less than 80 millimeter of mercury. Stage 1 hypertension is systolic blood pressure of 130 to 139 millimeter of mercury and diastolic blood pressure 80 to 89 millimeter of mercury. And then stage 2 hypertension is systolic more than 140 or equal to or more than 140 millimeter of mercury and diastolic blood pressure more than or equal to 90 millimeter of mercury. And ma'am, then we can further classify hypertension as hypertensive crisis when the blood pressure is more than 180 by 20 millimeter of mercury. And if there are end organ damage present, then it is defined as hypertensive emergency. And if no end organ damage is present, then it is hypertensive urgency.
Right. So in stage 2, we can also subclassify hypertension as mild hypertension, moderate hypertension, and severe hypertension. The severe hypertension is when the blood pressure is more than or equal to 180 and the diastolic is 120. Equal and more than 120.
Yes.
Right?
Yes.
Okay. What are the precipitating factor, risk factor for hypertension? Be
Ma'am,
slow and clear.
ma'am, there are various risk factors like sedentary lifestyle,
सबसे
obesity.
पहले you are going to discuss about the age.
Yes, ma'am. It is hypertension. The incidence of hypertension increases with age, and
Yes.
it is more common in males, and however, it is also common in postmenopausal females. And smoking and sedentary lifestyle are also risk factors. Alcohol consumption and obesity, obstructive sleep apnea, these are risk factors pertaining to hypertension.
What is the other classification of hypertension?
Ma'am, we can classify hypertension according to JNC classification, Joint National Committee classification, also as a norm of less than 120 millimeter mercury and diastolic blood pressure of less than 80 millimeter of mercury. And then pre-hypertensive stage as blood pressure of 120 to 139 millimeter of mercury and diastolic blood pressure of 80 to 89 millimeter of mercury. And hypertension stage 1, blood pressure is between 140 to 159 millimeter of mercury and diastolic is 90 to 99 millimeter of mercury. And stage 2 is blood pressure more than 160 and diastolic more than 100 millimeter of mercury.
And there is the isolated systolic hypertension also.
Yes, ma'am. Isolated systolic.
What is isolated systolic hypertension?
Ma'am, when the systolic blood pressure is more than 130 millimeter of mercury, but diastolic blood pressure is normal.
So where you see is isolated systolic hypertension.
Ma'am, it is more common in older individuals, aged more than 60 years, and it is a major risk factor for cardiovascular disorders in that age group.
And it is commonly seen in thyrotoxic constipation where there is a hyperdynamic circulation.
Yes, ma'am.
Right? The other classification of hypertension, the cause, according to the cause, essential and
secondary hypertension, ma'am. Primary
yes. What is
hypertension
essential hypertension?
Ma'am, essential hypertension is primary hypertension where there is no etiology, there is no clear etiology for essential hypertension, and the pathophysiology of essential hypertension is there is increased sympathetic system activity, increased systemic vascular resistance. There is dysregulation of renin-angiotensin aldosterone system activity. There is dysregulation of
what is the function of aldosterone?
Ma'am, aldosterone is responsible for sodium and water reabsorption. So increased activity will result in increased sodium and water reabsorption, which can also result in hypertension.
So it will increase the volume, ECF volume, right?
Yes,
so
ma'am.
increases the cardiac output.
Yes, ma'am.
And the cardiac output is one of the factors responsible for hypertension. See, there are two factors, the cardiac output and systemic vascular resistance. If both are increased, responsible. If one is increased, one is constant, then again it is responsible for hypertension, right?
Yes, ma'am.
What are the secondary causes?
Ma'am, secondary causes can be renal causes like glomerulonephritis, pyelonephritis, or polycystic kidney disorders, or renovascular stenosis, or renin secreting tumors. It can be endocrine causes like thyroid disorder.
What is the common cancer you see in renal disease? Renal cell carcinoma, again responsible for hypertension. Renal artery stenosis. What are the endocrine causes?
Ma'am, it can be due to thyroid disorders. It can be due to pheochromocytoma or Conn syndrome or primary hyperaldosteronism or congenital adrenal hyperplasia.
Yes. What are the other causes?
And ma'am, it can be due to CNS causes like psychogenic hypertension.
CVS? What about the CA, coarctation of aorta?
Yes, ma'am. It can also be cause of secondary
Yes.
hypertension.
What else?
Ma'am, it can be due to obstructive sleep apnea or obesity. It can be due to smoking, alcohol.
Yes. The hypertension may be associated, may or may not be, right?
Yes,
it's
ma'am.
not an essential feature of obesity, right?
Yes, ma'am.
Acha, you have said your patient presented with history of lump. Is there any features? What are the features? There is a malignancy in the malignant feature of this lump. What are the features for malignancy?
Ma'am, it was a painless lump and it was a fast-growing tumor, and it was
Okay,
associated.
number one is growth.
Yes, ma'am.
Number two,
Ma'am, it was painless.
number three,
Ma'am, it was associated with nipple retraction and skin changes,
what about the size of the lump?
like dimpling and puckering of. Ma'am, it has increased
Is there any
in
fixity? Is there any fixity to the skin?
Yes, ma'am. Yes, ma'am. There is fixity to the skin and chest wall.
Okay, okay. So these are features suggestive of malignancy, right?
Yes, ma'am.
Now you proceed.
Ma'am, general physical examination. My patient is conscious,
How you
oriented to.
treat? See. Before we proceed, how you treat hypertension?
Ma'am, if the blood, according to ACC AHA guidelines, if the blood pressure is 130, if the blood pressure is more than 130 by 90 millimeter of mercury, but there are no.
Before no. Before pharmacological therapy, we
Yes.
advise modify your lifestyle.
Yes, ma'am. Yes, ma'am.
Right? Do
Yes, ma'am.
proper exercise.
Yes, ma'am.
Right? Salt restricted diet.
Dash therapy, dash time. Ma'am.
Yes. Then comes the role of pharmacological agents.
Yes, ma'am.
Right? For say mild hypertension, we only advise this salt restricted and modify lifestyle. And stage 2,
Yes, ma'am.
we advise pharmacological treatment.
Yes, ma'am.
Right?
Yes, ma'am.
Next.
On general physical examination, my patient is conscious, oriented to time, place, and person. Weight of patient is 75 kg. Height is 156 centimeter, making BMI 81 kg per meter square. There is no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema, and patient is afebrile to touch. Vitals, pulse rate is 78 beats per minute, regular in rhythm, good in volume, normal character, no radioradial or no radiofemoral delay, and all peripheral pulses are palpable. Blood pressure is 134 by 76 millimeter of mercury, measured in right upper arm in sitting position. Jugular venous pressure is not raised, and respiratory rate is 4 per minute, regular, and abdominothoracic. Airway assessment, there is no gross facial deformity. Bilateral nares were equally patent, no deviated nasal septum, good oral hygiene, mouth opening more than 3 fingers, no loose, artificial or buck teeth, and modified Malampatti class 2, and neck range of movements were normal. The sternohyoid and sternomental distances were normal. Local examination, after taking consent and ensuring adequate privacy, the patient was examined after exposing till waist, and it was done in sitting position. So the left nipple appears little lower.
You just tell me the positive findings. Tell me the positive finding in local examination.
Ma'am, upon inspection, mass was seen in the right upper outer quadrant of the left breast. Retraction of nipple was present. Dimpling and puckering of skin was present. And on palpation also, ill-defined lump of size 6 into 5 centimeter was felt in upper outer quadrant. And lump
So
was hard.
it's a large lump with retraction of nipple and with puckering of skin. So there is no lymph node palpable in the axilla, right?
Yes, ma'am.
Now you move forward.
Systemic examination, cardiovascular system. On inspection, chest wall was bilateral, symmetrical in shape, no visible swelling, scar, pulsation, or sinus. On palpation, inspectory findings were confirmed. Apex beat felt at left fifth intercostal space, half centimeter medial to mid-clavicular line.
Is
No
there any
swell or
positive
parasternal
finding?
lead.
Is there any positive finding in your CPS?
No, ma'am.
No, I think we can skip.
Yes, ma'am.
What about the respiratory system?
Ma'am, no positive finding.
No positive findings?
Yes, ma'am.
So after your clinical examination, the diagnosis is same?
Yes, ma'am.
It is
48-year-old female, non-hypertensive, on regular treatment for 6 years, presented with lump in left breast.
So how will you investigate and why?
Ma'am, I will order a complete blood count involving hemoglobin, platelet, and total leukocyte to know the baseline value of hemoglobin and to know.
You move to the investigation part.
Then I will order serum urea, creatinine, sodium and potassium.
Why you need
serum
why you
electrolytes.
need serum urea and creatinine in this case?
Ma'am, because hypertension can result in nephropathy and our patient is a hypertensive for 6 years. So to rule out any kidney involvement or kidney cause of hypertension, we require urea and creatinine.
So how you define chronic hypertension?
Ma'am, if hypertension is present for more than 3 months, then it is defined as chronic hypertension.
Okay. Why sodium and potassium?
Ma'am, to know the baseline value of serum electrolytes and
Because your patient is on telmisartan,
yes, ma'am.
right?
Yes, ma'am.
Your patient is on telmisartan. If say patient is eating regular diet and he doesn't have any history of say dyspnea, breathlessness, only hypertension, there's no need. But because of this drug, it can cause alteration in this serum electrolytes.
Yes, ma'am.
Right.
Ma'am, then LFTs, total bilirubin, direct and indirect bilirubin, AST, ALT, and then total protein and PTR.
Was your patient is your patient is on chemotherapy?
Yes, ma'am. My patient is receiving adriamycin, and my patient had a history of chemotherapy. She received adriamycin and cyclophosphamide.
What is cyclophosphamide? What are the side effects of cyclophosphamide?
Ma'am, cyclophosphamide can result in pulmonary fibrosis, pericardial effusion, pericarditis, and it can result in encephalopathy.
Cyclophosphamide.
Yes.
Cyclophosphamide causes the hair loss.
Yes, ma'am.
It has some cardiac toxic effects also.
Yes, ma'am.
Right? Adriamycin are also supposed to be cardiotoxic.
Yes.
Right?
Yes, ma'am.
And sometimes they are all metabolized inside the liver. So LFTs are important.
Yes.
And platelet count.
Yes. Yes.
Very important. Previously, they were using methotrexate. Now, the methotrexate they are not using. These are the new drugs: doxorubicin, adriamycin, vincristine, and cyclophosphamide.
Yes, ma'am.
Now, what are the specific investigation you are going to ask? Other investigation beside blood.
Ma'am, I will ask for a chest X-ray and electrocardiogram. In chest X-ray, due to hypertension, there can be changes like prominent aortic knuckle or left ventricular hypertrophy. And in ECG, I will see for any axis deviation or any sign of left ventricular hypertrophy or any ST or T segment changes.
What changes you expect in ECG in hypertension?
Ma'am, there can be left axis deviation, left ventricular hypertrophy, and if it is associated with angina or myocardial infarction, there can be ST or T segment changes.
And what changes you expect in echo? 2D echo?
Ma'am, left ventricular hypertrophy, or there can be diastolic dysfunction. There can be reduction in case of heart failure patients.
Yes. So these are the investigation you are going to ask, and it is a confirmed case of malignancy, right? By the surgeon, the surgeon had told you. So,
yes,
what are your perioperative concern, anesthetic concerns? Advice you are pre-op advice.
Ma'am, preoperative optimization. I will ask this case to be taken as a first
pre-op
case.
advice, we will discuss the perioperative concern. What are your concerns, anesthetic concerns? Then you are going to give advice.
Ma'am, I want to prevent any hypertension or hypotension in the perioperative field because this can result in ischemic changes affecting cardiovascular system, neurological.
So there are three things: hypertension, hypotension, and tachycardia.
Yes, ma'am.
Right? Yes.
Yes, ma'am. It can because this can affect cardiovascular system. It can result in myocardial ischemia or it can result in cerebral hypoperfusion due to hypotension or cerebral hemorrhage and hypertensive encephalopathy or embolic stroke. And due to renal hypoperfusion, there is risk of renal failure. So, ma'am,
what is cerebral perfusion pressure?
Cerebral perfusion pressure is equal to mean
It is a
arterial pressure
pressure.
minus intracranial. It
It
is a
is a pressure
pressure.
which is responsible for blood flow through the lungs. Right?
Yes,
It is the mean arterial pressure minus the intracranial
Intracranial.
pressure is the cerebral perfusion pressure. What is the normal?
Ma'am, 32.
No, it is 60 to 80. If it is more,
ma'am.
it can result into cerebral edema. If it is less, then there will be ischemia. The if mean arterial pressure is affected, the cerebral perfusion pressure is also affected. Right?
Yes, ma'am.
So you have to be very careful about the blood pressure intra. You want to avoid hypotension as well as the hypertension.
Yes, ma'am.
Okay? If hyperperfusion, then ischemia. If hyper, then again,
Yes,
it will compromise the,
ma'am.
it will disturb the autoregulation, cerebral autoregulation.
Yes, ma'am.
So what is the pre-op advice?
Ma'am, my pre-op advice would be to, I will ask the surgeon to take this case as first case in the OT and go for
Yes.
liquids and written informed consent, and I will advise to continue tablet amlodipine 5 milligram and telmisartan 40 milligram on the day of surgery, and tablet ranitidine 150 milligram one night before the surgery, and tablet alprazolam 0.5 milligram one night before the surgery. And I will ask for blood group and cross methanol.
Yes. So you have taken patient inside the OT and you have certain aims to avoid hypertension crisis, hypotension, and tachycardia. What are the intra causes of tachycardia?
Ma'am, intra-causes of tachycardia, it can be due to surgical or anesthetic stimulus. It can be during laryngoscopy and intubation. It can be due to endobronchial intubation of the tube. It can be due to pain, like pain of anesthesia due to surgical stimulation. It can be due to inadequate ventilation, hypothermia, full bladder, and due to during reversal and recovery.
And what are the parameters you are going to monitor? Intra? You move on your slide, no? You move your
Ma'am, I
slide
will ask. Ma'am, target range for BP control. So the intraoperative BP control will depend upon the preoperative BP of the patient, and it has to be maintained within 20% of the preoperative values. And when
yes,
so if we want to delay the surgery or at what BP
when
we
you
have,
cancel your case, when you cancel, postpone the surgery.
If the blood pressure is more than 180 by 110 millimeter of mercury, and if there are signs of end organ damage, then only we can consider to cancel the patient.
So it is the stage 2 will target organ damage, right? And if the blood pressure is more than 180 and diastolic more than 120, right? So patient need to be investigated and require proper treatment. Yes. Read out.
Elevated blood pressure is typically not a reason to delay surgery in asymptomatic patients who have no other significant cardiovascular risk factor. Most elective procedures can proceed safely unless the patient has severe hypertension, which is systolic blood pressure of more than 180 and diastolic blood pressure of more than 110. Or there is an evidence of end organ damage like myocardial ischemia, stroke, or renal injury that can be improved with preoperative optimization. And single BP readings are not sufficient for assessing long-term blood control.
I think we have discussed this. Next.
Ma'am, intraoperative monitors, all the ASS standard monitors have to be applied, like 5-lead ECG, non-invasive blood pressure monitoring, pulse oximetry, temperature, and ETCO2 monitoring. And as our case is posted for MRN, it can take up to 2 to 2.5 hours. So I will also ask for Foley's catheterization to measure urine.
So there's a possibility of hypoperfusion or hypotension. So Foley's is required. What is the normal output you maintain intra?
Ma'am, around 0.5 to 1 milliliter per kg per hour.
See, if the surgeon, they want to use the, say, vasopressor for infiltration, what will you advise?
Ma'am, I will advise.
What is the dose of
adrenaline,
adrenaline they should use? Huh?
Ma'am, 10 to 20 mics per kg, around in 1:2 lakh concentration.
Yes. Yes. Next.
Ma'am, induction of anesthesia, our aim is to avoid hypotension, and tachycardia. There can be a fall in BP during induction, which is followed by pressure response.
Acha. Before say induction, what are the induction agents you are going to use in this case?
I will go with propofol, but we can also go with etomidate or thiopental. But we will avoid ketamine.
Which one is better? Which one is better among three?
Ma'am, etomidate is better because it does not change hemodynamics much.
Yes, but with propofol and thiopentol, you should be careful about the hypertension they tend to cause because your patient is already on telmisartan, right?
Yes,
Telmisartan tend to cause hypertension, which is difficult to treat. So that's why the timing of the telmisartan is usually in evening hours, right? Not on morning hours, right?
Yes. So there can be a fall in
So
blood.
what are the, say if there's a serious response to laryngoscopy and endotracheal intubation, what are the methods, pharmacological methods you used to attenuate those responses?
We can smooth laryngoscopy with a duration of less than 15 seconds. And I will, we can,
duration, yes, next.
and ma'am, we can also give certain agents like we can go with beta blocker, esmolol, 0.25
First is
to 0.5
Jalocard, which
mg
is
per
easily
kg.
available. Because your patient
Yes,
is
ma'am,
already on
1.5.
antihypertensive, don't use other antihypertensive, right? So you have
Yes, ma'am.
Jalocard. The dose is up to 2 milligram per kg of body weight. You can use fentanyl also.
Yes, ma'am.
2 max जो तुम use करते हो and deeper plane of anesthesia.
Yes.
Other drugs are beta blockers like
Esmolol, ma'am, 0.5 mg per kg, 2 minutes before the induction, or labetalol, ma'am, 0.15 to 0.45 mg per kg, 2 minutes before induction. And we can also use 1 mg IV 2 minutes before induction.
So you have to maintain the proper depth of
Anesthesia.
anesthesia, right? Yes. So you are using midazolam also as a pre-treatment on table. What is the role of midazolam?
Ma'am, it will act as an anxiolytic. It will also help in amnesia, ma'am.
Amnesia, antegrade amnesia, right? What type of ventilation? It is a controlled or spontaneous ventilation? Anesthesia.
I will prefer controlled ventilation, ma'am.
Why not spontaneous?
Ma'am, because it can result in increased sympathetic activity. Inadequate ventilation can result in increased sympathetic activity.
Because the spontaneous ventilation has a tendency for hypoventilation, right? And it is a long surgery. So the controlled ventilation is required, right?
Yes. Yes.
Okay. What about the fluid?
Ma'am, I will
IV fluid.
Ma'am, I will prefer co-loading or preloading this patient before induction to avoid BP fluctuations. And then
see, your patient is already very well controlled with 130 by 80 blood pressure. 130, 80 by blood pressure. There is no need for preloading. Why you want to see in these type of patients? Treat like a ASA grade 2. Your patient is ASA grade 2 without any organ damage, right?
Yes, ma'am.
It is.
Yes, ma'am.
Patient is well controlled.
Yes, ma'am.
So there is no need for preloading. Why you want to preload? Depending on the loss, you replace the fluid. If say there is a blood loss, replace with blood. What about the post-op advice?
Ma'am, in the post-op, I will.
What about before post-op advice?
Extubation.
Extubation. Tell me something about extubation also. Before
Yes,
extubation, what for post-op pain relief? What you are going to
Ma'am, we will prefer multimodal analgesia in this patient, like
Yes.
NSAID, IV PCM, IV tramadol, and local infiltration of local anesthetic with the suture site, or we can also go with blocks. Now blocks like pectoralis now block 1 and 2, serratus anterior plain block.
What is one? What is one?
Ma'am, in
Pax one?
Ma'am, in pectoralis now block 1, we deposit the drug between pectoralis major and pectoralis minor muscle, and we
Yes.
block medial and lateral pectoral now. In
Yes.
pectoralis now block 2, we deposit the drug between pectoralis medial and serratus anterior muscle, and we block medial and lateral pectoral now, and then the lateral cutaneous branches also. And then in serratus anterior plain block, we are depositing the drug between serratus anterior muscle and latissimus dorsi muscle. And in this, we are blocking medial lateral pectoral nerve, thoracodorsal nerve, long thoracic nerve, and lateral cutaneous branches, T2 to T9.
Okay. What are the other blocks you prefer?
We
Required,
can
advocated.
ma'am, intercostal nerve block or paravertebral nerve blocks, erector spinal nerve blocks.
Yes. So they decrease the opioid demand, right?
Yes.
So
Yes.
when will you allow the patient to have oral intake?
Ma'am, around 24 hours post-operative.
Yes. Yes. Okay. And monitor all the vitals post-operatively.
Yes, ma'am.
Right?
Yes,
So
ma'am.
this is the post-op pain.
Yes, ma'am.
I think we have discussed everything. Now I think Shireen will tell something about the hypertension and pathophysiology of hypertension. Dr. Shireen.
Good morning, ma'am.
Good morning. We have already discussed, yes.
Good morning, everyone. My name is Dr. Shri, and I will be presenting a brief overview of a hypertensive for modified radical mastectomy. So to begin with, audio.
It is audible.
Yes. So to begin with, a patient is classified as hypertensive when there is a consistent systolic BP reading of more than 140 millimeters of mercury and or a diastolic BP of more than 90 millimeters of mercury. 90 millimeters of mercury on an average of 2 or more readings on 2 or more occasions.
Next.
Hypertension is broadly two types, essential or primary hypertension, which is more commonly seen and it does not have an underlying etiology. Key contributing factors the sympathetic nervous system altered activity, dysregulation of the renin-angiotensin aldosterone system, and deficient production of endogenous vasodilators. Secondary hypertension occurs as a result of an underlying cause, most commonly renal causes such as acute and chronic glomerulonephritis, pyelonephritis, polycystic kidney disease, renal artery, and endocrine such as hyperthyroidism, chromocytoma, hyperaldosteronism, coarctation of aorta, and pregnancy hypertension.
So these are endocrine.
Yes, ma'am. So, according to the Joint National Committee and the American Heart Association, hypertension is classified as mentioned on the slide. We've already discussed this. So, moving on to the European Society of Hypertension, grade 3 hypertension, which is severe hypertension with a systolic BP of more than 180 millimeters of mercury and a diastolic BP of more than 110 millimeters of mercury, is usually when we prefer to defer a case for a further optimization of the blood pressure, or if the patient also has end organ damage. So a patient with a blood pressure of more than 180 by 110 millimeters of mercury is said to either have hypertensive urgency, where the patient does not have any evidence of end organ damage, or hypertensive emergency, where the patient may have new or progressive end organ damage.
Kiran, what is RCRI classification? The risk.
Ma'am, it's a classification used to for risk stratification of these diabetes patient. It's a 6. It's scored up to 6. Ma'am, it contains patients with diabetes mellitus on insulin. Then CKD with creatinine more than 2. And if the patient is undergoing any invasive abdominal surgery, and if the patient has a history of cerebrovascular
CAD?
accident, CAD.
And CAD.
And CAD. Yes, ma'am.
Right.
Ma'am, the discussion on hypertension is incomplete without mentioning gestational hypertension, which refers to a systolic BP of more than equal to 140 millimeters of mercury and a diastolic BP of more than equal to 90 millimeters of mercury, which both that develops after 20 weeks period of gestation. It usually resolves within 12 weeks postpartum, and no proteinuria or systemic findings are present. Coming to the predisposing factors, older age group, as we know, older individuals are prone to atherosclerosis, which is the
I think we have
commonest cause of.
discussed. You move forward. You move forward. We have discussed the predisposing factors.
Yes, ma'am. So, ma'am, coming to the pathophysiology of hypertension, there are mainly two mechanisms that govern BP control. The faster acting system includes the baroreceptors that are present in the carotid sinus and the aortic arch, which sense arteries stretch and relay signals to the nucleus tractus solitarius, which further triggers inhibition of the sympathetic outflow, thereby lowering the BP. And chemoreceptors located in the carotid and aortic bodies detect hypoxia, hypercapnia, and acidosis, and they trigger the sympathetic nervous system. The slower acting system is hormonally mediated. Hormonal systems manage longer term BP via volume regulation and vascular tone. Epinephrine and norepinephrine released from the adrenal medulla enhance heart rate and contractility, and also constrict systemic arterioles, thereby increasing cardiac output. The other major hormone system involved is the renin-angiotensin-aldosterone system. So, according to this hydraulic equation, blood pressure depends directly upon the cardiac output and peripheral vascular resistance. Physiologically, cardiac output and peripheral vascular resistance are maintained minute to minute by the three sites that are resistance arterioles, capacitance venules, and the fourth set is intravascular fluid, thereby also affecting the blood pressure. Coming to the renin-angiotensin-aldosterone system, it is triggered by low renal perfusion and low sodium delivery to the macula densa cells. Renin released from the juxtaglomerulus cells convert angiotensinogen produced in the liver to angiotensin 1. Angiotensin 1 is then converted to angiotensin 2 by the angiotensin converting enzyme produced by the lungs. Angiotensin 2 so formed is a potent vasoconstrictor which directly increases peripheral resistance, stimulates aldosterone secretion, and promotes ADH release and thirst. And ma'am, aldosterone also promotes renal sodium and water retention, which also increases the extravascular volume. and causes an increase in cardiac output and blood pressure. As the target organ damage. Most commonly affected organs include the heart, brain, kidney, and eyes. Cerebrovascular damage includes or hemorrhagic and small vessel disease, which leads to lateral infarcts and white lesions, which to cognitive decline and dementia. Cardiovascular damage includes left ventricular hypertrophy, ischemic heart disease, secondary coronary atherosclerosis, and heart failure due to chronic high BP, which stresses the myocardium, impairing the systolic as well as diastolic function. Renal damage in hypertension causes arteriolar, hyaline, and intimal thickening, which leads to ischemia, which can then lead to a reduction in the glomerular filtration rate, causing chronic kidney disease as well as end-stage renal. And in the ophthalmological manifestations, there is arteriolar narrowing, retinal exudates, hemorrhages, and in malignant stages, there may be papilledema. So for chronic intensive patient who comes for surgery, causes or any organ damage. To rule out causes, check for edema and hematuria. A complete kidney function test is done to check for and creatinine. And for suspected renovascular causes, we look for a renal bruit, and investigations include ultrasound and
Dr. Shirin, have you finished? Dr. Shirin. Have you finished, Dr. Shirin?
No, ma'am.
Have you finished?
No, ma'am. Ma'am, so with few
See, we have discussed all this. You can move forward.
Yes.
Yes. Again, move forward. So we have already
Ma'am,
discussed
pharmacological
something.
management.
Yes, yes.
Ma'am, coming to the pharmacological management hypertension, we know blood pressure is a product of cardiac output and peripheral vascular resistance. Centrally acting agents act on the heart via the central nervous system by causing sympatholysis and therefore reducing contractility and heart rate. Beta blockers act directly on the and cause a reduction in cardiac output and also have an effect on the renin-angiotensin-aldosterone system, causing arterial and venous vasodilation. Diuretics act at the kidney and affect the salt water balance. They reduce the preload, thereby reducing the cardiac output. ACE inhibitors and ARBs act on the renin-angiotensin-aldosterone system, causing a decrease in preload as well as arterial and venous vasodilation. Calcium channel blockers act on the heart as well as vascular smooth muscles to reduce the blood pressure. These are some names of the antihypertensive drugs that we commonly
So you can
use.
move. You can move. Shri, you can move.
Yes, ma'am.
Yeah. We have already discussed this. You show me the slide.
Yes, ma'am.
We have already discussed.
Yes, ma'am.
Yeah, we have discussed. I think over to Tishri. We have discussed this all. Right? This is the theory part we have discussed already with Dr. Nimit.
Yes, ma'am.
So, ma'am, we don't have any questions in the chat box.
Okay.
Yes, ma'am. And but as far as this topic of chronic hypertension, anesthetic management of chronic hypertension is concerned,
It is a very common. It is a very common and important topic for
Yes.
for all of us.
Yes, ma'am. Very, very important with seeing the widespread, I mean, the way it has become an epidemic. We commonly encounter patients with chronic hypertension. So it's very important to learn their management, not just from the point of view of Viva OC or our practical, but also from the point of view it's the day-to-day applicability in our OT settings. So thank you so
Yes.
much, ma'am, for such an elaborate elucidation of the topic. And I'm sure our students would have really gained a
It
lot
is a very
from
vast
it.
topic. It is
We're
a
still
very
waiting
vast
for
topic.
very vast topic,
Thank you,
definitely,
Doctor.
ma'am. I mean, the
Yeah.
more you get into it, you will realize it has a lot to its pathology. It has a lot of,
Yes.
in fact, pathophysiological implications, ma'am.
Yes. Yeah. 1
So,
hour is
any
less,
questions?
very
The
less
questions are
for this
welcome.
topic. Thank you. Thank you.
Thank you so much, ma'am.
Thank you, Dr. Itishet. Thank you.
Thank you. Thanks a lot, ma'am. It has been really, very grateful.
Okay.
I mean, we are very grateful for you to give your time and
Okay.
you to give those insights on the topic, ma'am.
Thank you, dear. Thanks.
So we will move ahead now with our next presentation. Mr. Sudhi, can you please display?
Asha.
Hello, Mr. Sudhi, can you please display the CV slide of Veena Chatrat, ma'am? So our next topic is a lecture on valvular heart disease. This is also again a very important topic from the point of view that now we are finding patients who have valvular heart disease, those who have this, they have the cardiac status of these patients is really very different from that of a normal patient. And now we often get them in our practice, considering the way our cardiac anesthesia as well as the cardiac surgery has evolved over the years. So I welcome Dr. Kirti Khetrapal ma'am, who will be speaking on this topic. And to moderate her, we have Veena Chatrat ma'am. Ma'am is professor and head in the Department of Anesthesiology and Critical Care, GMC, Amritsar. She has received ISIC listed in 2022. She has received state award from the CM Punjab for taking care of the COVID patients. She has been the president of North Zone ISA 2020 to 2021. She organized 18th North Zone ISACon 2020 and first Punjab ISACon 2018. She also organized seed workshop for Airway Management Foundation in 2017, and she has a total experience of 25 years. Her areas of interest are critical care and obstetric anesthesia. Over to you, ma'am. Welcoming you.
The important topic, Dr. Kirti Khetarpal will be delivering her talk on patient of valvular heart disease like mitral stenosis, mitral regurgitation, aortic stenosis, and aortic regurgitation, who will be presenting for the non-cardiac surgeries. Dr. Kirti Khetarpal, please deliver your lecture. She is professor in Department of Anesthesia and Critical Care at PGIMS Rohtak. She has 70 national and international publications. She has participated in various national and international conferences, and she has won Best Paper Award. Her areas of interest are acute and chronic pain management, ultrasound guided nerve blocks, airway management, and transplant anesthesia. Over to you, Dr. Kirti.
Thank you for the kind introduction. I have sent a recorded lecture, so I think will that be displayed?
Yes, ma'am. We are going to display that. Just a 2-minute glitch. We'll start. Yes, ma'am. It's there.
To all the viewers, my lecture is on valvular heart disease. Valvular heart disease constitutes a major cause of cardiovascular morbidity and mortality worldwide. Rheumatic heart disease is a dominant cause of VHD in the developing nations, while age-related degenerative valvular heart disease is common in developed nation. The valvular heart disease are classified on the basis of etiology into congenital valvular heart disease and acquired heart valve disease. The most common valvular lesion in clinical settings are the MS and the AS. Non-cardiac surgery risk stratification in VHD is done on the basis of estimating 30-day risk of cardiovascular death, myocardial infarction, and stroke after non-cardiac surgery. They are divided into low-risk non-cardiac surgery and elevated risk non-cardiac surgery. If you go to see low-risk non-cardiac surgery include surgeries with less extensive dissection and no major fluid shifts, while elevated risk non-cardiac surgery include those surgery with extensive tissue dissection and major fluid shifts. Coming on to the generalized approach, one must be thorough with the pathophysiology of each lesion to get a favorable clinical outcome. Perioperative assessment should include echocardiography and detailed assessment to know about the progress of the symptoms. Good perioperative optimization and monitoring help overcome hemodynamic disturbances which may occur during anesthesia and surgery. General principles for preoperative assessment include clinical and echocardiographic evaluation, non-invasive transthoracic echocardiography, four-dimensional CT to know about the valve morphology, hemodynamics, left ventricular hypertrophy, systolic and diastolic function of the left ventricle, and other valvular complications. Grading of severity of valvular lesions is done on the basis of echo findings. The characteristics of the valvular lesion, especially in mitral regurgitation, as being either primary or secondary, have to be evaluated. Recently diagnosed mild to moderate disease, it is recommended to repeat echocardiography to re-evaluate the progression of the disease if it is there. In severe VHD, we have to confirm whether the symptoms are due to valvular pathology or other cardiovascular disorder. Referral and discussion with the cardiologist, the surgical team, and in severe cases with the cardiovascular surgeon has to be done. Coming down to aortic stenosis, the most common cause of acquired aortic stenosis is idiopathic senile degeneration with sclerosis and calcification of the valve due to chronic inflammation. Coming down to signs and symptoms, the cardinal symptoms include exertional angina, exertional syncope, dyspnea, later on congestive cardiac failure ensues. A focused examination, a general physical examination, and targeted cardiovascular examination needs to be done. ECG will show left ventricular hypertrophy in more than 85% patients. X-ray shows prominent ascending aorta due to post-stenotic dilatation. Echocardiography not only tells us about the anatomy of the aortic valve, but helps in grading the stenosis severity and assess left ventricular function. When the aortic valve area is between 1 to 1.5 centimeters square, the disease is mild. Between 0.75 to 1, it is moderate, and less than 0.75 constitutes a severe disease. Echo finding in a severe calcific aortic valve shows a three-legged starfish appearance. Now, risk assessment. Mild to moderate aortic stenosis patient can undergo NCS regardless of their NCS risk profile, while asymptomatic severe AS patient undergoing high-risk surgery, you have to weigh the risk-benefit of getting an aortic valve intervention prior to non-cardiac surgery. In symptomatic severe AS, valve interventions are indicated depending upon the type of non-cardiac surgery risk and the time sensitivity of this surgery. Now, coming down to pathophysiology of aortic stenosis, it is a low cardiac output state and there is a chronic pressure overload over the left ventricle. Hemodynamically significant obstruction occurs as AVA approaches 1 centimeter square, the normal being 2.6 to 3.5 centimeters square in adults. The average survival after the onset of angina and syncope is 2 to 3 years. With the development of congestive cardiac failure, it is only 18 months. The initial pathology is left ventricular outflow tract obstruction and increase in the peak systolic wall stress of the left ventricle. This leads to concentric ventricular hypertrophy, diastolic dysfunction, and subendocardial ischemia. Further reduction in the valve area leads to ventricular wall stiffness, diastolic dysfunction. Left ventricular filling is dependent upon the aortic contraction as much as 40% as compared to 20% in the normal adults. Left atrial hypertrophy is left atrial hypertrophy starts and preservation of sinus rhythm from this point becomes important. Myocardial oxygen and demand and supply is disrupted, demand increases, supply decreases, hence chances of ischemia develop. Finally, what happens to the ventricle? It becomes very sensitive to the preload, sinus rhythm dependent, susceptible to ischemia, cardiac output, stroke volume, and pressure gradient across the valve decreases. Now, after understanding the pathophysiology, we should know what are the hemodynamic goals of such patients during surgery. We target at a slow normal heart rate for adequate diastolic filling and coronary perfusion. Sinus rhythm is targeted as the ventricle needs that atrial kick for ventricular filling. The preload has to be maintained for filling of that non-compliant ventricle. Afterload has to be maintained or increased. It is difficult for the left ventricle to compensate for decreased SVR. Hypotension is poorly tolerated. Myocardial contractility has to be maintained because it has to overcome the fixed cardiac output state as there is restriction of flow at the level of the aortic valve. The heart rate, we should know that both tachycardia and bradycardia are poorly tolerated. Beta blockers should be used with caution. Arrhythmias are poorly tolerated. Defibrillator and beta blockers should be ready. Avoid and treat atrial fibrillation and other supraventricular tachycardias. Now, neuraxial anesthesia in aortic stenotic patient. What are the risks? Loss of sympathetic tone decreases the SVR. Hypotension risk, since it is a fixed cardiac output state, the heart cannot compensate for the persistent hypotension. The balance between preload and afterload is disrupted, which is very much required in these patients. Risk of myocardial ischemia is there. If persistent hypotension is there, there is always a risk of bradycardia. Finally, reliable safety data are lacking. Mild aortic stenosis patient Even severe cases with stable hemodynamic and preserved left ventricular function can be given neuraxial anesthesia, avoided in patients with severe symptomatic AS. We avoid high doses and rapid onset like spinal anesthesia. Low and incremental epidural are recommended. However, we should maintain hemodynamic goals. Vasopressors should be ready. Advanced monitoring facilities should be there, and post-operative care should be given to these patients. Apart from what is already been mentioned, pre-operative evaluation should include evaluation of coexistent diseases like coronary artery disease and chronic kidney disease, monitoring, invasive arterial monitoring and CVP monitoring is required in severe cases. Otherwise, in mild to moderate cases, standard ASA monitors are sufficient. In severe cases with major non-cardiac surgery, transesophageal echocardiography helps to tell us about the left ventricular function. It is prudent to apply defibrillator pads in the preoperative period. Pre-medication should be adequate to prevent tachycardia, induction, stable hemodynamics, and good anesthetic depth should be targeted. Medications such as low-dose benzodiazepines, fentanyl, etomidate, sevoflurane are safe. Facilitation of tracheal intubation with vecuronium and rocuronium bromide is done. Avoid systemic hypotension. It should be treated aggressively with drugs initially, followed by the management of the underlying cause. Administer vasoconstrictors by infusion. Maintain sinus rhythm. Arrhythmias must be treated promptly. Sinus tachycardia is detrimental. Serum potassium levels should be maintained. Potential surgical causes of hemodynamic instability should be considered and modified wherever possible. Appropriate antibiotic prophylaxis should be given and strict aseptic precautions adhered to. Post-operative management should include keeping the patient in high dependency setting, aiming for excellent post-operative pain control, maintaining stable hemodynamics. We can use regional anesthetic techniques to provide post-operative analgesia. Non-steroidal anti-inflammatory agents should be avoided as there is a risk of post-operative renal dysfunction. Aortic regurgitation, blood flows back into the left ventricle during diastole. So it is a left ventricular volume overload is the pathognomic feature of aortic regurgitation. Chronic AR is more common than acute AR and has a better long-term outcome. Most common cause of chronic AR is idiopathic. Acute AR is tolerated poorly and can lead to acute left heart failure and pulmonary edema. Aortic regurgitation, the signs and symptoms are due to left heart failure of acute AR are dyspnea, hypotension, cardiogenic shock, and pulmonary edema. A detailed general physical and cardiovascular examination should be undertaken. ECG will show left ventricular hypertrophy. X-ray chest shows again features of left ventricular hypertrophy. Pulmonary congestion may have dilated ascending aorta. Echo helps in definition, defines the mechanism of AR, severity and its repercussion, regurgitant volumes, left ventricular dimension and function, aortic root assessment. Cardiac MRI is done in patients with aortic root dilatation. BNP is the marker of decompensation. Regarding calculating the severity of AR, the regurgitant volume, if less than 30% of the left ventricular stroke volume, it is a mild disease. 30 to 49%, it is a moderate disease. More than 50%, it is severe. This is the algorithm which tells us what should be taken first, whether aortic valve intervention should be done prior to non-cardiac surgery or not. In severe symptomatic patients, AVR should be undertaken before elective non-cardiac surgery. In severe asymptomatic AR, if the left ventricular end systolic diameter is more than 50 mm and left ventricular ejection fraction is less than 50%, then of course you have to undertake AVR prior to elective NCS. What are the hemodynamic consequences and pathology of AR? First, there is malcoaptation of the aortic valve leaflet due to chronic stress on the leaflet itself or the AV annulus or the aortic root or both. Progressive volume overloading occurs. Increase in the end diastolic wall tension occurs. Left ventricle undergoes remodeling with development of eccentric ventricular hypertrophy and chamber enlargement. Left ventricular and diastolic pressure initially is relatively normal because this volume increases very slowly. Eventually, left ventricular function will deteriorate, increase in left ventricular and diastolic pressure, which is transmitted back and increasing the left atrial pressure. Further, the pulmonary pressures also increase. In the end, symptoms of heart failure occurs. Looking at the pathophysiology, what are the hemodynamic goals during the perioperative period? We should target at a high normal heart rate to minimize the time spent in the diastole to reduce the regurgitant fraction. Sinus rhythm is always targeted. It is required that adequate volume loading be there so that the regurgitant fraction is less. Controlled reduction of SVR reduces the regurgitant volume. In cases of inotropes are needed, inodilators like milrinone and dobutamine are preferred. Maintain myocardial contractility and maintain adequate diastolic pressures. Mitral stenosis. In the developing countries, rheumatic heart disease constitutes the major cause of mitral stenosis. Progression of disease is usually around 0.1 to 0.3 centimeter square per year reduction in the mitral valve area. Symptoms like dyspnea, orthopnea, paroxysmal nocturnal dyspnea, repeated lower respiratory tract infection, and other symptoms suggestive of mitral stenosis should be elicited. A general and targeted cardiac examination to come to the diagnosis of mitral stenosis should be done. An X-ray will show left atrial enlargement, pulmonary venous congestion, valve calcification, elevation of left main bronchus, and displacement of the barium-filled esophagus on lateral film. Now, echo is helpful in confirming the diagnosis. You can find the thickened mitral valve, reduced mitral valve area, left ventricular dysfunction, leftward shift of the interventricular septum, subvalvular calcification, atrial fibrillation, and thrombus in the left atrium or left atrial appendage can be seen. Grading the severity, if the mitral valve area is between 1.6 to 2 centimeters square, it is a mild disease. If between 1.5 to 1 centimeter square, it is a moderate disease. Less than 1 centimeter square of the mitral valve area constitutes severe disease. Pathophysiology, mitral valve area of 1.5 to 2.5 centimeters square. Symptoms usually occur in association with exercise or other condition such as fever, pregnancy, or AF that lead to increase in heart rate and cardiac output. Mitral valve area less than 1.5 centimeters square. Symptoms develop at rest. Now coming down to the pathophysiology, a stenosed mitral valve causes a chronic decreased left ventricular filling. Initially, left ventricular contractility is not a problem, but slowly muscle atrophy and scarring of the left ventricular musculature occurs, leading to left ventricular end diastolic volume and pressure being reduced with a decline in stroke volume. Ultimately, the ejection fraction also reduces. The stenosis valve also causes increase in the left atrial pressure and left atrial dilatation, which leads to aortic fibrillation and formation of thrombus in the left atrium or the left atrial appendage, leading to thromboembolic complication. Increase in the pulmonary, venous, and arterial pressure causes reactive pulmonary vasoconstriction, elevated pulmonary pressure, right ventricular hypertrophy, right ventricular dilatation, and failure. Hemodynamic goals of mitral stenosis include low normal heart rate less than 70 is critical regardless of the rhythm to allow sufficient diastolic time for ventricular filling. Sinus rhythm should always be maintained. In fact, should be tried to maintain. Preload aim at normovolemia. Fluid bolus can worsen pulmonary edema. After load, cardiac output is fixed, so afterload maintenance is crucial. SVR reduction, there is decrease in coronary perfusion pressure. Pulmonary vascular pressures should be optimized by avoiding hypoxia, hypercapnia, and acidosis to prevent right ventricular decompensation. Nitrous should not be used. Myocardial contractility, left ventricular contractility is affected later. Right ventricle may need support if signs of failure are present. Inotropic supports with phosphodiesterase inhibitor or catecholamines may be required. Now, the suggested algorithm, whether the patient should undergo an NCS or a mitral valve intervention first, will depend upon whether the disease is mild, moderate, or severe. Anesthetic concerns in non-cardiac surgery. MS is initially generally well tolerated. Insidious signs need to be carefully sought. Treatment, patient may be on treatment for atrial fibrillation, dyspnea, and anticoagulants. Patient on warfarin needs to be converted to heparin before surgery. Digoxin should be continued preoperatively. Patients on anticoagulants may need a coagulation profile prior to the surgery. If warfarin is used for AF alone, a short period of no anticoagulation carries minimal risk. Oversedation in the preoperative period should be avoided to prevent hypoventilation and hypercarbia. Intraoperative monitoring, non-cardiac surgeries of short duration, standard ASA monitors are sufficient, but long surgery with anticipated large fluid shift and major tissue resection, invasive arterial monitoring, and CVP monitoring is essential. This helps in maintaining adequate preload, avoiding excessive fluid administration that aggravates pulmonary vascular congestion and pulmonary edema. Symptomatic patient with pulmonary hypertension may benefit from pulmonary artery catheter and transesophageal echocardiography. Important perioperative concerns, we have to focus on controlling heart rate and ventricular preload, managing right ventricular and left ventricular contractile function, managing coexistent pulmonary hypertension. General anesthesia is safe if carefully managed, is preferred for major surgery. Avoid agents that cause tachycardia or hypotension as they are poorly tolerated. Critical MS patients who have a low cardiac output, avoid increase in heart rate during induction of anesthesia and perioperative period. Blunt intubation responses, avoid ketamine as it causes tachycardia. Preferred agents includes Etomidate of fentanyl for induction, short-acting beta blockers can be used perioperatively. Elevated flow across the valve can occur during increased sympathetic activity from any stimulus and suddenly increase the pressure gradient across the valve. This may elevate LA pressure and consequently PA pressure, and pulmonary edema can be precipitated. If atrial fibrillation is there, try to maintain sinus rhythm. If atrial fibrillation precipitates during the surgery, it can be managed using digoxin, short-acting beta blockers, calcium channel blockers, and amiodarone. Cardioversion is preferred in hemodynamically unstable patients. Right ventricular dysfunction is a major concern in a patient with mitral stenosis. Inotropic support may be needed to augment right ventricular function. Fluid should be judiciously used because they can precipitate pulmonary edema. Nitrous oxide is avoided due to pulmonary hypertension. All measures that avoid increased pulmonary artery pressures should be taken, like hypoxia, hypercarbia, and acidosis. Neuraxial anesthesia, single shot spinal anesthesia has to be used with caution. Sudden sympathectomy can be dangerous. Epidural is preferred. Gradual titrated doses of local anesthetic avoid sudden hypotension. Cesarean delivery, again a major topic of discussion beyond the scope of this lecture. However, NYHA class 1-2 patient valve with valve area more than 1.5 centimeters square, gradient less than 5 mmHg, no pulmonary hypertension, spinal or graded epidural can be given. For more severe cases, GA is preferred. Post-operative management and complications should be intensely monitored and taken care of. Mitral regurgitation can be primary or secondary. Primary is due to the pathology of the valve preventing normal closure. Secondary is caused by LV dysfunction that affects the closing of mitral valve. It is known as the functional MR. This can be an acute or a chronic. Acute MR is precipitated by any disruption of the normal mechanism of the valve. The left atrium is unable to compensate acutely for increased pressure caused by blood refluxing back. As the pressure is transmitted back into the pulmonary circulation, patient present with sudden dyspnea and requires rapid stabilization and treatment. Chronic MR can be chronic primary or chronic secondary. Primary chronic is due to any abnormality of the leaflet that prevents them from closing. Secondary is due to the impairment of the left ventricle as by myocardial infarction or hypertrophic cardiomyopathy, and the anatomy of the valve in such cases is normal, hence it is known as the functional MR. Preoperative assessment, again, we have to focus on the history and clinical examination of this patient, the treatment they are on. In acute MR, the patients are on medication that reduce filling pressures. Afterload reduction on vasodilators are given or intra-aortic balloon pump is placed. Chronic MR, there are signs of heart failure. The treatment is in line with the standard heart failure management. Echo will assess the degree of regurgitation, LA enlargement, look for thrombus in LA, and evaluate associate pulmonary hypertension in advanced disease. Again, if the regurgitant fraction is less than 30%, it is mild MR. If it is 30 to 49%, it is moderate. Less than 50% regurgitant fraction across the mitral valve, it constitutes a severe MR. Coming down to pathophysiology, incompetent mitral valve, left ventricular function and pressure tend to be normal in the initial stages, but compensatory eccentric left ventricular hypertrophy and dilatation occurs to preserve the left ventricular systolic function, though EF may be normal or supranormal till the left ventricle is decompensated and hence heart failure symptoms appear. The back pressure increases the left atrial, causes left atrial dilatation. Left atrial pressures are preserved in the initial phases, but with progressive enlargement, atrial fibrillation can be there. Pulmonary vasculature pressure is preserved initially, but in the later stages, left atrial pressures increase and pulmonary vascular congestion, pulmonary hypertension, and right ventricular dysfunction ensues. What are the perioperative hemodynamic goals in the mitral regurgitation? Maintain a high to normal heart rate to minimize the time spent in diastole, hence decreasing the regurgitant fraction. Always target sinus rhythm. Mild preload augmentation and maintenance is useful to ensure forward stroke volume. Afterload naturally should be decreased so that it decreases the regurgitant volume and augments systemic perfusion. Like any other heart disease, heart valve disease, maintain the contractility. This is the suggested algorithm where the patient will require NCS first and mitral valve intervention first. Now, intraoperative monitoring, since this signs of left heart failure, aggressive use of inotropes may be needed. Patient tolerate both GA and neuraxial anesthetic techniques well. Avoid factors that increase pulmonary hypertension. Avoid bradycardia. If unstable patient, use opioid-based anesthetics. Inotropes may be required if there is hypotension. Invasive monitoring is required in patients with preoperative symptoms and impaired myocardial function. Monitor for CHF postoperatively, especially if large intraoperative fluid shifts have occurred. For antibiotic prophylaxis, patients with acquired valvular heart disease are at risk of developing infective endocarditis, but prophylaxis is no longer recommended in patients with mitral valve prolapse or other valvular diseases without previous history of infective endocarditis. However, aseptic precautions have to be strictly maintained. Now, general principles for postoperative care include risk stratification, cardiovascular management, anticoagulant management. Medication should be strictly given to the patient. Pulmonary care of the patient should be done. Early mobilization and DVT prophylaxis should be given. Monitor the patient for complication. All the investigations should be done and follow-up of the patient should be planned. These are general post-operative care for all valvular heart diseases. Last but not the least, the left ventricular volume loop. Now we are aware about the basic pathophysiology. So we have studied that aortic stenosis is a chronic pressure overload over the left ventricle. So you see the peaking pressures of the left ventricle in the mitral stenosis as compared to the normal left ventricular pressure volume loop. While regurgitant lesions are a volume overload, you see an increase in the end diastolic volume of the left ventricle as compared to the normal loop. Now we come down to the mitral valve disease. In mitral stenosis, when it becomes advanced, the left ventricle becomes atrophied and stiffened. So the loop of mitral stenosis is smaller, that is, volume is less, pressure is less when compared to the normal loop of the left ventricular pressure and volume. Again, in mitral regurgitation, you see the amount of volume and diastolic volume has increased as regurgitant lesions are a pressure overload on the left ventricle. This I have concised the hemodynamic goals. This one must understand the principle for stenotic lesions and regurgitant lesions is quite similar. A heart rate slow to normal is targeted in stenotic lesions, while high normal in regurgitant lesion. It is sinus rhythm maintenance is critical in stenotic lesions, while preferred in regurgitant lesions. Preload has to be maintained, or it has to be adequate or mildly increased in the regurgitant lesions as compared to the stenotic lesions where you have to maintain them. Afterload has to be maintained or increased in the stenotic lesions, while controlled decrease in the SVR has to be there in the regurgitant lesions. Myocardial contractility has to be maintained in every valvular heart disease, but it needs to be augmented in regurgitant lesion so as to decrease the regurgitant volume and promote forward flow. This is in the nutshell and a brief outline of valvular heart disease management for non-cardiac surgery. Thanks for your patience.
Thank you, Dr. Kirti, for the wonderful presentation. You have rightly said that a thorough understanding of the pathophysiology of the valvular heart disease is essential when we plan for the anesthesia and perioperative care for such patients. And meticulous use of optimal fluids, close monitoring of the changing hemodynamics during the intraoperative period, and avoidance of the situations that cause major reductions of the cardiac output and fluid shifts, they are mandatory to achieve the good clinical outcome. And it is advisable, like the patients with stenotic heart lesions, they are prone to go into the atrial fibrillation during the intraoperative and during the induction phase. So it is advisable to put the defibrillator pads in the preoperative area on the patient, so that in case if any unstable tachycardia or unstable atrial fibrillation develops, then that is immediately managed with synchronized cardioversion, or in case of shockable rhythm, they are immediately defibrillated so that untoward event is prevented in the intraoperative period. Once again, thank you, Dr. Kirti, for the wonderful presentation, and thanks to the Appec team for giving me this opportunity.
Thank you so much, ma'am. Thank you so much, Kirti ma'am. Thank you so much, Veena ma'am, for your valuable insights on this. I would say on this tectonic topic, I would say that is really very difficult to understand by most of the PGs, ma'am. Thank you, ma'am. Now I would invite Dr. Nandita Sharma, ma'am. She will be moderating the session on congenital heart disease. Ma'am is professor and head of anesthesiology at ASCOM's and hospital. She has Jammu, and she has a fellowship in Indian Academy of Pain Management. She is a fellowship in palliative care, and she is AHA instructor, BLS and ACLS. Her areas of interest are regional anesthesia, acute and chronic pain management, and palliative care. Welcome, ma'am. Ma'am, please kindly introduce our next speaker, ma'am. Thank you.
Good morning, everyone. Previous speaker has given a detailed discussion on the heart diseases and then management in non-cardiac surgery. Now, our present speaker, Dr. Poonam Matani, she's a professor of pediatric anesthesia at Postgraduate Institute of Child Health, Noida. And she's the principal, her achievements are principal PGICH Noida with effect from 2024. And she was the one who initiated pediatric anesthesia services in this institution since 2015. And she has held, and she was a national executive member for IAPA, that means Indian Association of Pediatric Anesthesiologists, and pediatric anesthesia observership she has done from London in September 2019. And major conferences organized by Dr. Poonam are the IAPA 2024, the RAPA Con 2017, and USG and blocks in October 2019. She has more than 40 publications and 12 chapters in books, and more than 115 lectures. She has delivered various talks, panel discussions, and chairperson. So, and her areas of interest are pediatric and neonatal anesthesia. So, over to Dr. Poonam Matani.
Thank you, ma'am. Thank you for that kind introduction. May I request the organizers to kindly share the recording? A very good afternoon, respected organizers, chairpersons, seniors, colleagues, and my dear students. This afternoon, I shall be talking about anesthetic management of children with congenital heart disease for non-cardiac surgery. So before we have a look at the pathophysiology, let's have a look at the data that we have. It'll just take a moment. Okay. So it has been seen that congenital heart disease affects 1 in 125 live births, making it one of the most common birth defects. In high-income countries, 90% of these children survive into adulthood, increasing the need for ongoing care. 30 to 41% of children with congenital heart disease require non-cardiac surgery by the age of 5. And the mortality risk for congenital heart disease patients undergoing non-cardiac surgery is 5 to 10 times higher than that of their healthy peers. So why are these cases such high risk? Children with congenital heart disease face unique physiological challenges that significantly increase their risk during non-cardiac surgery. And it is very important to understand these factors for the safe anesthetic management of these children. So in this study, which was conducted over a period of 17 years at a tertiary referral center in USA, and the results of which were published in the year 2007, they found that the incidence of perioperative cardiac arrest during non-cardiac procedures is 2.9 per 10,000 anesthetics. Of these, 7.5% are attributable to anesthesia. Most of these perioperative cardiac arrest patients had a congenital heart disease, and the majority of congenital heart disease patients were less than 2 years. So before we delve into the pathophysiology, let's just recapitulate the physiology of neonatal cardiovascular system, which provides a unique challenge. So oxygenated blood travels from the placenta through the umbilical vein to the portal vein, and majority of it passes through the ductus venosus into the inferior vena cava. Some blood passes from the umbilical vein into the portal vein through the liver, and then it enters the IVC. Now this blood, which enters the right atrium in a neonate, preferentially travels across the shunt to the left atrium, bypassing the lungs. And the blood which travels from the right atrium to the right ventricle also bypasses the lungs and travels to the systemic circulation through the patent ductus arteriosus. Now, whenever a child is born, the central shunts undergo closure, diverting the blood to the lungs, and persistent shunting through these shunts can lead to severe hypoxemia. Now, at birth, the pulmonary vascular resistance decreases significantly, and stressors like hypoxemia can delay this regression, increasing the mortality risk. Also, the neonatal myocardium has decreased compliance, making cardiac output highly dependent on the heart rate and the circulating volume. Further, because of organ immaturity of the liver and the kidneys, the drug metabolism and excretion is also affected, adding another dimension of complexity to the already complex anesthetic management. So at birth, 3 critical adaptations occur. The pulmonary blood flow increases dramatically, about 8 to 10 times that of the fetal blood flow. The central blood flow patterns are significantly altered due to abolition of the shunts, and from a parallel, we now switch over to a series circulation. And the combined ventricular output increases. This is in response to the increased energy demands due to the increased work of breathing and due to thermoregulation. So based on certain factors, the congenital heart disease are classified. So first classification is based on the absence or presence of cyanosis. Acyanotic lesions are primarily VSD, ASD, PDA, pulmonary stenosis, aortic stenosis, coarctation of aorta. And cyanotic diseases, cyanotic lesions are mainly TOF, TGA, tricuspid atresia, truncus arteriosus. Now, the second classification is on the basis of pulmonary or systemic flow into either excessive pulmonary blood flow, inadequate pulmonary blood flow, inadequate or obstruction to systemic blood flow, or abnormal mixing. So on the basis of presence or absence of cyanosis, congenital heart disease is classified into first category is the acyanotic congenital heart disease. Here the babies are pink and the primary lesion is there is a left to right shunt. This can be due to a restrictive lesion or due to an obstructive lesion. The most common causes of restrictive lesions are ASD, VSD, and PDA. Now, if the restrictive lesion is large, then they are associated with a severe congestive cardiac failure in infancy because of excessive blood flow from the left side of the heart to the right side. If unrepaired, this may eventually lead to pulmonary hypertension and reversal of shunt, which is known as Eisenmenger syndrome. Obstructive lesions, on the other hand, include aortic stenosis and coarctation of aorta. Here, the severity of the lesion determines the age at presentation. Neonates with severe obstruction may be critically ill with a duct-dependent circulation. Based on the same classification, the criteria of presence or absence of cyanosis, the other category is that of cyanotic lesion, wherein the babies are also termed as blue babies. This is mainly because of a right to left shunt. The common examples of this is tetralogy of Fallot, in which there is a VSD with an aortic override, there is a right ventricular outflow tract obstruction, and right ventricular hypertrophy. And this may present with severe cyanosis and hypercyanotic spells in children, or if unrepaired, there will be history of cyanosis, fatigue, and a history of squatting. The other lesions which are included in this category are transposition of great arteries, single ventricle physiology, and the common mixing. So coming on to the preoperative evaluation, it is very important to do a preoperative thorough assessment of these children. One must take a very good comprehensive patient history, which should include, but not limited to, taking a detailed birth history. One must evaluate for the maternal disease in the mother, any drug or alcohol intake during pregnancy, the birth weight of the child, the current weight, any history of prematurity, birth asphyxia, any history of NICU admission, and if yes, why, and the frequency of NICU admission. Current status must be evaluated. See if the patient is stable or unstable. Is the patient breathless? What is the exercise tolerance? Is there history of frequent respiratory infections? Is there history of central cyanosis, hypercyanotic spells, or history of squatting improving during a cyanotic spell? Then one must also evaluate for presence of any congenital anomalies, which can be craniofacial. It can be associated with complex congenital disorders such as Down syndrome, or any history of cardiac or non-cardiac surgeries performed after birth. One must also take a detailed history regarding the medications the patient is on, whether the patient is on diuretics, digoxin, propranolol, prostaglandins, inotropes. If yes, these have to be continued. This must be followed by a thorough physical examination, which should include but not limited to presence of look for features, dysmorphic features. There can be associated congenital anomalies like Down syndrome, cleft palate, whether there is any history of failure to thrive. There's a poor weight gain, as you can compare against the standard growth charts. Look for any signs of respiratory distress, as in dyspnea, tachypnea, intercostal subcostal recession, nasal flaring, grunting, etc. Any central cyanosis is present. Look for dependent peripheral edema. For the pulse, one must evaluate the rate, rhythm, volume, character, and also note for any radiofemoral delay. Look for any palpable thrills. Look for chest deformity and hepatomegaly as age appropriate, whether it indicates an increased right atrial pressure or heart failure. So a thorough history and examination must be followed by certain essential investigations, which include a complete blood count, renal function tests, liver function tests, arterial blood gases, particularly in ventilated neonates. A coagulation profile needs to be done, and a septic profile workup, especially if the child is sick, and baseline procalcitonin and blood culture may be required. Additionally, certain diagnostic investigations are required, including the chest X-ray, follow the ABCD approach, the ECG, the two-dimensional echocardiography, and the cardiac catheterization report must be looked at. So Preoperative assessment is the cornerstone of safety, and it guides the anesthetic planning and ensures patient safety. So based on this, patients can be grouped into three categories. Either the patient has never been operated, so it's a non-operated patient, or a patient has had a previous palliative surgery in the form of a BT shunt, or a previous corrective surgery. Now, based on the patient evaluation, these patients are then stratified into high risk, intermediate risk, or the low risk category. So this risk classification of children with congenital heart disease for non-cardiac surgery was given by White and Payton et al., and it was published in the year 2012. It categorizes patients based on certain criteria into high risk, intermediate risk, or low risk. So patients who are physiologically poorly compensated and or have presence of major complications such as cardiac failure, pulmonary hypertension, arrhythmias, and cyanosis, or those with complex lesions which include a single ventricle or balanced circulation physiology, cardiomyopathy, aortic stenosis, or those patients who are planned for major surgery like an intraperitoneal, intrathoracic surgery, or anticipated where anticipated blood loss would require transfusion, or a child under 2-year-old planned for emergency surgery with a pre-operative hospital stay more than 10 days belonging to ASA physical status 4 or 5. All these criteria would classify a patient into the high risk category. So based on these, let's have a look at the complexity of the heart lesions. One must tailor the anesthetic approach and predict the potential complications during non-cardiac surgery based on the complexity of these heart lesions. So either the patient can have a normal or a series circulation, cardiac circulation, which means that there are separate pulmonary and systemic blood flows which are similar to the healthy heart. Here, the anesthesia goals are to maintain stable hemodynamics and to avoid significant shifts in pressure or volume. Or the patient can have, the cardiovascular system of the patient can have a parallel or a balanced circulation, wherein there is mixture of oxygenated and deoxygenated blood, often due to presence of shunts. And a critical balance of pulmonary to systemic blood flow is required to prevent either heart failure or cyanosis. Third category is wherein the patient has a single ventricle circulation, whereas there is only one functional ventricle, and these patients have complex hemodynamics. So the goals are to maintain adequate systemic blood flow, optimize the oxygenation, and avoid any increase in the pulmonary vascular resistance. So based on the presence of complications that are present preoperatively, again, the congenital heart disease children are classified into the high risk category. These major complications include presence of a cardiac failure, presence of pulmonary hypertension, presence of arrhythmias or cyanosis preoperatively. If these complications are present, then one must shift the patient to a tertiary center for any non-cardiac surgery, however minor it may be. For emergency surgery, it is said that one must seek help from an experienced pediatric anesthesiologist or at least a second experienced anesthetist and a cardiologist. So coming to the principles of anesthesia in congenital heart disease patients, one must avoid unnecessary surgery, particularly in neonates and children with complex, that is cyanotic heart disease. One must understand the physiology of the lesion. One must assess and optimize the cardiac lesion. Continue the medications as per indication. Consider prophylaxis against infective endocarditis. Avoid acute decompensation during surgery, that is, maintain an adequate ratio of the SVR to the PVR. Management of hypoxia, shunt, polycythemia, heart failure, pulmonary hypertension, and ventricular dysfunction, as indicated. Psychological preparation is essential for both the patient as well as for the family, and a team approach involving a surgeon, anesthesiologist, and intensivist are vital. So look here at the medication and the devices that the patient may already have ongoing. The common medications that the patient could be on would include ACE inhibitors, beta blockers, amiodarone, diuretics, pulmonary vasodilators, or antiplatelets or anticoagulants. And regarding the devices. They can be an implanted pacemaker or a defibrillator. So here one must understand the underlying rhythm, the device mode, and the settings preoperatively. These are some of the indications that have been given by AHA for prophylaxis against infective endocarditis in patients undergoing dental procedures. So prophylaxis against infective endocarditis is indicated in patients with prosthetic cardiac valves, in those with previous history of infective endocarditis, those with unrepaired cyanotic congenital heart disease, those with completely repaired congenital heart disease with a prosthetic material within the last 6 months, those with a repaired congenital heart disease with residual defects, those cardiac transplant patients with a cardiac valvulopathy, and rheumatic heart disease if prosthetic valves or material has been used. So intraoperative management strategies that are important are: one must tailor the agents to carefully maintain the balance between SVR and PVR. One must avoid an increase in the PVR, otherwise increase in PVR will lead to worsening of the right to left shunt. Institute invasive monitoring as per indication, and regional anesthesia must be considered to reduce the systemic opioid requirements and to improve the hemodynamic stability. So anesthetic technique, there is no universal technique that has been advocated. It depends on the physiology of the lesion and the compensation. So sedative pre-medication and analgesia is advocated. Midazolam can be used by any route, intranasal, oral, IV, along with ketamine or even alone, but one must ensure adequate airway and breathing. Opioids are used to preserve the myocardial contractility. For induction, it can be either inhalational or intravenous induction. Both are acceptable. Inhalational induction with sevoflurane is preferred for children. Prolonged sevoflurane, 8% is not advocated. Lower concentrations and slow induction is preferred. Anyway, these patients will have a slow induction, so one must be very careful about the dosing. For intravenous induction, propofol is only to be used in patients with a very good myocardial function. In sick patients or those with compromised myocardial functions, an IV-based induction is preferred. Ketamine is preferred as an induction agent by many anesthesiologists, and if the postoperative course is expected to be turbulent, one must avoid etomidate. For maintenance, both isoflurane and sevoflurane are equally acceptable. One must avoid deep anesthesia and support the ventilation wherever possible. So here, this diagram shows us the intraoperative management strategies that are to be done, which will determine the direction of shunt, the balance between the SVR and the PVR, and it will affect the cardiac output or the systemic perfusion. So on the right hand side, we see the factors which will increase the PVR and decrease the SVR. So any factor which increases the PVR will worsen the right to left shunt, and it will thereby worsen the cyanosis. So these factors are to be avoided in patients with TOF. And the factors on the left side here, any factor that will decrease the PVR or increase the SVR will worsen the left to right shunt, and thereby it has a propensity to cause cardiac failure. So the same thing for a left to right shunt, which are the most common type of shunt, the lesions include ASD, VSD, PDA, AV canal defects. Here, there is an increased pulmonary blood flow, and these are mainly the acyanotic lesions. One must avoid 100% oxygen hyperventilation, as this will worsen the congestion, like I just showed in the previous slide. And in patients who have a right to left shunt, propofol must be used cautiously because it reduces the SVR and the mean arterial pressure. It will further worsen the right to left shunt and cause desaturation. And ketamine, however, maintains the systemic vascular resistance. So therefore, it is preferred in TOF and in Eisenmenger patients with Eisenmenger syndrome. So we have a case of an uncorrected TOF patient coming in with a brain abscess. A 5-year-old boy with TOF with clubbing, cyanosis, seizures, and a large temporoparietal abscess is planned for emergency craniotomy and drainage under general anesthesia. So the perioperative complications that one can anticipate are presence of cyanotic spells due to presence of TOF. There is a heightened risk of arrhythmias and sudden cardiac arrest in this child because the child being cyanotic. There is a risk of pre-existing coagulation defects and increased risk of bleeding during neurosurgery, risk of septicemia and other infections, which can be major causes of postoperative morbidity and mortality due to the brain abscess. And also, in addition to all these, there is a risk of raised ICP and neurological compromise. So evidence from clinical studies have shown that brain abscess can be successfully excised in cyanotic congenital heart disease under either local anesthesia or general anesthesia. However, a tailored approach based on the individual patient's condition is required. So local anesthesia includes a burr hole aspiration. It is generally safe and effective, and it is selected. It has a lower risk, as we would know, and it is for mainly for smaller abscesses. And excision via craniotomy under general anesthesia is indicated for large abscesses, patients with raised ICP, seizures, or uncooperative children. Here, there are high perioperative complication rates, but the mortality is significantly reduced with preoperative planning and vigilant post-perioperative care. So our goals and strategies in this case would be, one is to optimize the SVR. So you have to maintain or increase to reduce the right to left shunting. You have to minimize the PVR. If the pulmonary vascular resistance increases, then the shunt will worsen and cyanosis will increase. So one must avoid hypoxia, hypercarbia, acidosis, and hypothermia. One must ensure adequate hydration, prevent polycythemia-related hyperviscosity, which already exists in this patient because of cyanosis, because of patient being that of TOF. So one must be very mindful of the hydration status, correct the imbalances, and institute invasive monitoring for real-time hemodynamics. So our concerns here, like I said, would be there is a reduced pulmonary blood flow due to the right ventricular outflow tract obstruction, and a hyperviscosity syndrome and polycythemia due to long-standing cyanosis. So already because of a reduced pulmonary blood flow, there is a right to left shunt. So all factors that will increase this right to left shunt will worsen the cyanosis. So here, like already mentioned, pre-op optimization has to be done, address the fever, the dehydration, the coagulopathy, and the electrolyte imbalances, give sedative pre-medication, keep the patient calm, give general balanced anesthesia with good analgesia, avoid dehydration, keep the patient well filled intraoperatively also, avoid any sympathetic stimulation, which can then increase the systemic vascular resistance, will increase SVR, and again, this is to avoid the hypercyanotic spells. And anesthetic induction is preferred with ketamine and fentanyl to maintain the SVR. Avoidance of hypotension and hypoxia are critical to prevent the cyanotic spells. So a closed teamwork is required, post-op monitoring is required, and long-term therapy included extended antibiotic therapy is required. If, despite all our measures, if a hypercyanotic spell occurs during surgery, one must increase the FiO2, deepen the anesthesia, give a bolus of ringer, increase the SVR so as to reduce the right to left shunt. A phenylephrine bolus might be required, and consider a beta blocker. So the take-home message is that one must understand the congenital heart disease pathophysiology before giving anesthesia to any child. Assessment and optimization of the cardiac lesion is required to maintain hemodynamic stability and to prevent cyanotic spells. Systemic pre-operative evaluation to devise individualized anesthetic plans according to the cardiac risk categorization. One must have a judicious utilization of invasive modalities as per the risk category. Early recognition and aggressive management of complications should be done. Close monitoring is required usually for these children in high dependency units and in ICUs. And multimodal analgesia balancing effective pain relief with adequate respiratory drive is required. Thereby, to summarize, a meticulous planning, continuous vigilance, and a cohesive multidisciplinary team transforms complex perioperative challenges into successful outcomes. These are a few of my references, and I thank you for patient hearing. And I would be happy to address.
Thank you, Dr. Poonam, for a lovely talk. Very well elucidated the congenital heart diseases and their anesthetic implications and management. As we all know, that patients with congenital heart disease are at increased risk of developing complications during a perioperative period as compared to their counterparts who are absolutely normal. So these patients, they really require proper care, monitoring, management. And definitely now with the improvement in medical management and even surgical management, many patients of congenital and in fact complex congenital conditions are doing well and coming up to the adulthood. So definitely we get lots and lots of patients of congenital heart disease coming for non-cardiac surgeries. So we have to know the exact mechanism of what and the pathophysiology and what we are supposed to do. Dr. Poonam has nicely talked about a case of tetralogy of Fallot because that's the most common thing all of us dread. When it comes to BSD or a ASD patient coming for surgery, for non-cardiac surgery, we're not that scared. Only a few things which are very important. But tetralogy of Fallot, because it's a patient, if it is a corrected patient or an uncorrected patient, definitely we are definitely worried about the patient. And the patients with congenital heart disease, the management is challenging, and there is no evidence-based single recommendation. So the management will vary according to the patient. And there are various, whatever you feel comfortable with, you can manage the patient. So what I would like to say, she rightly said that it's a multidisciplinary approach. Not only the anesthesiologist and the surgeon, you have to involve the intensivist, the cardiologist, the neonatologist, and whoever is involved in that particular patient. Yeah, thank you, Dr. Poonam.
Thank you, ma'am.
There are any questions from the audience?
No, ma'am, we don't have any questions in the chat box. And thank you so much, Poonam ma'am and Nanita ma'am, for taking out your time and giving you valuable insights on the topic, which is really very important and very difficult to understand topic once again, ma'am. Thank you so much, ma'am. Thank you.
Thank you so much. Thank you.
So moving ahead with our presentations, one of the very important legs of our Viva Voce is a short case presentation. And it's a very important topic on Colles fracture, which is planned for open reduction and internal fixation. For this, I would invite Dr. Gitanjali Chilkoti ma'am. She is a professor in the Department of Anesthesiology and Critical Care in UCMS and GTB Hospital, New Delhi. Her areas of interest are obstetric anesthesia, airway management, and pharmacogenomics. And she has achieved a Health Education Teacher Award by the DMA in 2022, Young Teachers Award by ISA Delhi branch in 2022. She's a member of the Governing Council, East Zone ISA Delhi from 2024 to 26. And she has 91 publications with 11 book chapters to her credit. She has been the organizing secretary of the annual conference of ISA Delhi in 2018, PG Assembly in 2017, and again in 2019. She is scientific chairperson in ISACON 2024, and she's a faculty in AHA accredited BLS and ACLS and Airway Management Foundation, with being reviewer in various indexed national journals. Thank you so much, ma'am, for taking out your time, and we'll move ahead with our case presentations. Dr. Girdhar Kumar will be presenting. He is a postgraduate third-year student in ABVIMS Dr. RML Hospital.
Thank you, Dr. Iti.
Thank you, ma'am.
Girdhar, please make this a full screen. Make it full screen.
Yes, ma'am.
Girdhar, can you make it full screen? It is still showing in the
Full
slideshow.
screen.
Full screen, yes.
Yes, ma'am.
Okay, while this full screen is being done by Dr. Girdhar, thank you so much, Dr. Riti, for the kind introduction. And before we move on to this, before we move on with the case discussion, I would just like to highlight few things that this particular case is a very commonly kept short case in the exam. The simple reason being that these patients are young and they are easy to mobilize for the viva, I would say. And you will not be surprised that when you have a case of Colles fracture every day, if there is a 3 days exam, you may have a case like this every day. And additionally, the another reason is that with the advent of ultrasound in the perioperative medicine, it has revolutionized the use of upper limb blocks. On the contrary, neuraxial blocks still remains to be the standard for lower limb surgeries. And this particular case of Colles fracture gives us an opportunity to discuss all upper limb blocks and to assess these students accordingly. So in exams, they are usually given 2 short cases in the MD exams, and the time allotted is 15 minutes. So you have to take a very focused history taking, and usually no systemic examination is needed for the short case. However, I would suggest you to not to rely on me, and you during your exam, you ask the facilitator that if the systemic examination needs to be done. However, usually it is not done. So your history taking should be crisp, it should be structured, and you should be able to present it logically. And you must be able to highlight the positive and negatives of your case, right? So that is all that I have to tell you about this case. I would request Dr. Girdhar to please go ahead with the case.
Yes, ma'am.
Dr. Girdhar?
A 68-year-old female presented to emergency department after sleeping in the bathroom. She complains of pain and deformity. Her chest with displaced fracture with extra articular distal radius fracture with dorsal displacement. She is planned for open reduction and internal fixation. She is known case of hypertension on tablet amlodipine and has well controlled type 2 diabetes on metformin. There is no significant history other than that. General physical examination, BMI is of 28 kg per meter square. She is right hand dominant. Her vitals are of heart rate 82 per minute. Blood pressure is 142 by 84 mmHg, and saturation is 98% on room air. Her airway is Mallampatti grade 2 and with normal mouth opening and rest within the normal limits.
Okay. So this case is she's an old patient, 68-year-old male with Colles fracture, and now patient has been scheduled for open reduction and internal fixation. So it seems to me like an elective case, right? It's an elective case or a semi-elective case. So what are the anesthetic goals for this case?
So, ma'am, anesthetic goals for this case will be providing optimal surgical anesthesia and analgesia. Patient is elderly female with hypertension and diabetes. So, to maintain hemodynamic stability, to maintain post-op intra-op analgesia, intra-op comfort. Patient is elderly female to minimize post-op cognitive dysfunction and to minimize thromboembolic events and post-op nausea, vomiting, and post-op analgesia.
And in addition to that, the preserving the upper limb function post-operatively is also an important concern. And just because our patient is an old patient, so all the concerns related to the geriatric patient population also would be your anesthetic goal. Okay.
Yes.
So, what are the various factors that will determine the choice of anesthetic technique in this case? Factors influencing
Patient
choice.
is. Yes, ma'am. So regional anesthesia provides various benefits over general anesthesia, like it avoids airway manipulation, it gives better peri-op and intra-op and post-op analgesia, it minimizes risk of post-op cognitive dysfunction, the early mobilization and discharge, so decrease risk of thromboembolic events, associated with decreased post-operative nausea vomiting. So the regional anesthesia will be preferred.
So Girdhar, you have told us that why you should go ahead with regional or the peripheral nerve blockade and not general anesthesia, right? So, but what I was asking was, what are the various factors which determine the choice of anesthetic technique? Surgery क्या है? Surgery is the open reduction and internal fixation. Okay, it's not a closed
Open.
reduction.
Yes.
So the type of surgery, the nature of surgery, the duration of surgery, the associated comorbidities, है ना? And what
Yes.
are the associated comorbidities in this case?
Ma'am, diabetes and hypertension, which was
But
well
patient
controlled.
is well controlled, right? So associated comorbidities, okay? And not
Yes.
only that, your choice of anesthetic technique by and large depends also upon the preference nowadays, preference of the
Yes, sir.
patient,
Patient,
surgeon,
ma'am.
and sometimes maybe anesthetist as well. Okay.
Yes.
Because there is no hard and fast rule that you will give nerve blockade or you will give regional anesthesia. So preference would also help you in, choosing the anesthetic technique, right?
Yes.
So, what are the various anesthetic options which are available for the surgery?
Ma'am, regional anesthesia, including upper limb nerve blocks, which comprises in interscalene, supraclavicular nerve blocks, infraclavicular brachial plexus, and axillary brachial plexus nerve block, and general anesthesia.
What else?
Ma'am, if it's a short procedure, we can also go for IVRA, intravascular regional anesthesia.
Is it being used nowadays?
No,
So
ma'am.
we'll come on this later. So amongst the your options, you also said interscalene block. Would you be interested in giving interscalene block
Yes,
for
ma'am.
open reduction and tunnel fixation for Colles fracture?
No, ma'am.
No. Why?
No, ma'am.
Why?
Ma'am, because interscalene did not cover C8 and T1 nerve roots, which is included in Colles fracture.
So what are the advantages of giving a peripheral nerve blockade over general anesthesia? By this time, you have told us that you will be interested in giving a peripheral nerve block, right? So what are the advantages of this over
Yes,
general
ma'am.
anesthesia? You have already told us few.
Ma'am, it avoids air. Yes, ma'am.
Yes.
It avoids airway manipulation. So
Mhm.
stress related to intubation,
That's okay.
laryngoscopy will be
Next,
avoided.
next. Yes,
That's when there is better intra-op and post-op analgesia. They decreased or minimized risk of post-op cognitive dysfunction, the early mobilization and early discharge. So patient is minimize risk of thromboembolic events. They decrease
If your
peri of
patient,
stress
if
and
your patient
complication.
is Yes. If your patient is geriatric, then you will
Yes, ma'am.
have those concerns related to postoperative cognitive dysfunction or delirium,
Yes.
right? In addition to that, have you ever realized that whenever we give a nerve blockade or regional anesthesia, you lower the systemic drug absorption because the requirement in regional anesthesia is lesser. So
Decrease.
that is also an
Yes.
advantage, है ना? Especially,
Yes.
not in all cases, but especially in patients with comorbidities, right? So there it is an advantage that the polypharmacy, which is associated with general anesthesia, will not be in case of regional anesthesia, right?
Yes.
Okay. Now, so you have said you will give peripheral nerve block. Now, what specific
Yes.
block would you give in this case and why?
Ma'am, we use ultrasound guided supraclavicular nerve block. Ma'am, because it's a simple, most reliable, and it gives dense block, and it's a single shot technique. So I will go with supraclavicular nerve block.
Nowadays, most of the peripheral nerve blocks are single shot, except for one. But what is the other advantage of giving supraclavicular block? It has a quick
Ma'am,
onset, right? It has a quick
yes, ma'am.
onset. It gives denser block, है ना? And what about the
Yes, ma'am.
success rate? Success rate is higher when you compare to other nerve blocks, right? What
Yes, ma'am.
precaution do you take when you give supraclavicular nerve block?
Ma'am, supraclavicular nerve block have few complications like ipsilateral phrenic nerve palsy, vascular puncture, hematoma. So we should avoid this, and also local anesthetic systemic toxicity. So we have to carefully, yes.
Yes, go ahead, please.
Ma'am, before giving injection, we have to carefully aspirate before injecting the local anesthetic.
Okay. So that means something else which is very important when you're giving supraclavicular nerve block. Very important, which you have missed. You are working near the lungs.
Pleura, ma'am.
So what is
Yes, ma'am. Avoiding pneumothorax.
So you did not say pneumothorax.
Yes.
Okay. So what are the potential complications of supraclavicular nerve block? First and foremost, you would try to say pneumothorax, right? There
Yes.
could be nerve injuries. Now, this particular area has very rich vascular supply. Vascular injury
Yes.
हो सकती है यहाँ पे. What else?
Yes, ma'am. Nerve injury, vascular injury, hematomas, where pneumothorax and ipsilateral phrenic nerve palsy, ma'am.
Yeah. And all these blocks, you would always keep a possibility of one entity which is related to the administration of local anesthetic agent.
Local
What is
local
that?
anesthetic systemic toxicity, ma'am.
So, I know this is also one of the complications, right?
Yes, ma'am.
Okay. So what are the set of patients where you would not give peripheral nerve blockade? Where it is
Ma'am,
contraindicated?
yes, ma'am. First one is the patient refusal. If there is
Yes.
a second is the coagulopathy, local site infection, and patient is not able to cooperate or unable to lie down for the duration of the surgery.
Great. Great. So all these are the contraindications. You said coagulopathy and then patients who are on anticoagulants.
Yes, ma'am.
Anticoagulants or high dose antiplatelets. So all these are the absolute contraindications of peripheral nerve blockade. Okay.
Yes,
Now,
ma'am.
Girdhar, can you briefly discuss the sonoanatomy of the commonly used peripheral nerve blocks for this case? We would skip interscalene because it is not
Yeah, ma'am.
recommended for Colles fracture, and the reason you have already told us. So please discuss the
Yes, ma'am.
sonoanatomy of the three blocks briefly.
Okay. So upper limb nerve block primarily comprises of interscalene, supraclavicular, infraclavicular, and axillary nerve block, and whereas interscalene nerve block blocked at the level of roots, supraclavicular blocks at the level of trunk and division, infraclavicular at the level of cords, and axillary at the level of terminal branches. So going with ultrasound guided supraclavicular block, it targets distal trunk and proximal division of brachial plexus with patient in supine position with head turned away with arm adducted. A linear transducer with 8 to 18 megahertz will place just above the midpoint of the clavicle, and on ultrasound we can appreciate the subclavian artery and surrounding its round hypoechoic structure, which is brachial plexus, our target site. So a needle of 20 to 25 gauge of 5 centimeter long needle will be advanced towards the target site, and 20 to 25 ml of local anesthetic will be injected after careful aspiration to avoid intravascular injection. Going with infraclavicular nerve block, it targets the cords of brachial plexus. So patient in supine position with head turned away with from the side to be blocked with arm adducted to 90 degrees and elbow flexed. Linear transducer in parasagittal view just placed just medial to coracoid process and inferior to the clavicle. And on ultrasound, we can appreciate axillary artery and axillary veins, and surrounding to the axillary artery, we can appreciate cords surrounding the medial, lateral, and posterior cords. So needle in plane technique will be advanced towards the site, and a local anesthetic of 20 to 25 ml will be given after careful aspiration to avoid intravascular injection. Third one is the axillary block. So it targets terminal branches of brachial plexus, and patient in supine position with arm abducted at 90 degrees and externally rotated, so the dorsum of hand rests on the bed. So linear transducer will be placed transversely on proximal medial aspect of the arm in order to view axillary artery and surrounding nerves in short axis view. short axis view. So here we can appreciate medial nerve, upper nerve, ulnar nerve, and radial nerve. We have to inject local anesthetic surrounding the axillary artery to block these nerve, and also to here we have musculocutaneous nerve, which is between biceps and coracobrachialis muscle. So it has to be blocked separately for the adequate anesthesia.
So here I would like to emphasize one thing, that when you have seen the sonoanatomy and how these blocks have been administered, one of the problem with axillary nerve block probably is that it requires 2-3 redirections, multiple injections. As Dr. Girdhar has said, you could see in the diagram also that first you try to give it at the level at just above the radial nerve, then just adjacent to the medial nerve, and then you have to redirect your needle and you have to block the musculocutaneous nerve also to have a reliable block. So you may say that this is one of the problem with axillary nerve block, and that is the reason the chances of patchy effect is higher with axillary nerve block. That's why we went in favor for the supraclavicular nerve block. So this is what I'd like to emphasize here. Dr. Girdhar, can you go back to the infraclavicular block? Infraclavicular block. Yes. Back button again. Go back. Previous slide. Previous slide. Yes. So previous slide. Yes.
Okay.
Yes, here. So one, better show infraclavicular. Infraclavicular. Next slide. Yes. Previous slide where you have shown the position of the transducer.
Okay.
Stay here, right? So here, if you see one of the variation of the infraclavicular block is called Raptor. Raptor is one which has come up, in last few years. Raptor is nothing. It is the retroclavicular approach to the infraclavicular region. So here, if you see at the transducer is placed in the parasagittal plane, and the direction of your needle is in plane, and it is going from capillate to the caudal. Whereas what happens in the Raptor approach, that is retroclavicular approach, that you insert this needle from behind the clavicle, and then you reach to your target site, that is the 6 o'clock position where you have to instill your drug. So this is one of the modification of infraclavicular block, which is called Raptor, that is retroclavicular approach to the infraclavicular region. The advantage of Raptor approach is higher success rate, right? This you should know, right? Okay. Go ahead. So in addition to that, so we have seen supraclavicular block, we have seen infraclavicular, we have seen axillary. Now there is another block, which is again a variation of infraclavicular block, which is called costoclavicular nerve block. Could you see it here? Costoclavicular, yes. So this is one of the variation of infraclavicular brachial plexus block. If you look here, your transducer is just below the clavicle. Okay, it is just like the mirror image where you place your transducer in the supraclavicular block. Here you are placing your transducer in the same position below the clavicle. This is called the costoclavicular block. Okay, so actually, eventually you are seeing the same structures. You are seeing the same trunks and its divisions, but from below the clavicle. Okay, next slide. Okay, so this is the kind of image that you get in the costoclavicular brachial plexus block. Now, this particular block has emerged as a very effective approach to the upper extremity regional anesthesia. The costoclavicular space, this is the triangular space where you can see that needle is being inserted. This triangular space, this is called the costoclavicular space. It is the anterior portion of the superior thoracic region, and it is located between the clavicle and the first rib, just like the supraclavicular block. Okay. But now what are the advantages is that by targeting the brachial plexus at this site or at this specific anatomical location, it offers a very powerful and a single shot sensory motor block of the upper extremity, because all these your nerve blocks, they are clustered in the form of grapes over here. So the advantage is single injection. Okay, so it offers single shot injection, and the success rate is again higher with the costoclavicular brachial plexus block. So Raptor and the costoclavicular brachial plexus block are the variations of the infraclavicular block. As such, the infraclavicular block, they need expertise. Supraclavicular block, as Dr. Girdhar has rightly pointed out, yes, it is a better choice because it provides a denser block. It is easy to, easy to administer, quick onset. The problem with infraclavicular blocks are they are a little deep-seated, right? So it needs a little expertise. But then that problem with the classical infraclavicular nerve block, that is not seen with the costoclavicular. Costoclavicular, on contrast to the conventional infraclavicular, is easy, okay? And it is a single injection technique. And costoclavicular space is a little more superficial to the conventional intraclavicular block. So all these are the advantages, okay? Okay. Now, since we have read the three broad categories of nerve blocks, that is supraclavicular, infraclavicular with its two variations, that is raptor and costoclavicular, and the axillary nerve block. So if we have to think in terms of this particular case, that is the patient is for ORIF and for, ORIF for Colles fracture. Now, could you tell me, Dr. Girdhar, which one do you feel is the most suitable? Though I've already answered, but which one do you feel?
Ma'am, supraclavicular nerve block will be preferred, ma'am. More suitable because it quick onset or more denser block.
So when you talk in terms of onset time, onset kiska quicker out of these, supra, infra, and axillary?
Supraclavicular.
Supraclavicular. When you talk in terms of, now let's talk in terms of risk of pneumothorax. The risk of pneumothorax is maximum with?
Supraclavicular.
Yes, risk of pneumothorax, though it is dense and quick block, but then risk of pneumothorax is highest with supraclavicular. Now, risk of vascular injuries?
Yes,
risk of vascular injuries?
Is also higher with supraclavicular nerve block, ma'am.
Followed by infra, followed by axillary.
Followed by
axillary. Okay. Now, when you talk in terms of patchy effect, a need of additional block, which one scores the most?
Ma'am, supraclavicular nerve block have a better.
Just now we said it is quick, it provides denser block.
Yes, ma'am.
Axillary. Just now I told you, while we were discussing axillary, that when we
Yes,
give
patchy
axillary
effect
nerve
will
block,
be
because you
more with
require
axillary
redirections.
Yes, ma'am. Because of sparing of musculocutaneous nerve, multiple injections, and it also did not cover the intercostobronchial nerves, which further, if using tourniquet, then it leads to tourniquet pain after 30 to 45 minutes of
No, we will come next. Let's stay here. So, because axillary nerve block, because multiple redirections and multiple injections might be needed. So, patchy effect is maximum with axillary nerve block. You said about intercostobrachial nerve, intercostobrachial nerve is it blocked with any type of brachial plexus block?
No, ma'am.
So why are you talking in context to? So why are you talking in context to axillary nerve block? It is not blocked with any of the brachial plexus blocks, be it supra, infra, interstellane, it is blocked by none. Okay, so let's not discuss this over here. So in terms of suitability for this case, we would rank supraclavicular as 1. Okay, taking care of the complication, that is pneumothorax and vascular injuries. Okay. Second option would be
infraclavicular nerve block.
Infraclavicular with either of the variation we can use. Okay. And axillary comes the last. Why?
Third one. Yes, ma'am.
Because of the higher chances of
patchy blocks.
Patchy effect. Though axillary is the safest, but the chances of patchy effect is also higher. Because here you must remember that we are not, targeting sensory block. Here you need a motor block. आपको anesthesia चाहिए. You don't want analgesia over here. So that is all about the choice of these techniques. Achha, just now you said that IVRA also is a type of technique which was used years back. So what are the advantages and what are the disadvantages of bias block? Like first you tell me what could be the advantages of bias block?
Ma'am, advantages are it gives better analgesia, more successful rate, and easy to apply, and but its disadvantages are it's associated with local anesthetic systemic toxicity.
Mhm.
And the tourniquet pain if more than 1 hour is there.
Okay. Tourniquet pain. Tourniquet pain is a concern. Then there is a concern of duration limit, You cannot go beyond a
Yes,
certain
ma'am.
time when you are using
Yes,
tourniquet.
ma'am. 60 minutes, ma'am.
But is it being done nowadays very often?
No, ma'am.
Have you done this or have you observed this bias block?
No, ma'am.
No. So because of these limitations, its use has, its use has, almost obsolete because with ultrasound machines, with precise nerve blocks, there are various other ways, to do this. So that is why it is not used. So in exam, you should avoid saying it, and especially when you have not seen it or observed it or done it yourself, right? And is interscalene block recommended in this case? This we have already discussed. Okay. So
Yes,
for this, fracture involves the distal radius. Okay. So distal radius for the anesthesia of distal radius, you basically needs the lower roots of brachial plexus, that is C7, 8, or T1, which is your median, ulnar, and radial nerve. And interscalene block predominantly blocks only the
C5 to C7.
upper roots. Yes, it is
Yes,
blocks
ma'am.
only the C5 to C7. Okay, so it gives an inadequate coverage. So do not say interscalene block in exam, when you get
Yes.
this case. Next slide, Dr. Gilbert. So now first question is, what are the components of informed consent? Now you have to take up this case for surgery. Okay,
Yes, ma'am.
you have to take up this
So,
case
ma'am,
for surgery. Hmm.
so
What all
in
things you
inform,
would include in your informed consent?
yes, ma'am. Ma'am, it will include nature of the procedure and anesthesia related or all anesthesia related risk benefit of regional anesthesia over general anesthesia. Patients should be counseled about the uh, to able to lie down and cooperation and GA consent if general anesthesia consent if our block fails.
Something very important, Dr. Gilbert. You have told about the advantages of the block, है ना? You have told about the complications. Complications में क्या क्या
Yes.
बताओगे उनको? You have to tell it
Ma'am,
in
nerve
injuries,
like nerve injuries, vascular injuries, risk of pneumothorax.
infection, hematoma,
Yes, ma'am.
systemic toxicity. All these things you
Yes, ma'am.
would tell to the patient. And then you said you will take consent for general anesthesia. Something before you should take something else you should take consent for before taking consent for general anesthesia straight away. You will give the patient choices. You will give the
Yes, ma'am.
patient all the alternatives which are available. You'll,
Yes, ma'am.
you'll tell patients, we are planning to put this nerve block, but then you can be anesthetized and can be given general anesthesia. However, the advantages of nerve blocks are these, and problems of these are these, and the advantages in general anesthesia. So you have to give the patient an alternative. Okay, that is very important, which is often missed in the informed consent. Right? And then obviously consent for general anesthesia, just in case if your nerve block fails.
Block fails.
Right? That is the last
Yes, sir.
component probably. So how will you prepare this patient?
Ma'am, I will ask for the baseline investigations, like complete blood count, liver function test, kidney function test with serum electrolyte, baseline ECG, and chest X-ray. Then I will, my pre-op orders will be nilpara for 8 hours for solid and 2 hours for clear liquids, written informed consent, and tablet amlodipine to be continued till the morning of surgery with sips of water. To omit tablet metformin on the day of surgery, tablet alprazolam 0.25 mg at the night before the surgery to be given, and tablet rantidine 150 mg HS night before the surgery to be done.
So this includes your preoperative preparation. Since it is an old patient, you have given you have allay the anxiety by using alprazolam. Rather, it has been seen that the anxiety is seen much more in, young patients, right? So why would you like to get serum electrolyte in this case? In your list of investigations, obviously you'll do only routine investigations, right? So why serum electrolytes, you said?
Ma'am, it's elderly patient and can associated with risk of arrhythmias.
All elderly patients, you get serum electrolytes?
No, ma'am.
Patient who can walk 2 flights of stairs can come and show you in PAC. Would you anticipate some dyselectrolytemia in this case?
No, ma'am. Since
Or patient
patient
is on
well
some
controlled.
or patient is on some drugs which can cause dyselectrolytemia.
In this case, no, ma'am.
So be very cautious when you're saying serum electrolyte. There has to be some evident reason for this electrolytemia. Either patient is on some drug, either patient is bedridden, critically ill, not accepting orally, or patient has some liver diseases, or some bleeding diathesis. Then only you ask for the electrolytes, or some kidney disease, liver or kidney. If it is not that, then it doesn't come in the routine investigations, right? Okay. So after preoperative preparation, आपने alprazolam दे दिया, आपने aspiration prophylaxis दिया as per your institutional protocol, right?
Yes, ma'am.
And all fasting orders. So the preoperative preparation remains almost same. There is nothing specific over here. So now you have given supraclavicular nerve block. So how would you monitor this patient intraoperatively under regional anesthesia?
Yes, ma'am. We'll use ASA monitors, ECG, pulse oximetry, non-invasive blood pressure.
Monitor needs to be put before institution of block. I know.
Yes,
So
ma'am.
start from there. You wheeled in the patient. You will
Yes, ma'am.
record all baseline vitals.
Yes, ma'am.
You'll record all baseline vitals and intraoperatively you can. So what are you don't say ASA monitor. These are called ASA recommended minimal mandatory monitoring. ठीक है? तो इस केस में क्या क्या मॉनिटर
Yeah.
करोगे?
Okay. Ma'am, non-invasive blood pressure, pulse oximetry, temperature monitoring will be done, and NIBP and ECG, ma'am. And also we will vigilantly monitor the local signs of local anesthetic systemic toxicity, and also monitor for tourniquet, if tourniquet inflation time and pressure of the tourniquet. And we will monitor for floats to maintain normal volemia, and to prevent hypothermia, we will maintain.
Sorry, I missed something in your
monitor
intro.
temperature.
How would you monitor temperature in a patient whom you have taken for peripheral nerve block? Would you insert a nasopharyngeal
Ma'am,
temperature probe in this case? Would you like to do that?
Ma'am, we will use skin temperature.
Is temperature monitoring a component of ASA recommended
Ma'am, I will use.
mandatory monitoring? Yes.
Yes, ma'am.
It is a part of ASA recommended
Can-
minimal mandatory monitoring, but then you have to analyze. तो आप कैसे करोगे? You can do temperature monitoring by other means. है ना? A patient who's awake, inserting a
Ma'am,
nasopharyngeal.
skin.
Yes. Yes. Okay.
Yes, ma'am.
And rather the hypothermia is seen more commonly with general anesthesia or regional anesthesia.
Ma'am, more with general anesthesia.
ठीक है? So regional anesthesia you may skip also. Okay, especially for short procedures.
Okay.
That doesn't mean that regional anesthesia there is no hypothermia. Okay, there also it takes
Okay.
place, but it is seen more under general anesthesia. Okay, so that's all about the intraoperative monitors that you would do. And very correctly you said you would also check urine output and any systemic toxicity signs for local anesthetic agents.
Local anesthetic.
आपने
Yes.
डोज कितनी दी थी supraclavicular nerve block में?
Ma'am, 20 to 25 ml of local anesthetic, ma'am.
क्या concentration दिया था?
Ma'am, bupivacaine of 0.5%, ma'am.
Yes, because you want surgical anesthesia.
Anesthesia.
Okay.
Yes.
Okay. Why didn't you think of putting in a catheter?
Ma'am, it is more complicated and
First of all, the beta, it's a short duration surgery.
yes,
है ना?
ma'am.
It's a short duration, maximum 1 hour, 1.5 hours. So catheter is not needed and pain can very well be managed in the post-operative period. Just in case if patient has comorbidity, let's say patient has heart disease and you want a better post-operative pain relief in that case, which block you would give? Supraclavicular में डालते हैं catheter?
No, ma'am.
Which upper limb
Because
block is best when we talk in terms of catheter placement?
infraclavicular nerve blocks, ma'am.
Very good. Infraclavicular. Can you tell me the reason why infraclavicular?
Ma'am, it avoids risk of chronic nerve palsy, and also there is this minimal risk of pneumothorax and better tolerated for the patient by the patient.
वो तो axillary में भी होता है. So why not put a catheter in the axillary nerve block? The same advantages are there in the axillary nerve block also.
Ma'am, but better toleration by the patients is the
Toleration
position of
better
the
क्यों? Why toleration better? See, let's talk about each block one by one. Supraclavicular block, there is a, sort of a fossa, where so it's a small space comparatively, okay? And it's an area which is mobile because it is near to the neck. So every time you will move, you move your catheter also, right? So it's a mobile area, that's why you avoid. Why do you avoid? Why do you prefer it with infraclavicular block? Because with infraclavicular block, did you see the anatomy? There is pectoralis major and minor muscle. So these muscle,
ma'am.
these chest muscle helps in they trap the catheter more.
Intraclavicular force.
The catheter
Yes, ma'am.
remains in place. That is the reason for catheter placement, infraclavicular nerve block is preferred. Axillary, again, it is a very superficial block, just 1 centimeter below you have all the structures. Where will you place the catheter? So when catheter, you'll say infraclavicular. However, for this particular surgery, the catheter placement is not required. Is that all right?
Okay.
So that is the reason.
Yes, ma'am.
Okay. So now coming on to, would you consider sedation during the procedure?
Yes, ma'am. Yes, ma'am. Yes, ma'am.
Yes. What would you give? Your patient is
Ma'am,
68 years old.
yes, ma'am. We give injection midazolam, or we can use injection fentanyl 0.5 to 1 mics per kg. And we can also use injection dex.
So just give only one sedative, either Midaz, either Dexmed, or 1 shot of fentanyl. Don't try to give a cocktail over here, especially when it is a geriatric patient. Why?
Ma'am, there is decreased requirement of dose, and also there is increased risk of respiratory depression.
Yes, because they have increased sensitivity, higher chances of post-op
Yes, sir.
delirium and cognitive
Yes.
dissonance. Okay.
Yes, sir.
Now coming on to the post-operative pain management. अब आपने peripheral nerve blockade में case कराया है, supraclavicular block, you are given
ma'am.
25 ml. The surgery lasted for 1.5 hours. After surgery, how would you manage pain?
Ma'am, I will manage by multimodal IV analgesia by giving injection paracetamol 1 gram IV TDS, and with supplementation of injection tramadol 1 to 1.5 mg SOS. mg per
PCM
kg.
के साथ कुछ और नहीं देना चाहोगे? PCM and opioid you want to give?
Yes, ma'am. Ma'am, we can use NSAIDs.
Yes. So when we are talking about the post-operative pain management, try saying round the clock PCM and NSAID with opioid as a rescue analgesic, tramadol as a rescue analgesic, right? The world is going towards the opioid-free anesthesia, opioid-sparing analgesia. I know. So we would avoid the use of opioid by using it only as
Opioids.
a rescue analgesic, right? Catheter ka humne already we have discussed, right? That is all. That is all the post-operative pain management, right? NSAID में क्या हो सकता है? NSAID में any specific NSAID you would give? What could be the problem of giving
Diclofenac.
NSAID here?
Ma'am, diclofenac, ma'am. We can give.
Diclofenac. So you can give diclofenac around the clock. Does it affect your neuraxial block, or does it causes any concern with the catheter in situ?
Ma'am, it's it's associated with coagulopathy, and also if patient have hampered kidney functions, then it is given with caution.
What are COX-2 inhibitors?
Ma'am, like
COX-2 inhibitors.
aspirin.
Would you prefer COX-2 inhibitors amongst NSAIDs?
Ma'am, will not prefer
Will
because
not prefer?
it's
Which NSAID preserves the gastric mucosa and platelet function better? See, you may prefer COX-2 inhibitor,
sorry,
but
ma'am.
one dose, doesn't affect the platelet function that much and doesn't causes concern related to the catheter in situ. Okay, so you can very well go ahead with NSAID. Okay, PCM, NSAID, round the clock, followed by opioid as an rescue analgesic. Out of opioid also, you would prefer weak opioid like tramadol first, right?
Yes,
Okay, next slide. Next slide. So now let's discuss
Yes,
few
ma'am.
troubleshootings during the intraoperative phase. Now this case by Dr. Giridhar was started under supraclavicular block, but after 40 minutes, patient complained of dull aching pain in the arm and forearm. What could be the cause, Dr. Giridhar?
Ma'am, since patient is complaining of dull aching pain, and after 40 minutes, it's suggestive of tourniquet pain.
Okay.
So it's basically due to reactivation of unmyelinated C fibers, which causes this dull aching pain.
Okay, so it is a tourniquet pain. Okay. Why did you say
Yes.
tourniquet? Because it is dull aching.
Ma'am. Yes, ma'am.
It is dull aching despite there being full anesthesia in the forearm. Okay. The dull
Yes,
aching
ma'am.
is only in the upper arm. That is all. Now tell me, Dr. Girdhar, is tourniquet applied in all cases of or if for Colles fracture?
No, ma'am. It is not applied in all cases of Colles fracture. It usually depends on the surgeon, also depends on if it's a multiple fracture. If it's a crushed injury, then it will be avoided.
Do they apply tourniquet in crushed injury?
No, ma'am.
Severe soft tissue or
It is
crushed injury
avoided.
is one of the contraindication for tourniquet application. So again, this particular entity depends
Yes,
upon
ma'am.
the surgeon's preference. There are various surgeons who would prefer using tourniquet because they say that the ligaments and the muscles are better seen in bloodless field. No? So in our setup, in our institute,
Yes,
they
ma'am.
out of 10 cases, all 8 and 9 they apply tourniquet. Right? Okay. So
Ma'am,
one of
I'm
the
Sorry, ma'am.
sorry to
contraindications.
say, ma'am, I'm sorry to say, I would interrupt
Just
here, but
finishing.
yeah, ma'am, we have to, like, we are already past the time and our next
Yeah,
speakers are waiting. They have
yeah.
7:40
Finishing.
also.
Yes,
Yes, ma'am.
finishing in 5 minutes.
Thank you, ma'am.
So this is all. Second troubleshoot. Yes. Have to give the next slide. Now, if the patient
Yes,
was
ma'am.
on antiplatelet therapy, how would your anesthesia plan change?
Ma'am, if patient is on single antiplatelet aspirin, then we can continue with regional anesthesia. Whereas if patient is with dual antiplatelet like aspirin plus clopidogrel, we have the guideline says to hold clopidogrel 7 days prior to the procedure. So since it is a elective surgery, we plan to defer the case.
Yes. So if it is a single antiplatelet, go ahead. And if it is dual, you would not give peripheral nerve blockade. Third troubleshooting. So after 30 minutes of surgery, patient complains of excruciating pain, intraoperative failed peripheral nerve blockade. So how will you assess and what action would you take?
Ma'am, since after 30 minutes of surgery, patient complain of excruciating pain, suggesting it's basically of surgical site, it's a surgical pain. We will assess by motor and sensory function, and I will supplement it by IV analgesic and IV sedations. And my last resort would be converting it into a GA if it fails.
So rightly said. In that case of an assessment, you will check for patient discomfort or tourniquet pain. You can do a sensory mapping, You can ask the surgeon to infiltrate the radial or medial nerve with some local anesthetic agent, depending on which nerve sparing has taken place. And immediate action, as you have said, you would ask the surgeon to infiltrate, or you can give a small dose of analgesic, maybe IV fentanyl or IV midazolam. And however, if their surgery is extensive and there is complete block failure, you would give general anesthesia. But throughout all this time, you must document the block failure and monitor for local anesthetic systemic toxicity, and communication with the surgical team is paramount in this kind of scenario. Last slide.
Yes, ma'am.
Next slide. So the take-home message from this particular case is that regional anesthesia, supra-infraclavicular blocks are well suited for these kind of surgery. Coverage of the intercostobrachial nerve and the medial brachial cutaneous nerve, which are not covered by brachial plexus block, should or may be considered in cases of tourniquet pain management. However, the evidence is not short, but still it may be considered. Now, peripheral nerve block can be performed in patients on aspirin or NSAIDs. Deep plexus block in anticoagulant patient, guidelines for neuraxial block is being followed as per the recent ASRA guidelines. Now, for other peripheral nerve blocks, the performance of the technique with the catheter maintenance and removal based upon the compressibility of the area where you're putting a block, the vascularity of that area, and the consequences of bleeding must be considered. Then the preoperative optimization and the vigilant monitoring are key for the good outcome. Thank you. Thank you, Dr. Girdhar.
Thank you so much,
Thank you, ma'am.
ma'am. We don't have any questions in the chat box. And this was a very comprehensive illustration of the whole case, ma'am. Thank you so much for your valuable insights. So we will move ahead with our presentations. And for this, I would invite Dr. Bimla Sharma, ma'am.
Good afternoon.
Good afternoon, ma'am.
Good afternoon.
Ma'am is the head. Good afternoon, ma'am. Thank you so much for joining us, ma'am. Ma'am is the head of Department of Palliative Medicine and she is the senior consultant anesthesiologist at Sir Gangaram Hospital, New Delhi. She is founder member, trustee, fellow, and regional coordinator, Indian College of Anesthesia. She is honorary professor palliative medicine, Jamia Millia Islamia University. She is guide and examiner for National Board of Examinations at MD. She has received Bhojraj and Cops Award for ISA National, and she has more than 60 national and international publications and several book chapters. And she has conducted many AOA and pain workshops. Her areas of interest are supraglottic devices, palliative care, and pain management. Ma'am, welcome again, and please introduce our most esteemed speaker for the topic, ma'am. Thank you so much.
Thank you. Thank you for your kind introduction. And at the outset, I would like to thank Dr. Neeja and her team for having me here. And we have a very eminent speaker, Dr. Pimi, for the next talk on the perioperative management of patients coming for non-cardiac surgery with implantable intracardiac devices. So I'll not take much of time. Dr. Wimmy is a professor at Department of Anesthesiology, Pain Medicine and Critical Care, AIIMS, New Delhi. And she has been awarded Commonwealth Academic Staff Fellowship in Liver Transplant Anesthesia and Critical Care at St. James University Hospital, Leeds NHS Trust, Leeds, UK. And her areas of interest are critical care, hepatobiliary and liver transplant, obstetric anesthesia, and acute pain. Over to Dr. Bimni, please.
Good afternoon, ma'am. I think I already have a pre-recorded lecture, so I think
yes,
we
yes, we can.
play it. Yeah.
Yes. Thank you.
Today, I'm going to be talking about the management of a patient with a cardiac implantable electronic device, or CIED, for a non-cardiac surgery. So in the next 25 minutes, I'm going to go through the physics and nomenclature of CIEDs, indications for placement of CIEDs. I'll be describing a case scenario of a patient with CIED and subsequently the preoperative evaluation, preparation, intra and post-operative management for that patient. Then finally, the non-operating room procedures in patients with CIEDs. So what is a CIED? These are electronic devices both for rhythm management as well as management of cardiac failure. And there are about 37,000 CID insertions per year in India alone, and it is increasing. And therefore, it is very likely that we are going to encounter patients with CIDs for surgery or for non-operating room anesthesia. And as anesthesiologists, it is imperative that we understand the characteristics of these equipment, the troubleshooting for these, as well as the perioperative concerns of these patients and their anesthetic management. So what are the various types of CIEDs? So the most common and what everybody is familiar with is the permanent pacemaker or a PPM. Then the second most common is an AICD or an automatic implantable cardioverter defibrillator. Then two less common are the cardiac resynchronization therapy device or the CRT device and an implantable loop recorder. And I think as trainees, you just need to know about PPMs and ICDs. But for the sake of completion, I'm going to be talking about the other two as well. So ICDs are basically devices which are capable of pacing as well as defibrillation or shock therapy. And these are indicated in patients with a very high risk of sudden death due to ventricular arrhythmias. Then CRT devices are basically biventricular pacemakers. That means the leads are placed both in the left ventricular as well as the right ventricle. And these are indicated in patients with moderate to severe cardiac failure with a left ventricular ejection fraction of less than 35% with a wide QRS interval. It optimizes the timing of the right and the left ventricular contraction, which is uncoordinated with sole RV pacing. The ILR is a leadless cardiac monitoring device, which is basically used as a diagnostic tool and is indicated in patients with recurrent unexplained syncope or palpitations. So basically what it does is that it has self-contained electrodes, which then is used for recording the ECG during the time of the episode. So the pacemakers are comprised of a pulse generator as well as the pacing leads. And the pulse generator is a silicon chip and electronic sensing and output circuitry. And what it does, it delivers current to single or multiple chambers. Then it is attached to pacing leads, which can be of two types, unipolar or bipolar. In a unipolar lead, there is a single electrode which is present at the tip of the lead, and the pulse generator acts as the second electrode or the anode. In a bipolar lead, however, both the cathode and the anode lie on the tip of the lead, and therefore these leads are less susceptible to electromagnetic interference. So this is what it looks like. This is the pulse generator which is attached to the leads, and it is then inserted via the subclavian vein, and you can see the leads entering into the right ventricle, right atrium, and the right ventricle. And this pulse generator is generally implanted subcutaneously in the pectoral region and the left pectoral region just below the clavicle. So like I said, the pulse generator gives out electric current which is transmitted between the anode and the cathode, and then subsequently it goes on to the myocardium via a lead to achieve depolarization. Now, a successful pacing-induced depolarization leads to an electrical capture, and the intrinsic electrical activity of the myocardium of that patient is also there. If it's there, then the pacemaker responds by either inhibiting or triggering the pacing, depending on the electrical activity. Now, there is a certain classification of the pacemakers, and this is generally a generic coding which is denoted by various alphabets, and basically of 5 types, but the first 3 are the most commonly used and are more pertinent to us. And the first letter actually tells us about the chamber space. The second letter tells us about the chamber which are sensed. Then the third letter tells us what is the response to that sensing. So O means done, A means atrium, B means ventricle, and D is dual. That means both atrium as well as ventricle. So now these codes are combined to describe, like I said, the mode of pacing, the mode of sensing, and how the pacemaker will respond to the presence or the absence of the intrinsic electrical activity. And just to explain about how this works is, I'm going to give you a few examples. I'm sorry. So the first is the VOO, which means that the pacing is occurring in the ventricle. O means no sensing, and the third O means there is no response as well. So there is this mode is a ventricular asynchronous pacing. That means the pacemaker is set at a fixed pacing rate. And this you can see, these spikes is the pacemaker function, and it is occurring at a regular interval irrespective of the patient's own intrinsic activity. Then we come to the VVI, which means there is ventricular pacing, there is ventricular sensing, and the sensed intrinsic QRS complex then leads to inhibition of the ventricular pacing. Now, like you can see here, this pacing spike is followed by a QRS complex. That means this is paced, and here you can see that this is intrinsic activity because there is no pacing spike. So this is patient's own intrinsic activity. Now then AOO, again atrial pacing, no sensing, and therefore this is an atrial asynchronous pacing which is delivered at a fixed rate. And again you can see the pacing spike is just below the P wave, and it is occurring at a fixed interval without any coordination with the patient's own intrinsic activity. Then AAI means atrial pacing, atrial sensing, and the intrinsic P wave is inhibited by the atrial pacing. It inhibits if there is an intrinsic activity or intrinsic P wave generated by the patient's own atrium, it inhibits the artificial pacing or the atrial pacing. Like you can see here, this is the patient's own intrinsic P wave, and therefore this does not require any pacing. Here, however, there is a pacing spike which is followed by a P wave. So then we come to DDD, which means that there is pacing as well as sensing in both the atrium as well as the ventricle. The intrinsic P wave and intrinsic QRS can inhibit the pacing. If there is intrinsic activity present, the pacing equipment will go silent. It will not do anything. It will let the heart work. But if there is intrinsic P wave, then and it is not followed by a QRS, then it can trigger a QRS. Like here you can say there is intrinsic P wave, intrinsic QRS, so there is no pacing. There was no intrinsic P wave, so there is pacing followed by a P wave and then by a QRS complex. QRS complex is intrinsic. Here there is paced P wave, a paced QRS complex. So there's all various combinations that you can see. So what happens in the DDD? There is atrial sensing and ventricular sensing, which means atrial and ventricular activity is detected within the preset time interval, and which leads to inhibition of the pacing activity. That means the patient's own heart rate is enough to maintain a cardiac output. Then there is atrial pacing and ventricular sensing. That means that atrial pacing leads to ventricular activity within the preset time interval. So it is sensed by the ventricular lead and inhibits pacing, as in 6 sinus syndrome. Then there is atrial sensing and ventricular pacing, like I showed in that previous ECG. If there is sensed intrinsic atrial activity, it triggers ventricular pacing if there is no spontaneous ventricular depolarization within a preset time interval. And this is something which occurs in a complete atrioventricular block and normal SA node function. And finally, there is atrial pacing and ventricular pacing, which means there is pacing of both atrium and ventricle if intrinsic electrical activity is undetected within preset interval. This occurs most commonly in complete heart block. Now, what is a magnet mode? You would have often heard of the use of a magnet in a patient who has a pacemaker. So the application of a magnet to a permanent pacemaker varies with the pacemaker setup and the manufacturer. It initiates, basically what it does is, it initiates an asynchronous pacing mode. That means AOO, VOO, or DOO, depending on the type of leads or the type of pacemaker. And it starts delivering a constant rate with pace stimuli, which is regardless of the native rate or rhythm. But if the VOO or the DOO is kept for a very long time in the postoperative period, there can be a risk of PPM-induced ventricular tachycardia. So these are the various indications for a permanent pacing. So the class 1 indication in sinus node dysfunction is documented symptomatic bradycardia or chronotropic incompetence. And in AV conduction abnormalities, there is 3rd degree and advanced 2nd degree AV block. There are various other indications. I think you can all go through this in the textbooks. Then what are the factors which affect functioning of CID? So this is the most important thing that one needs to understand, because this directly affects our management of the anesthetic management of these patients or management of these patients in the OR or in our care. So the first and the most important is the electromagnetic interference or the EMI. Then the myopotentials, which can be generated as a consequence of shivering or fasciculations induced by succinylcholine, electrolyte disturbances, or there is alterations in pH, blood transfusion, and chemotherapy. So what happens in these conditions? If there is shivering or fasciculation, it is sensed as a cardiac contraction and it can inhibit pacing. The other reasons that the other causes such as electrolyte changes, temperature, pH, blood transfusion, which itself can lead to pH and temperature changes or electrolyte changes, and chemotherapy. All of these can alter the myopotential threshold and therefore lead to loss of capture. That means even though the pacemaker is working, it's not leading to depolarization. So there is no actual contraction of the atrium or the ventricle, whichever it is facing. So what are EMIs or electromagnetic interference? These are potential disruptions of operation of electrical device when it is in vicinity of an electromagnetic field which is generated by an external source. So the most common source of EMIs are the electrocautery or electrosurgery unit, as it is otherwise called, and it generates electric current of about 100 kilohertz to 4 megahertz. So this can actually significantly impact the functioning of a pacemaker. So there are two types of cauteries, bipolar and monopolar. The bipolar are definitely safer because the active and the return electrodes are within that cautery pen and it maintains a very small local current pathway, whereas a monopolar has a very large current pathway because the electrode is placed on the patient's thigh or back. So the other equipment which can generate EMI is the nerve stimulators for nerve blocks, peripheral nerve stimulator, transcutaneous electrical nerve stimulator, lithotripsy, and radiofrequency ablation devices. So what are the risks of EMI? What happens if there is EMI? So this can lead to inhibition of pacing due to ventricular oversensing. And this because the EMI can be interpreted as signals as native R waves, and which leads to inhibition of the pacing. There is no pacing, and this can lead to profound bradycardia or asystole. On the other hand, the EMIs can also be such as fasciculations can be misinterpreted as tachyarrhythmias, and if there is an ICD, there can be delivery of an inappropriate shock or anti-tachycardia pacing, which can be very dangerous to the patient. It can also directly damage the CID, and there can be activation of the power on reset mode, where the device reverts to the factory programmed parameters, which can again lead to loss of specialized functions in CRT especially, or they can be total device failure with no output. This too can happen with a very strong electromagnetic interference. So what happens when you use magnets? So whenever you place an arm magnet, like I mentioned previously, on a CID, it reverts to an asynchronous mode. But this is temporary. As soon as you remove it, the normal function resumes. So the magnets differ based on the type of the manufacturer, and this is generally found in the coronary care unit. So this is not something that you can pick up from the market and use any magnet. These are specifically designed magnets based on the type of the pacemaker. So like we said, these are specifically designed. They are either designed as a block or as a ring, and they are positioned over the implantable device. And it is very important, I think all of you should remember that you should, if you need to place the magnet, it should be placed on the device which needs to be felt under the skin, which should not be kept on the skin incision. Sometimes the skin incision differs from the site of the pacemaker where it is actually implanted. Okay, so in the PPMs which are manufactured by Medtronic, Boston Scientific, and Biotronic, the magnet is positioned directly over the device. However, in St. Jude Medical PPM, the magnet is offset with the curved ring magnet positioned over top or bottom of the device. So this is what the Medtronic magnet looks like, and this is placed directly on top of the PPM. And the ring magnet, which is used in the St. Jude, it is placed either on the top or the bottom, slightly away from the magnet. So like I said, the pacing of the magnet changes the PPM mode to a fixed rate pacing. It can sometimes, like I said, if it is kept for a very long time, it can be arrhythmogenic as well, leading to an RMT phenomena. It can lead to dangerous ventricular arrhythmias. So if this is what happens when a when a magnet is placed over a PPM. So what happens when you place a magnet over an ICD device? So what it does is it inhibits the delivery of the antitachycardia pacing and the shock therapy. That it prevents that, but it has no effect on the bradycardia pacing. So remember that ICD has a defibrillator function and a pacing function. So if it is also doing a pacing function for bradycardia, that will not get affected in an ICD. So if bradycardia pacing deactivation is also required, then it has to be done by a programmer in the preoperative period. So the inhibition of the shock delivery by the magnet on ICD is effective only during magnet placement, and it should be secured on patient for the duration of surgery using surgical tape. In the Biotronic ICD, if the surgical procedure lasts more than 8 hours, it reverts to normal function, and then the magnet needs to be removed and then reapplied and then it will function for another 8 hours. So now we come to the case scenario. Say this is one of the most common case scenarios. You have a 65-year-old male with benign prostatic hypertrophy, scheduled for a transurethral resection of prostate, and he has had history of recurrent syncope. Excuse me. For which a permanent pacemaker was inserted 2 years back. He's presently asymptomatic and has no other comorbidities. In the preoperative evaluation, a detailed history needs to be taken, followed by a physical examination and review of all available medical records. It is imperative that you check for the device information card, which is provided by the pacemaker company, along with the ECG and X-ray. So this is what a device information card looks like, and you can say the date of implantation is mentioned, the serial number, and the model is also mentioned. So, look, if you look at this chest X-ray, you can see the pulse generator, which is in the left pectoral region, and it has 2 leads. One is implanted in the right ventricle, and the other in the right atrium. So this is most probably a dual chamber pacemaker. Now here what you can see is a pulse generator, and there is a single lead with these thickened areas of coil. So this is a single chamber ICD. That means the lead is only in the right ventricle with 2 high voltage shocking coils. So this is an ICD. And what do you see here? Here you see 3 leads, right? So you see the right atrium, right ventricle, and you also see one going here, which is placed in the coronary sinus. And these thick opaque segments are for the anti-shocking function. So these are the various kinds of pacemakers: St. Jude, Trident, Biotronic, etc., and Medtronic, different types, and this is what they look like on the X-ray. So what are the the ECG features of pacing. So this is pacing, like I explained in the previous ECGs. There are how do you diagnose pacing? It is noted by spikes. So these are vertical spikes of short duration, usually 2 milliseconds, and the amplitude depends on the position and the type of lead. So in the atrial pacing, the pacing spike generally precedes the P wave. So you can see here, this is a atrial pacing spike followed by P wave. Then there is ventricular pacing, where the spike precedes the QRS complex. Now you can see here, so this is the spike followed by a QRS complex, spike followed by QRS complex, and generally the QRS complex resembles a left middle branch block pattern. Then there is a dual chamber pacing, where the pacing spikes may precede only P wave, only QRS complex, or both. Like I said, so here this is preceding only the P wave. Here it is preceding both the P wave as well as the QRS complex, and here only the QRS complex. So what is this ECG donating? So what you can see is spikes followed by QRS complex. That is successful capture. And here you can see just spikes which are not followed by the QRS or a P wave. So this is failure to capture. Now what do you see here? You see pacing followed by P wave and a QRS complex. And here what do you see? There are no pacing spikes and there is an idioventricle. So this is failure to pace. So what do you need to see in the preoperative assessment? The information needed from surgical team is surgical procedure and the location of what is the incision going to be, the possible sources of AMI. Are they going to be using electrosurgery unit or electrocautery? What is the position of the patient, and do we anticipate large blood loss or fluid shift? So next we come to what is the information needed from the CID team, which means cardiologist, electrophysiologist, and the company representative or the technician. So what we need to know is the type and the function of the CID, like I explained before, the manufacturer and the model, the indication of implantation, very important, and the device's last interrogation. And what do you understand by interrogation? When has it been checked last? So for permanent pacemaker, it has to be within the past 12 months, and for an ICD within past 6 months, and for cardiac resynchronization therapy device within the last 3 months. The other thing that needs to be checked is the battery life, the details of the CID, pacing mode, program lower rate, ICD therapy, etc. Whether the patient is dependent on the pacemaker, whether the patient has its own significant intrinsic rate or not, or it's completely pacemaker dependent. What is the underlying rhythm? What is the response of device to placement of a magnet, and whether the settings are reverted to original on removal of the magnet. So what was the findings on our patient? Our patient had a Medtronic pacemaker and was on a DDD mode. The indication was a sick sinus syndrome. The patient was completely pacemaker dependent, and the surgeon planned to use electrocautery. So what happens, why do we need to know where the incision is? So like it's depicted here, if the incision is very close to the pacemaker generator unit, then the chances of the current going through interfering with the pacemaker circuit is very high, which can lead to pacemaker malfunction. However, if the surgical site is away from the pacemaker incision, the likelihood of the cautery interfering with the pacemaker function is very less. So the preoperative reprogramming to asynchronous mode is required when there is significant risk of EMI and the patient is completely pacemaker dependent, like in the patient that I described, or the patient has significant electrolyte abnormalities which can interfere with the myopotentials. Now, just to summarize what I said, if the patient has a pacemaker, the first thing you need to find out is whether there is going to be electromagnetic interference. If no, then we don't need to do anything. If there is yes, then the next thing that we need to know is the patient pacemaker dependent? If the patient is not pacemaker dependent, then there is no reprogramming necessary, but just have a magnet available in case of emergencies. If the patient is pacemaker dependent, then the next thing that you need to know is the distance of the CID to the source of the electromagnetic. If it is more than 15 centimeters, then nothing needs to be the same, no reprogramming, but have a magnet. If it is less than 15 centimeters, then it is advisable to reprogram to asynchronous. Now, if the patient has an ICD, then we need to know if there is an EMI associated with the procedure. If not, then we don't need to do anything. If yes, then we need to deactivate the ICD either preoperatively by calling the programmer or by placing a magnet intraoperatively. Then, is the patient pacemaker dependent? Like I explained previously, if the patient is pacemaker dependent, then we cannot rely on the magnet alone because it has no effect on the pacemaker function. And same as pacemaker, if the distance is less, the electromagnetic interference distance, the source of electromagnetic interference is less than 15 centimeters, then we need to reprogram to the asynchronous. So what are the intraoperative considerations? The intraoperatively, we need to maintain a very vigilant monitoring, keep an eye on the cardiac rate and rhythm. It is ideal to have an invasive blood pressure to look out for pulseless electrical activity, and any changes in electrical activity or hemodynamic instability, if you notice intraoperatively, then immediately ask the surgeon to stop use of cautery. And if you suspect adverse pacing behavior, then you should keep the magnet, apply the magnet over the pulse generator. So then the other precautions that one needs to take is to keep the cautery dispersal plate or the earthing electrode as distal as possible to the site of device implantation. The cautery should be used in short, irregular bursts, preferably bipolar cautery or a harmonic scalpel, and more on cutting than coagulating current. Then if the patient has malignant ventricular tachyarrhythmias for which an ICD has been placed and it has been deactivated by a magnet, and the patient has a tachyarrhythmia intraoperatively, then one can remove the magnet and resume the function of the ICD. However, just to be careful, one can also place external pads preoperatively just in case that the ICD malfunctions. So either external pads or handheld pedals as far as possible from the pulse generator, again to minimize the current flowing through the pulse generator and the leads. And the ideal position is the anterior posterior position, and this is how it looks. That means that the apical pad is placed right here where it is always placed, and the second pad, which is usually placed anteriorly under the right clavicle, it is placed posteriorly like this. So this is what the anterior posterior pad placement is looks like in a patient who has a permanent pacemaker. Because like you can see, ideally it is placed on the left side, but it can also be placed on the right side. So this position is the best. However, if the patient has a left-sided placement, then this can also be used, but this can definitely not be used if the patient has the right-sided implanted pacemaker. So anesthetic agents has no effect on pacing. However, hyperventilation, acid base, or electrolyte abnormalities can affect the pH or the electrolytes, and therefore it should be avoided. Volume overload, blood transfusion, and high blood concentrations of local anesthetic, especially if there is accidental intravenous injection, can increase the capture threshold and sometimes can alter lead impedance as well. CID in the post-operative period, the CID settings are, you should remember to restore them to baseline, either by removing the magnet or by taking the help of the programmer. There should always be immediate availability of backup pacing and defibrillation in case of malfunction. And after the patient, after the pacemaker has been reset to the original settings, one should always get it interrogated for appropriate device function, especially if there has been use of central venous lines or PA catheter insertion or cardiopulmonary bypass, which can interfere with the leads. So if there is non-operating theatre procedures such as radiofrequency ablation, one should disable the ICD and the pacemaker should be reprogrammed to the asynchronous mode, and the ablation current should be kept as far as possible, as far away as possible from the pulse generator and the leads. MRI is generally contraindicated in patients with CID unless the pacemaker is MRI safe. So the newer ones are now MRI safe, so they can be used. And whenever MRI is done, it should be done using specific protocols. Then in lithotripsy, one should disable the ICD, and atrial sensing pacing should also be disabled if the lithotripter triggers the RBO. In electroconvulsive therapy, one should disable the ICD because that can generate an inappropriate current for defibrillation, and the CIED should be interrogated later to assure correct settings. So in radiation therapy, generally is not associated with EMIs, but it can cause electrical reset. The ionizing radiation can also damage the insulation of leads. So it is generally safe with appropriate shielding, but one should always get it checked after the radiation has finished. So what happens if a patient with CIED has a cardiac arrest? So the resuscitation is done in the same way as if there is when in a patient who has no device, but there is no significant risk to the person performing CPR. If one needs to give an external shock, one should take care that the defibrillation patch should be placed as far away from the device as possible. And post resuscitation, there should be device interrogation to know that it's functioning properly. So to summarize, the ideal perioperative management of a patient with CID is a multidisciplinary one where there is a continuous communication between the anesthesiologist, the cardiologist, the electrophysiologist, the programming technician, and the surgical team. The primary aim is prevention of CID malfunction by minimizing exposure to EMIs, and the decision-making process should be tailored to individual patients and their needs. So I will end by giving you a trivia, which is interesting. So the picture that you see here is that of Mr. Larson, who's the world's first implantable pacemaker patient. And he went on to receive 26 different pacemakers during his lifetime as they kept getting involved. And he died in 2001 at the ripe old age of 86, outliving the inventor of the pacemaker as well as the surgeon who implanted the pacemaker in the first place. Thank you very much.
Thank you very much, Dr. Vimmi, for a very lucid and very comprehensive talk on the subject. As such, not many of us, have experience of giving anesthesia to these patients. At least I have not given anesthesia to any patient with, left ventricular assist device. So, I mean, you really highlighted very, very important points. And as such, we know that like there is increasing, risk of cardiovascular disease, and the population is aging. So more and more patients will be coming with this implantable cardiac devices, and it is imperative, very, very important that we know about these things. One thing I would like to ask, I know we're running short of time, just one question, since you talked about cardiac arrest. So patients, and then I'm working in palliative also. So many patients at the end of their lives, it's advisable, to remove the device or switch it off. And in case there is some mishap, like you talked about cardiac arrest, the patient dies, then how do you dispose of these devices? Because that is also important, because at the end of life, especially, that the patient may get cardiac shocks, painful, which can be very painful. So how does one dispose of? And in fact, the patients and the family members should be informed about a few details about the pacemakers in such an eventuality.
That's a very wonderful question. I don't think this question would have arisen in the minds of many people, but yes, it's a practical situation that we feel that we come across often. And what we do in our ICU is, if we have a patient who's died and who was end stage, then we usually we ask for a cardiologist who comes and removes those devices, because that is what we do in our setup. And it is very important to remove any kind of devices. So all the central venous lines, the catheters, the arterial catheters removed by our nursing staff, and these implantable devices such as pacemakers or ICDs, we take the help of a cardiologist who come and remove it themselves.
Thank you. Thank you very much.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Okay. Thank you so much, Bimla ma'am and Bimi ma'am, for your valuable insights, for your valuable inputs. And it's always great to have you like stalwarts, and you all are like big inspiration to us. Thank you so much, ma'am, for your presence and for your
Thank
time.
you. Thank you for having me. Thank you, Dr. Sharma. Thank you.
We will break for lunch, and so that like we don't lag in time, we will come back at 2:10 p.m. itself, which is the stipulated time. So a lunch break of only 10 minutes, and we will be back by 2:10. Huh? Mr. Sudeep, can you please display the MCQs?
Yes, madam.
Yeah, please. So as we said, we witnessed some really very good lectures on actually very tectonic topics, which are difficult to understand. And I hope all the delegates who have attended these lectures, they have gained immensely. They would have understood how to, give their long case, short case presentations, and the topics, especially on ICD, on congenital heart diseases. They are really very difficult to understand, very vast topics. So I hope now they'll be really very easy for you to understand and pour out in your examinations. So the first question is, what is the most important consideration in anesthesia management for a 48-year-old female with chronic hypertension undergoing modified radical mastectomy? It's A, fluid balance and maintenance; B, blood pressure control and anesthetic drug choice; C, pain management and sedation; and D is risk of post-operative nausea and vomiting. The second question is, a 65-year-old male with a history of severe aortic stenosis is scheduled for an elective inguinal hernia repair under general anesthesia. His echocardiogram shows a valve area of 0.8 centimeter square and a mean gradient of 50 millimeter of mercury. Which of the following anesthetic goals is most appropriate for this patient? It is A, maintain high heart rate and low systemic vascular resistance; B, avoid preloading the left ventricle and maintain tachycardia; C is maintain normal sinus rhythm and avoid hypotension; D is use a spinal anesthesia to avoid myocardial depression. So we'll be waiting for your answers, and the correct answer will be told after the lunch. So be quick, kindly join back by 2:10 p.m. Thank you so much. We'll start at 2:10, ma'am. Thank you, ma'am. So we are back from a lunch break. I hope you all could have a sumptuous lunch in between. Mr. Sudhir, could you please display the questions once more? Mr. Sudhir, could you please display the questions? Yes. Please, it's not getting displayed. Can't see.
Yes, ma'am. Yes.
Yeah. So the first question was, what is the most important consideration in anesthesia management of 48-year-old female with chronic hypertension undergoing modified radical mastectomy? And no marks for that, but the answer we all know, it's blood pressure control and anesthetic drug choice. So the second question was, a 65-year-old male with a history of severe aortic stenosis is scheduled for an elective inguinal hernia repair under general anesthesia. His echocardiogram shows a valve area of 0.8 centimeters square and a mean gradient of 50 millimeter of mercury. Which of the following anesthetic dose is most appropriate for this patient? As ma'am had rightly pointed out in a lecture, for any stenotic lesion, we should maintain normal sinus rhythm and avoid hypotension. So it's C over here. Thank you so much. Now proceeding ahead with our next topic, I would invite Dr. Sanjula Veermani ma'am and Dr. Manjula Sarkar ma'am. Good afternoon, ma'am. So Dr. Sanjula Veermani ma'am, she will be moderating our session on CABG with or without bypass. Ma'am is Director, Professor and Head in the Department of Cardiac Anesthesia, JIPMER, New Delhi. She has more than 50 publications in national and international journals. She is in the editorial board of various national and international journals, and she is ex-editorial assistant in Annals of Cardiac Anesthesia. Ma'am's special area of interest is cardiac anesthesia. And I would always say that my interest in cardiac anesthesia had been possible because I have worked under ma'am. And ma'am is a superb teacher. Thank you, ma'am. Thank you, ma'am, for being here.
Thank you,
Ma'am,
Itishri. Thank you for the nice, kind words. Dr. Manjula has joined. Hi, Dr.
Yes,
Manjula. How are you? Dr. Manjula?
Ma'am, who is there?
Acha, this will be recorded. Okay.
Yes, ma'am. This will be a recorded lecture.
Okay, fine.
I thank the organizers for giving this opportunity to me to speak on this prestigious PG assembly. And the topic allotted to me is anesthesia for coronary artery bypass grafting on pump and off pump. Cardiac surgery is a dangerous and complex field of medicine with lots of morbidity and mortality. Quality anesthetic care with a specific attention to detail can greatly enhance the patient's safety and outcome. Details that are ignored can lead to disaster, so we have to be very, very careful. We should be knowledgeable, we should expect the disasters, and we should know how the cardiac events or adverse cardiac events can be taken care. If we look for the history, in 1951, Wenberg implanted the lima into the myocardium. That was the first time it got implanted. The first successful op-cap was performed in 1961. The Kolisov in 1964 performed the first successful anastomosis of the left internal memory artery to left anterior ascending artery. In 1961, Fevelov and Effer performed the reverse saphenous vein grafting, and in 1990, concept of fast tech of cardiac anesthesia has came into the picture focusing on early extubation, early mobilization, and early ambulation. The recent concept is ultra-faster cardiac anesthesia, extubation within 2 hours of the surgery. So if we look for the history, the cardiac surgery and cardiac anesthesia has gained the advanced popularity and good management in the recent years only, after the 1990, we can say like this. If we look for the indications for coronary artery bypass grafting, it is performed for both symptomatic and prognostic reasons. Indications are classified by the American College of Cardiology and the American Heart Association according to the level of evidence supporting the usefulness and efficacy of the procedure class 1 and class 3. Left main coronary artery stenosis, more than 50%. Stenosis of the proximal LAD and proximal circumference, more than 70%. 3 vessel disease, 1 or 2 vessel disease, and large area of viable myocardium. In high-risk areas in patients with stable angina, also the one of the indication. More than 70% proximal LAD stenosis with either ejection fraction of less than 50% or demonstrable ischemia are non-invasive testing. Disabling angina, ongoing ischemia, poor LV function, but with viable or non-functioning myocardium above the anatomical defect can be reversal and should be taken for the surgery. MI in cases where percutaneous coronary interventions is not possible to perform, PCI has failed, or there is persistent pain and ischemia threatening to the significant area of the myocardium, devascularization. Contraindications, very small arteries, calcified arteries, poor conduits, huge hearts, hemodynamic instability, and cardiogenic shocks. Asymptomatic patients who are at the low risk of MI or death, who will experience little benefit from coronary revascularization. Elderly age, not really contraindicated, but short life expectancy, more likely to experience perioperative complication, should be weighed and decide accordingly. Preoperative preparation should include the proper history, examination, investigations, pre-medications, and monitoring. Induction goals are avoid undue hypotension, attenuate hemodynamic response to laryngoscopy and intubation, fall in blood pressure more than 20% of the baseline needs use inotropic supports, selected agent, small incremental doses, and titrate it first against loss of consciousness, then to an acceptable fall in blood pressure. Muscle relaxation, control ventilation, adequate oxygenation, prevent the hypertension and problems. High-dose narcotics are the type of induction which are commonly used and most popular also. Fentanyl 5 to 10 microgram per kg produce prolonged postoperative respiratory depression, high incidence of awareness, rigidity, fail to control hypertensive response to stimulation has to be taken into consideration. Tiva infusion of propofol 0.5 to 1.5 milligram per kg, remifentanil 1 microgram per kg bolus. Total dose of fentanyl should be 5 to 7 microgram per kg can be taken for the induction. Use of short-acting agents results in early extubation and lesser hospital stay. Drugs are costlier and remifentanil should be supplemented by morphine at the end of the postoperative pain relief if the availability of morphine is there in your institutes. Mixed IV, midazolam, propofol. Opioids are given intermittently and total dose of fentanyl and remifentanil should not exceed 15 and 5 microgram per kg respectively for taking care of the patients in view of fast-track anesthesia management. Inhalational volatile agents for maintenance of anesthesia and sympathetic response suppression, isoflurane, sevoflurane, desflurane are used for the maintenance. It results in easy control of depth of anesthesia and hemodynamics, stability, and early extubation. Others, in frail patients, combination of ketamine and midas provide hemodynamic stability, good amnesia, analgesia, and minimum respiratory depression. This is the picture showing the cardiopulmonary bypass machine, which is having the cardiopulmonary bypass pumps, oxygenator, heating machine, and roller pumps. The basic CP bypass circuits include tubing cannulas that drain venous and return arterial blood to the patient, oxygenator which take care of the gas exchange, and mechanical pump that provide the systemic oxygenation. Basic CP bypass circuit. Priming is must. Priming prior to use CP bypass circuit must be primed with fluid, should be devoid of bubbles, microemboli. Fluid which are used for the priming are balanced salt solution, ringolactate, other fluids, albumin, mannitol, electrolyte, and heparin. Prime volume standard versus minimum on an average 1500 ml is the priming solution we are using it. Blood to prevent excessive dilutional anemia and decrease in oxygen carrying capacity. Children, small adults and patients with the already existing anemia should be taken care with the blood. Reservoir receives the blood from patient via one or the other venous cannula placed in the right atrium or the SVC, IVC or the femoral vein. Oxygenator, artificial lungs. Modern machines have membrane oxygenator, prevent destructive blood gas interference. So these are the different kind of the oxygenators which we are using it. Bubble oxygenator, membrane oxygenator, and perimembrane oxygenator. Basic CP bypass circuit, heat exchanger is also there, which counter current cooled or the warm, and heat transfer occur by the conduction method. So this is the patient and this is the oxygen, heat exchanger, roller pumps, arterial line, coronary suction, reservoir, and auxiliary filters. Pump are the artificial hearts, double-armed roller centrifugal pumps. One major difference between roller head and centrifugal pump is that flow from centrifugal pumps will vary with changes in the pump preload and afterload. So these are the two pumps which we are using it commonly, centrifugal pump and the roller pumps. Arterial filter. Particulate matter may enter into the cardiotomy section, so which has to be taken care by the arterial filter. Final filter reduces the systemic emboli. Filter is always in parallel with the bypass. Limb increased filter becomes clogs and develop the increased resistance. Cardiotomy suction is the aspirate blood from the surgical field during CP bypass machine and return it directly to the main pump. Potential part of the entry for the fat and other debris is not there. So accessory pumps are used for this reason. Accessory pumps and device, left ventricular vent. With time, blood reaccumulates in the left ventricle, residual pulmonary blood from bronchial arteries, decompress the left ventricle and aspirate air from the heart during de-airing procedures, prevent ventricular distension that may lead to myocardial infarction and is particularly important in patients with aortic insufficiency. Site by a left superior pulmonary vein, aortic root, LA or LV. Cardioplegic pumps, procedure to produce asystole by infusing cold cardioplegic solution into coronary arteries, protects myocardium from damage into ischemia, concept increased potassium, extracellularly reduced transmembrane potassium, cardiac arrest during diastole. Contents of the cardioplegic solution are potassium, sodium, calcium, magnesium, buffers bicarbonate, hypertonic agents, mannitol, lignocaine or glucocorticoids, glucose, vehicle solution, cardioplasia administration, retrograde, anterograde, or both combined retrograde and anterograde. Continuous warm cardioplegia solutions can also be used depending on the need of the patient. And these are the different functions which all the contents are doing it when we are using the cardioplegia solution. Management of CP bypass, pre-CP bypass checklist. Anticoagulation with heparin. Check ACT, goal should more than 450. Supplemental meditation, neuromuscular blockage, anesthetic, analgesic, anesthetics, anesthetics, pulmonary artery catheter drawn back 3 to 5. Pulmonary artery injury during heart manipulations by the surgeons, absence of the bubbles, arterial line, all monitoring access catheters should be taken into care. Anticoagulation administered before initiation of CP bypass machine to prevent DIC and formation of the clots in the pump, dose 300 to 400 units per kg body weight. Administer in reliable line. Some surgeons administer themselves in the right atrium. Activated clotting time should be more than 400. Major ACT after 3 to 4 minutes. ACT should be less than 400. Additional 100 units of the heparin should be given. Heparin resistance may be there, so antithrombin 3 deficiency overcome by administering antithrombin 3 infusion or FFP milder form increase heparin dose. Patients with HIT, if it is remote and no antibodies detected, can safely administer alternative hirudin, bivalirudin, anacroid or eroven. Protamine heparin reverse with no longer needed for CP bypass. Reverse by protamine dose is 0.6 to 1.3 milligram per kg per 100 units of the heparin. Taste dose of 10 to 20 milligram over 60 minutes before full dose. Cannulation, arterial ascending aorta, femoral or axillary artery, venous, RA, IVC or SVC. Responsibility of anesthesiologist during aortic cannulation, limit systemic blood pressure 100 millimeter of mercury, maintain the mean blood pressure 60 millimeter of mercury, increasing the inhaled anesthetic agents or vasodilators. After aortic cannulation, pressure is raised back. Venous cannulation has the minimum risk. Retrograde autologous blood transfusion can also be done in these cases. Bypass period. Loss of arterial pulsatile waveform taken off for the perfusionist. Main concern for anesthesiologists to maintain the cerebral perfusion. Default systemic perfusion aim mean pressure should be maintained between 50 to 160 millimeter is a commonly acceptable range. Insulin administration for the random blood sugar if it is more than 200. Weaning from bypass, close communication amongst the team, temperature should be normal, hemoglobin should be more than 7, infusion if inotropic supports are needed, electrolyte should be maintained well, ventilation should be good, ECG placed at 90, and special consideration for effectiveness of the valve repair should be taken into consideration. CP bypass effects, physiological and pharmacological. If we look for the physiological effects, stress response, catecholamine, cortisol, arginine, vasopressin, and angiotensin, others humoral system, released when blood contact with the internal surface of CP bypass, free radical systemic inflammatory response should be taken into care and should be taken into consideration, and treatment should be done for that. Physiological modulators, leukocytes, ultrafiltration, high-dose vitamin C, systemic steroids, aprotinin can be used as and when needed. Plasma and serum concentration of most water-soluble drugs accurately decreased the onset of CP bypass time. Lipid-soluble drugs has minimal effect. Effect of CP bypass are complex, sudden increase in volume of distribution and hemodilution, decreased protein binding, example heparin, change in perfusion and redistribution, reduced elimination, reduced VF to liver and kidney, and reduce the metabolic acidosis. Off-pump CABG, avoid cannulation, cross-clamping, systemic inflammatory response, coagulation disorders, and multiple organ dysfunction. Op-cap techniques, minimally invasive direct access coronary artery bypass, mini thoracotomy, anteriorly located single or two vessel surgery, example anastomosing Lima to anterior descending coronary artery or to reduce the severe postoperative pain. Off-pump coronary artery bypass grafting, median sternotomy or multi-vessel grafting. Contraindications for op-cup surgery, intracavitary thrombi, malignant ventricular arrhythmias, deep intramyocardial vessel, and procedure combined with valve replacement or ventricular aneurysm. Problems associated with op-caps are obtaining adequate exposure of the anastomosing site during cardiac monitoring, hemodynamic alterations with cardiac manipulations, increased arterial size, pressure, marked decrease in the cardiac output, reduced mixed venous saturation, and ventral position of the heart, diastole, valvular annuli. Mitral, tricuspid, aortic valve involved, and AV annulus significant stenosis. Anticoagulation in op-cap surgery, ACT 250 to 350, not required more than 400, lower than CP bypass, no contact with foreign surface. Intraoperative complications expected are hypertension, malignant hypertension, should be treated with the volume, Adequate heart rate and sinus rhythm should be maintained. Increased afterload and maintain the systemic perfusion pressure. Inotropic therapy, phenylephrine, informed surgeon, resting heart in pericardial cavity. And if no improvement, then take care accordingly. IBP can also be used. Arrhythmias, treat the arrhythmias by the antiarrhythmic drugs. Commonly used drugs are lidocaine infusions. Electrolyte imbalance should be taken into consideration, and temperature correction is must. Hypothermia, warm blankets cover. OT room temperature should be maintained. The time taken for sterile preparations should be kept in the minimum. Warm IV fluids and low fresh gas flow. Myocardial ischemia, prevention, maintaining the systemic blood pressure near normal, keeping MAP of at least 70, reduction in the myocardial consumption by avoiding tachycardia. Ischemia during diastole and anastomosis can be prevented by using interluminal coronary shunts. Hemodynamic changes related to heart position, lifting and rotating the heart during OPCAP, changes in the CO, SV, LEDP, RAP. During grafting of right coronary artery bradycardia, reduction in blood supply to the sinus and AV nodes. If required, use atropine and atrial patient. Monitoring, post-operative period, 5-lead ECG monitoring is must. For any fresh gas changes like ischemia or MI, treat with low molecular weight heparin, antiplatelet medications, insertion of an intra-aortic balloon, or reversal of the grafting. Continuous monitoring of SpO2, EtCO2 temperature, and ABG is must in all these cases. Regarding pain management is concerned, epidural analgesia, bupivacaine with fentanyl can be used safely. Intravenous opioids can also be given. Fentanyl patches can also be used. And it is better to use multimodal analgesia to avoid the toxicity of the single drug. ICU management, ventilation, FiO2, tidal volume, respiratory rate, IE ratio, control mode of ventilation, ABG performance after minutes, FiO2 should be taken into consideration for maintaining the patient's ventilation. Blood loss, if the blood loss is in acceptable limits, less than 10%, it's all right. If it is more, then replace the blood. Core temperature should be maintained. Arrhythmia should be taken into consideration. Residual neuromuscular blockage should be taken into consideration. After confirming adequacy of reversal, ventilatory modes is switched off to spontaneous ventilation and give the supportive ventilation as and when required. Fast track anesthesia is gaining the popularity. Everybody wants to be fully conscious after the surgery, immediately after the surgery. Patient wants to do the early mobilization. Surgeon wants to do the early mobilization. So we can prevent many complications. So fast track anesthesia defined as a tracheal extubation within 6 hours of the cardiac surgery, early mobilization of the patient, and early discharge from the hospital is the basic aim, a basic goal. Use of the short-acting opioid medications, long-acting sedatives should be avoided. Early extubation resulted in regaining the cough reflex and thus a lower incidence of atelectasis and pneumonia and respiratory problem. Patients are not suitable for bleeding, dysarrhythmias, and hemodynamic stability, then should be taken into consideration for fast-track anesthesia. So after all this discussion, I would like to conclude, CBG surgeries are need of an hour. Many patients are coming with the ischemic incidences. Knowledge, advanced monitoring, newer drugs, skilled surgeons, and better infrastructure leads to the better outcome. Selection of the patient and preparation of the patients help in managing these cases and giving us the better outcome and results. So I'm sure that after attending this lecture, your mind is clear that you can deal with the coronary artery bypass graft patients without any hitch and hesitations. And in case if you have any doubt regarding anything, you can contact me on my mobile or on my email address. Thank you very much for your patience hearing.
Thank you, Dr. Manjula. It is a very nice, excellent, lucid lecture, and you've covered starting right from history, then about both on pump, off pump, and right up to pain management, ICU management, and even fast tracking. So I really kudos to your lecture. You're a very familiar face in the ICTA conferences, and it's nice that the students have benefited from your knowledge of everything, and now the PG students also. And this lecture was, I think, enough for the level of the PG students. Questions and all are not asked, no? I just want to say that the difference between on pump and off pump is that people are nowadays going more for off pump surgery, but it has its own disadvantages because the geometric aberration that we cause because we are not going on pump, we are not resting the heart. Then in that case, sometimes there is under perfusion or under correction of the various coronary arteries which are involved. And the expertise is needed by the surgeon, and a very expert anesthetist is needed for doing off pump. Whereas on pump, you can just like the patient will be on bypass, and you can either give the cardioplegia like with complete arrest, or even on the beating heart, you can do the bypass surgery. So I think anything else, Itishi, you would like to add?
No, ma'am, I can only say one thing, that it is really very inspirational and very imbuing to all of us when we see that stalwarts of anesthesia like you and ma'am are there teaching us, enriching our knowledge. And I would say all the delegates that those who have been attending this lecture, they have really, benefited the most, that ma'am had given her lecture and you were here to support us, ma'am. Thank you so
So
much.
the bottom line for the take-home message for the students would be that any patient of CAD, what you have to reduce the myocardial oxygen demand while maintaining the cardiac output. So when you're looking after the myocardium, the supply and the demand, that is the basic balance that you have to maintain. So whether you do it on bypass or off bypass, you have to maintain the cardiac output, maintain heart rate, but reduce the myocardial oxygen demand, and so on and so forth. So that is how one has to manage patients who are CAD, because they will also have other problems. Comorbidities are really great. So all that also has to be taken into account. Most of them will be diabetics, hypertensives. So a good preoperative assessment and optimizing their condition as far as possible, and then taking up the patient, I think, will benefit both from anesthesia point of view as well as for the patient also.
Can I say something?
Yeah, yes,
Am I
ma'am,
audible?
please. Yes,
Yes,
ma'am.
ma'am.
Yes, ma'am.
Okay, fine. Thanks, Anchula, for giving this conclusive remark for this lecture. And nice to see you on the screen. Physically,
Yeah,
we
it
can't
is.
see, but on the screen we can see. And and I know there are many surgeons till today's date, they prefer to do the CABG on pump.
Yes.
They feel more comfortable,
Yeah.
and not only for the skills in relation to the surgical techniques are concerned, but they say that the heart gets enough rest and they are really getting benefit on the CP bypass. But it's always, it has to be decided by the surgeon that what are the pros and cons. But for anesthesia considerations, I will say on an average, the requirements are same. The decision making makes a difference, and on pump is all right, but off pump, you have to be really careful. And many times we have to convert the off pump into on pump. Today only I have converted one patient because ejection fraction was 20% and the patient was not maintaining. So they have to go on pump and do the surgery. So both are good, and it depends on the need of that movement, what we have to do. So anesthesia considerations has to be taken into consideration. Thanks a lot. Thanks a lot for the opportunity.
Thank you so much, Itishi. Thanks for all
Thank you, ma'am. Thanks a lot, ma'am.
And Manjula, see you sometime soon in one of the cardiac conferences.
Yeah. Yes,
And
yes,
we'll
sir.
meet again. Yeah.
Thank you, ma'am. So as we saw that it's like depending upon the case, we have to decide, and as well as the surgeon has to decide whether we want to go on pump or off pump. They both have their advantages and disadvantages. And as ma'am said, it is actually maintaining the oxygen balance, I should say, or we have to reduce the oxygen demand so that we have a good outcome for the patient who are undergoing CABGs. Thank you so much, ma'am, for the insights. And
Thank you so much.
now we'll move ahead. Thank you, ma'am. We'll
Thank you.
move
Thank you,
ahead
Tishi.
with the
Thank you.
next leg. Yes, ma'am. Thank you, ma'am.
Thank you. Thank you.
So we'll move ahead, and now we have a long case presentation with us. And it is also, again, a very important topic, a topic which we always have a dilemma when we are facing there in our, in our day-to-day practice. And the long case is on women, 50-year-old female posted for incisional hernia repair with a history of PTCA 6 months back. And for this, I would invite Dr. Maitri Pandey, ma'am. Ma'am is Director Professor and former HOD in the Department of Anesthesiology in Lady Hardinge Medical College, New Delhi. Currently, we are blessed to have ma'am with us in our own institute. She is past president ISA Delhi branch. She is fellow Indian College of Anesthesiologists. She has several publications in national and international journals and many chapters in the anesthesia and critical care books. She has conceptualized and implemented workshops for mastering table viva voce and mock exams for final year PG students. Ma'am's areas of interest are obstetrics, critical care, simulation, cardiac resuscitation, and pediatric ARV. We welcome you, ma'am, and we look forward to your valuable insights in the Appec 2025. Thank you, ma'am. Natri, ma'am. Ma'am is there. And presenting the case, we have Dr. S. Vignesh, who's our postgraduate third year student, and our SR, Dr. Shreya Garg, senior resident, Dr. Shreya Garg. Ma'am is just joining.
Good afternoon, everyone. So today we'll be discussing about a patient with IHD with stent, and it is not possible to discuss each and everything about it in 1 hour. So we will try to cover most of the things, and you listen carefully. If any question is there, you can ask in the end. So Dr. Vignesh, please start the case.
Yes, ma'am.
Am I audible?
Yes, ma'am.
So be loud and clear, please.
I'm a 59-year-old male. He's a resident of Mayapuri. He's a security guard by occupation, belonging to social economic status of upper lower class. As came to hospital with chief complaints of increasing of swelling around the umbilicus since 2 years. And a history of presenting illness. Patient was apparently well 2 years back. Then he noticed a swelling from the incisional site over the umbilicus. Initially, it was a size of a pea, then gradually increased to the present size of a carom coin. Swelling increases in size while coughing, straining, on walking, and lifting heavy objects, but decreases on rest and in lying down position. No history of chronic cough. Swelling is not associated with pain, fever, vomiting, constipation, or diarrhea. Not associated with discharge from the swelling and skin changes. Past history, patient is a known case of hypertension for 3 years and on regular medications. The patient had an episode of severe chest pain 1 year back, which was radiating to left shoulder and lasted for more than 30 minutes. Following that, he was hospitalized. A diagnosis of coronary artery disease was made. Intervention was done through inguinal hernia and inguinal area and was informed that stent was placed. As per the documents, angioplasty showed 80% blockage of left anterior descending artery
PTCA to LAD was done with drug-eluting scan. No fresh complaints of chest pain, palpitation, syncope, breathlessness on exertion, or breathlessness on lying down, or swelling in legs is observed after the intervention. No history of weakness in limbs. No
Just a minute. Just a minute, Vignesh. Just a minute. So why have you taken complaints of palpitation and syncope? You are saying that you have taken. There's no history, no. Is it important?
Yes, ma'am.
Is the negative history important of palpitation and syncope?
Yes, ma'am. Palpitation signifies the presence of arrhythmias, ma'am.
Okay. And syncope?
And syncope.
Syncope is because cerebrovascular disease may be associated. So you are ruling. Okay.
Yes.
Continue.
And no history of weakness in limbs. No history of any other chronic illness or any other comorbidities. No history of diabetes mellitus, tuberculosis, jaundice, seizure, or thyroid disease. The patient had undergone laparoscopy, cholecystectomy under general anesthesia 8 years back. It went uneventful. No history of any known allergy. Treatment history. The patient is on tablet enalapril 5 mg OD, tablet metoprolol 25 mg BD, tablet aspirin 75 mg OD, tablet clopidogrel 75 mg OD, tablet atorvastatin 40 mg OD, and he's taking tablet sorbitrate 5 mg sublingual on as well. Personal history is
Okay, so Vignesh, what? Continue.
He's a security guard.
Continue.
Security guard by occupation. So he's taking vegetarian diet, non-smoker and non-alcoholic. Bowel and bladder habits are normal. Patient can do the household activities without any breathlessness. Socio-economic status, he belongs to upper lower class according to modified Kupuswamy scale. And family history, his father died due to some heart-related ailment 5 years back. No history of any known comorbidities in the family. And coming to general.
So what, any other history you want to elicit? Vignesh, any other history you want to elicit in this patient?
Any other history? History.
So you should always ask any history of paroxysmal nocturnal dyspnea or orthopnea.
Yes,
okay. So it will tell you about the ventricular function.
Yes.
Okay. Though he may not be having it, but negative history is also important.
Yes.
Okay. Continue.
On general physical examination, patient is conscious oriented to time, place, and person. And weight is around 68 kgs, height 165 centimeters, BMI is 24.5 kilogram per meter square. No palarectus, cyanosis, clubbing, lymphadenopathy, or edema stated. Was afebrile to touch, and meds is more than 4.
Okay.
Vitals.
Continue.
Pulse rate
So
72.
he is having all the vitals are within normal limits. Okay.
Yes. Yes.
So you go to the next slide. Any other problem with the patient?
Any other on abdominal examination?
Vignesh?
Yes, ma'am.
You put the slide.
On abdominal examination, the patient had
continue.
2 linear scars of length 1 centimeter, each seen in a right hypochondrial and epigastric region, and a swelling is noted of size 5 cross 5 centimeter over the umbilicus. A scar is also noted over the swelling. There is no visible peristalsis or pulsation seen over the swelling. There is no ulceration or skin changes seen over the swelling. On palpation, all the inspectory findings are confirmed on palpation.
Okay.
Afebrile to touch, and swelling is reducible. No guarding rigidity present. Expansile cough test was positive. On percussion, dull note on percussion over the swelling was noted. On auscultation, no peristalsis sound was heard over the swelling.
Okay. What else? What you want to see particularly when you are examining the cardiovascular system?
While examining
in this patient, is there any finding in the cardiovascular system?
No, ma'am. Within normal limits.
There's no finding.
Yes,
but would you like to look for something? It is of importance to you?
Yes, ma'am. I will like to know about JVP, ma'am, in case of to rule out heart failure, ma'am, and
Yes, left-sided heart failure, JVP or pedal edema, history of it may be there also. And what else? On auscultation, what do you like to see? You need to rule out. You need to rule out fine crepes or rails, okay, and S3 gallop.
yes, ma'am.
So it will indicate left heart failure. Okay. So these things you have to be very particular when you are examining these patients, even though patient may not give history of all these things. Okay.
Yes, ma'am.
So okay, continue.
On cardiovascular system, on inspection, chest wall was bilateral, symmetrical in shape, no visible swelling, scar, pulsation.
No, any significant finding? Do you need not read this? Any significant finding in cardiovascular system?
No, ma'am, no significant finding.
Continue.
Respiratory system, ma'am, bedside PFT was done with breath holding time of 30 seconds observed, ma'am, and rest of the respiratory time within normal.
So what does it mean? The breath holding time is 30 seconds.
The patient has adequate cardiopulmonary reserve, ma'am, to undergo.
It has a good cardiopulmonary reserve. Okay. Next.
And the CNS examination is within normal limits, ma'am. Examination of spine is normal.
Okay. So what is the summary? Finished with the case?
Yes,
You have to be fast, Vignesh, otherwise we'll...
59-year-old male with a known case of coronary artery disease, post PTCA, 1 year back on DAPT and hypertension on medications, diagnosed with incisional hernia, posted for laparoscopic herniaplasty under ASA class 2.
Okay, so this patient has come to you to the pre-anesthetic checkup clinic.
Yes, ma'am.
And what investigations you would like to order, you would like to see?
Yes, ma'am. First, I will ask for complete blood count, ma'am, to know about hemoglobin, TLC count, and platelet count, ma'am. And I would like to know, since the patient is
okay. Yes.
Since the patient is
So
on,
what are the recommendations regarding the hemoglobin in patients of CAD, coronary artery disease? Is there any recommendation?
Yes, ma'am. Hemoglobin should be minimum 10 gram per deciliter, ma'am. And
minimum should be 10 gram per deciliter. If the patient is anemic, then if it is more than 10 gram per deciliter, then they do not need blood transfusion. Okay.
Yes.
And in patients of CAD, if it is more than 8 gram per deciliter, then you do not, blood transfusion is not required. Okay.
Yes. And I would like to get the TLC to rule out any infection, ma'am. Because infection can cause tachycardia, which is detrimental in
this patients. Okay. What else? What else?
Platelet, since the patient is on DAPT, ma'am, I would like to, if available, I would like to know about the function of a platelet, ma'am, by using TEG or ROTA, ma'am.
If it is available. If it is available. Okay. What else?
And the KFT, ma'am, since the patient is on AC inhibitor, which might increase serum creat levels, ma'am, I would like to get a KFT done, ma'am, and the serum electrolyte, since it causes potassium retention. LFT for baseline levels.
Next.
And random blood sugar to
rule. If for baseline you want to see.
Yes, ma'am.
Any okay, blood sugar, increased blood levels. Yes. What else?
And I will get a chest X-ray done, ma'am.
What else?
And 12 lead ECG, ma'am. To get the baseline ECG changes.
12 lead ECG, okay. So what will ECG show? Is chest X-ray absolutely mandatory in this patient?
Chest X-ray? No, ma'am.
It may not be, but in patients, if the history of any tuberculosis or any chest infection, then you can do it. Okay, yes. So what will ECG, what do you want to know by seeing the ECG?
Ma'am, I will get to know about the old ECG changes, ma'am. So I can get a baseline ECG of the patient. So, and presence of any bundle branch blocks in this patient.
Bundle branch block. Why bundle branch block? You want to look at the STT changes are there or not, any, you know. So whatever changes which are present before when he presented with acute coronary syndrome, are there, it is resolved or it is there, or any signs of old infarction like Q waves are there or not? You will know in the ECG. So what are the recommendations for ECG? Doing ECG in non-cardiac surgery patients with coming from with ISD with stent.
Recommendation.
So if it is an yes, can you tell me AHA recommendations?
If the patient, since the patient is a known case of CAD, ma'am.
So if there is no history of any changing symptoms like new onset dyspnea or arrhythmias or any blocks, so you did not do it in these patients because there's no new symptoms, and that too for a low risk surgery it is not required. Okay, for non-cardiac surgeries with elevated risks with history of the decompensated heart failure, arrhythmias and all, you need to do it. Okay.
Yes.
So in this, if there is a previous ECG present and he is not complaining of fresh complaints, then we can be good with the previous ECG. Okay.
Yes.
So is it important to stratify the risk in this patient? Would you like to know about the functional capacity? How will you know about the functional capacity of this patient?
Ma'am,
is it important to know?
It is important to know, ma'am, for this stratification. And I will first assess the meds of the patient. If meds is
so it is more than 4. Okay.
Yes.
So it is more. It is a good functional capacity.
Yes, ma'am.
Any other test can be done for functional capacity?
Yes, ma'am.
Any other? This is a subjective.
Yes, ma'am. Ma'am, we can.
Any better way of knowing the functional capacity?
Indexes like DASI, ma'am, Duke's Activity Status Index can be used, ma'am, and cardiac exercise testing can also be for high risk cases.
Okay. For high risk cases, okay. So in whom the meds is not very much, they are not very able to tell about meds, or you are not sure about the functional status, then you can do this. This is it is also a self-reporting test, and it has got 12 points, and if it is more than 34, then it is a good functional status. Okay. So this is a semi-quantitative test, better than meds. Okay. So and what other, how do you stratify risk in these patients? You would like to know, you will like to explain the family members of the patient that how much risk is there for doing the surgery in these patients? How will you stratify risk?
For that, I will use RCRI, revised cardiac risk index.
Okay.
Of 6 parameters, ma'am. Can I explain the parameters? Ma'am, the patient
go ahead.
History of CAD, congestive heart failure, and history of TIA or stroke, and history of diabetes mellitus on insulin, and a history of and the patient has serum creatinine more than 2, ma'am. And along with that, high risk, if the patient has high risk surgery like intraperitoneal, intrathoracic, or suprainguinal vascular surgeries.
Elevated risk surgery. Okay.
Yes.
Okay. So all these things will tell you that the patient is high risk. So you have to tell the patients that the risk is high. Okay. So there are certain risk calculators. RCRI is one of them, and other risk calculators are there which will tell you about the risk, and it is an objective method of knowing it.
Yes, ma'am.
So in our anesthesia, how we classify risk, how we stratify our patients at risk? Most commonly, which we are using today's surgeries. ASA classification. Okay. ASA classification. Okay. So now this patient, when you calculate the risk, how much will it come? RCRI, how much is this in this patient?
This patient has.
You have to be fast, Vignesh. We are losing time.
The patient has history of CAD, ma'am, and if the serum creat level is more, and the patient might go into RCA 2.
So suppose it is all right, so it is low risk.
Low risk.
It is 1. Okay, 1 because we are not doing elevated risk and no diabetes, no history of diabetes, no renal dysfunction. So we take 1. So 1 is low risk, and 2 and more than 2 is high elevated risk. Okay, so this patient comes under low risk.
Yes.
Then how will you plan the anesthesia? What pre-op orders will you give?
I will.
Now you have
my-
done all the tests, you know it is a low risk, है ना? Okay, so
and I will keep the patient NPO, ma'am, for 2 hours for clear liquids and 6 hours for light meal and 8 hours for heavy meals, ma'am. I will explain the risk involved in the surgery, ma'am, about the major adverse cardiac events that could happen and get a high risk consent, ma'am.
So the chances with RCRI 1 and is less than 1%. It may occur, but it's less than 1%. Okay, it is a low risk surgery. So you will explain the risk. You will take anilporolori. What about the drugs? Any anti-anxiety drugs you want to give?
Yes, ma'am. I would like to give a tablet alprazolam, ma'am, 0.5 mg on the night before surgery and 2 hours before surgery, ma'am. And I will ask him to continue the medications he's taking, beta blockers he's taking, ma'am, and ACI inhibitors and statins.
So how is beta blocker important in these patients? How is beta blocker important in IHD patients? Is it important?
Yes, it is important, ma'am, because it has multiple roles like anti-arrhythmogenic, ma'am, anti-hypertensive, ma'am, and it reduces myocardial contractility and reduces preload and afterload, ma'am. So and reduces heart attack.
It decreases the heart rate, it decreases the contractility, okay?
Yes, ma'am.
And in this way, it decreases the oxygen demand. So it is good to have these in the patients. And what are the recommendations of continuing this beta blockers in the perioperative period?
It's
AHA recommendations?
It recommends as a class 1 recommendation, ma'am, to continue in perioperative period, ma'am, for beta blockers.
Continue, okay, perioperative period. And what are, how if suppose you think that the patient is not taking and you think it will be beneficial, can you start it on the day of surgery?
No, ma'am, I require minimum of 2 to 7 days, ma'am, for the patient to be on beta blocker, ma'am. I should not
At least 7 days.
Yes,
7 days is required to start it, and it should not be started on the day of surgery. It produces more harm than good.
Yes.
Okay. So what are the other drugs which the patient is taking?
The patient
Patient is taking ACE inhibitors.
Ma'am, I will ask him to continue AC inhibitors, ma'am. Since the surgery, we are not expecting major blood loss or major fluid shift. I will ask him to continue. And
Yeah, you ask him to continue it, okay?
And statins, I will ask him to continue throughout the perioperative period, ma'am. And regarding dual antiplatelet.
So it is also a class 1 recommendation.
Yes, ma'am, class 1 recommendation. And regarding dual antiplatelets, I will ask him to continue aspirin, ma'am, throughout the perioperative period, ma'am. And I'll ask
aspirin. You can.
Yes, ma'am.
Okay.
And I will ask to stop clopidogrel 5 to 7 days before the day of surgery, ma'am.
Okay. Suppose the time period was only 6 months, more than 6 months. Then what would you have done?
Ma'am,
this is an elective surgery.
I will first assess the risk.
What are the recommendations?
Yes, ma'am. I will first assess the risk for thrombosis and bleeding in the surgery he is going to get done, ma'am. If there is more chance of thrombosis, I will ask him to continue DAPT, ma'am.
No, you're getting confused. We are talking about this patient, and in this patient, it is a low risk and elective surgery. So if it is less than, it was an acute coronary syndrome. If it is less than 12 months, then what we do, ideally in these patients, you can wait for 12 months because the surgery is not urgent. This is not semi-urgent. You can wait for 12 months and then you can do the surgery. Okay. And if it is a chronic coronary disease, then 6 months is enough for that. Okay. So it is a class 2A recommendation, these two. Okay, understand? And if it is less than 3 months, then with drug eluting stent, if it is less than 3 months, it does more harm. So you should not do it. Even if it is emergency, then you can see whether it can be deferred or any palliation can be done or not. Even then, if it is required, you have to go with dual antiplatelet therapy unless the risk of bleeding is more than the thrombosis bleeding. Okay, these are the good class 2A recommendations. So you have to know about these things, then you can be crystal clear. Okay.
Yes, ma'am.
And if it is less than 6 months with chronic coronary disease and the risk of thrombosis is high,
Yes,
then you can go do bridging at it is a class 2B recommendation.
Yes, ma'am.
Can bridging with IV antiplatelet drugs.
Yes, ma'am.
Okay,
Yes,
so we will proceed further. So you have given all these and you pre-op orders, and you now how will you? What is your plan? What are your goals of anesthesia?
My goal to maintain the oxygen,
What are your
maintain the myocardial oxygen and
you have to
demand, ma'am, by avoiding brachycardia, hypertension, bradycardia, and hypotension, ma'am, and by keep maintaining normothermia.
And normothermia, and also you have to avoid hypercapnia. Okay, and sudden blood loss should also be avoided in these patients, should be taken care of. Okay,
Yes, ma'am.
so when a patient with stent ISD with stent comes to you, so what are the things you will keep in mind? It is how will you conduct your case, no? So what things will help you? Number one is the interval which you know, which is more than time interval from acute coronary syndrome to the PCF. It is more than 1 year in our patients. And what is the nature of control? The patient is having good stability without any other comorbidities. Okay. And number three, how will you monitor these patients intraoperatively in the perioperative period, and what is your anesthetic technique? And an interventional cardiologist should be available. Even if it is not available in your hospital, you should know where they are available, so that if something happens intraoperatively, then you may be able to refer to that patient. Okay.
Okay.
So these are the things. Now, how will you are planning, which type of anesthesia you are planning in this patient?
I will be giving a general anesthesia, ma'am.
Yes.
Controlled ventilation
Okay.
and tab block for pain management.
Okay, so how will you proceed in the OT? What monitoring you will apply?
Yes, ma'am. First, I will apply a pulse oximeter, ma'am, NIBP, and ECG monitoring, ma'am.
ECG.
Yes.
ECG is very important. Okay.
Yes, ma'am.
Continuous ECG monitoring is important. Which leads you would like to monitor?
Ma'am, I would, if
You would
available,
like to monitor 1 lead, 2 lead, 3 lead?
3 lead, ma'am, which includes lead
I can't
2
hear you.
and V5.
So normally you choose the leads according to the area of the myocardium or the artery involved. In this you said left anterior descending. So in this V3, V5 will be a good choice. Okay.
Yes,
So it has been shown in the literature that lead 2, 3 and 5 is very, very sensitive, but around 96 to 98% sensitive for picking up myocardial ischemic changes. Okay. So ECG, SpO2 and NIBP in this case, because it is a low risk and intermediate surgery. And what else would you like to do? Temperature.
Temperature.
So you will keep the EtCO2 in ready, so that after so how will you do induction in the anesthesia?
Yes, ma'am. First, I will give injection midazolam, 1 mg IV for antegrade amnesia, and followed by that, I will give injection fentanyl 2 mg per kg. And
so he's 50 kg, so he will give 60 kg, 120 mics. You would like to give. Okay.
Yes,
what else?
And I will induce with injection propofol, ma'am, in a titrated dose, ma'am.
Okay.
And be cautious.
So since he is a stable patient, so you can do with propofol.
Yes, ma'am.
With titrated doses. Okay. What else?
And I will use a muscle relaxant injection Vicronia, ma'am, 0.08 mg per kg. Ma'am, I will.
So what are the methods to decrease the laryngoscopic response of intubation?
Ma'am, I will use injection lignocaine 1.5 mg per kg 90 seconds before intubation, ma'am. Or I can use.
But you didn't say.
Injection labetalol.
There is a lot of lag. I can't. Yes, you can use. You can use lignocaine. Of course. What else? You can use. What?
Injection esmolol, ma'am, 0.5 mg per kg, ma'am. And I can give it.
So when you're using esmolol, what care will you take? Esmolol जब use करोगे तो what care you will take? What will you see when you're using esmolol? There should not be bradycardia and the patient should not be hypotensive. Now BP should be normal or above normal. Okay. And what are your goals of maintaining BP and heart rate in these patients? Goals क्या होने चाहिए? Within 20% of
the
baseline. Okay.
Yes.
So now you will intubate the patient.
Yes.
Okay, taking care that the laryngoscopy is minimum less than 15 seconds. And then you will ask them to do the case. And then suppose in the intraoperative period there is an ST depression.
Yes, ma'am.
So it is important to do the ST segment analysis
Yes,
in these patients so that you can know whether it is significant or not. Okay. So if there is ST segment depression more than 1 millimeters in the chest lead, what will you do?
First, I will assess the depth of
In the intraoperative period.
First, I will assess the depth of anesthesia, ma'am.
So how will you maintain anesthesia? Maintenance?
I will use inhalation agent.
You will see now how you are maintaining anesthesia, no?
Yes, ma'am.
Okay. So inhalational agent, or you can do with the TIVA also. Okay. So even all studies have shown that both are equal outcomes. Okay. So you will do which inhalational agent would you like to use?
Ma'am, I will use sevoflurane, ma'am. In this case.
You would like to use sevoflurane. Okay. So what are the advantages of sevoflurane?
Ma'am, myocardial depressant activity, ma'am, and which can reduce cardiac workload. So
Ischemic preconditioning.
Yes,
Inhalational agents are known to do ischemic preconditioning, but it may, if given in high concentration, it may lead to what? Vasodilatation and fall in blood pressure, or they are also direct myocardial depressants. So you have to be very careful when you are using inhalation agents. Okay. So anything on MAC, you should be careful. So now the depression has started. What will you do?
First, I will
ST depression.
assess the depth of the anesthesia, ma'am. If it's on a low, I will deepen the plane of anesthesia. And
You increase the depth if you think the patient is in lighter plane of anesthesia.
Yes,
What
ma'am.
else?
And I will get to know if patient is having adequate analgesia, and I will give intermittent boluses, ma'am, if required. And and I will.
What else?
And if
you will check the fluid status, isn't it?
Yes,
You will see whether the patient is not hypovolemic, if the patient is not going to left ventricular failure, you will check the you will auscultate. You will see all these things.
And if it's
then what will you do if you have ruled out?
Yes, ma'am. And I will check if the patient is catheterized or not. I will try to catheterize the patient, ma'am, and for any resolving of tachycardia or hypertension, ma'am.
If it is due to tachycardia, if it is accompanied with tachycardia, then you can do this. What else? You have to, the patient is, and they are doing this thing, laparoscopic hernia repair, then you have to see the intra-abdominal pressures. If they are very high, then you have to reduce it. Okay. So all these things have to be taken. If everything has been seen, then what will you do? What will you do? Abhi bhi ST depression hai.
I will get troponin levels done, ma'am.
But how will you solve it? You can send troponin levels. When you send troponin levels? If the ST depression is continuously more than 20 to 30 minutes, okay, or it is coming and going and or adding all these, if it is more than 1 to 2 hours, then you send for troponin levels, and you can give NTG. You can start if the BP is normal or on the higher side. You can give NTG. You can relieve pain by giving injection morphine. Okay, it also helps in decongesting the lungs. Okay, so it is a very good analgesic. So these measures can be taken.
Yes, sir.
Okay. So now you have finished the surgery. What will you do?
Now,
how will you extubate the patient?
I will extubate the
Yes.
I will try to reduce the sympathetic response associated with the extubation, ma'am, by giving a small point just before extubation, and and after extubating the patient, I will monitor him for the next 72 hours, ma'am, with continuous ECG monitoring.
Okay.
And
Why?
Ma'am, the risk of postoperative MI is high in particularly in the first 24 hours. Ma'am. So it still can happen
But
after 22 hours. Yes, ma'am.
Okay, it is very high in the first 24 hours, then for next for 24 hours, and it may occur up to 72 hours. In many cases, it has been seen up to even after 7 days. So you have to be very vigilant about this. Proper monitoring in an ECG with the ECG, at least 2 leads. Okay, 2-lead ECG monitoring. You have to monitor the blood pressure. You have to monitor the oxygen levels, and you have to take care of the pain. So, can you tell me, this is the last one or two questions, that what are there any other causes of ST depression other than ischemia? Any other cause which you should have told me? Yes. Any electrolyte imbalance? Okay.
Any electrolyte
Any other dysrhythmias? Okay, so these dysrhythmias and electrolyte imbalance, any block status is coming. So any other what are the other causes of ST? Any patient was on digitalis. This patient is not there, but maybe on digitalis. So these patients may have ST depression other than myocardial ischemia.
Yes.
Okay. So with this, we come to the end of our presentation. So any questions people can put on the chat box, and Dr. Shreya will be summarizing this ISD in her lecture. Thank you very much. Good note.
A very good afternoon, everyone. I am Dr. Shreya. Senior resident at Dr. Arvind Hospital, New Delhi, and I'll be summarizing the topic patient with coronary artery disease for non-cardiac surgery. Now, most of the points were discussed during the case discussion. I'll be mainly focusing on the ECC 2024 guidelines. So coming to the introduction, ischemic heart disease is characterized by inadequate supply of blood and oxygen to a portion of myocardium, resulting in oxygen demand and supply mismatch. It may manifest as stable angina, acute coronary syndrome, which includes unstable angina, STEMI, non-STEMI, or sudden cardiac death. Now, a brief overview about the incidence, how grave the problem is. It has an inpatient mortality of about 5 to 17%, and the incidence of perioperative MI is roughly about 1 to 17%. With patients experiencing MI or myocardial injury after non-cardiac surgery, and they have an inpatient mortality of 15 to 25%, being particularly high in the first 30 days. Before I switch on to the pathophysiology, a rough idea about the blood supply of heart. The blood supply of heart rises from aorta through the anterior aortic sinus, which gives rise to right coronary artery, and the left posterior aortic sinus giving rise to left coronary artery. The right coronary artery gives rise to the right marginal artery, which supplies the right ventricle, and the left coronary artery divides further into the left circumflex and the left anterior descending artery. So the common areas of stenosis in decreasing order of incidence are left anterior descending, right coronary artery, left circumflex, and followed by left main coronary artery. Now, there's no fixed theory. However, there are two possible theories: acute plaque disruption during and hemorrhage in the coronary artery system, and resulting in the myocardial oxygen supply demand mismatch, contributing together to the perioperative MI. Now, these are the factors causing myocardial oxygen demand mismatch. Decreased oxygen supply can be because of the decreased coronary blood flow and decreased oxygen content and reduced oxygen availability. And increased oxygen demand can be in cases of tachycardia, hypertension, increased preload or increased afterload or hypothermia. So all these factors have to be controlled during the perioperative period. Now, the goals of our pre-op evaluation are to determine the extent of ischemic heart disease and any other previous interventions, to decide on the further testing, treating the modifiable risk factors, reviewing the medical therapy, and planning the guideline-directed management and therapy, and planning our anesthetic technique accordingly. So we have certain risk calculators. These were discussed during the case discussion: functional capacity assessment, cardiovascular risk indices, and the pre-op biomarkers for risk stratification. So for the risk assessment of functional capacity, we have the Duke Activity Status Index called commonly called DASI. So it is a semi-quantitative tool, patient-reported ability to perform a set of 12 daily activities, and scorings are given according to it. Higher the score, higher the functional status. So we take the cutoff as 34. If it is more than 34, it is good functional capacity. If it is less than equal to 34, it is poor functional capacity. Now, Mets, this is one important point asked in exams. One metabolic equivalent of task is the amount of oxygen consumed by a 40-year-old with 70 kg weight at rest, and is equivalent to an oxygen consumption of 3.5 ml per kg per minute body weight, per kg body weight. So it is categorized again from 1 to 12, and 12 being the highest. So we take the cutoff as 4. If the Mets are more than 4, that means the patient is able to climb one flight of stairs, 15 steps, 6 inches in height, without getting breathless. The patient has a good cardiopulmonary reserve, and less than 4 has a poor cardiopulmonary reserve. Now, the cardiovascular risk indices, we have the revised cardiac risk index, which has, as discussed in the case, it's 6 independent parameters. If it is RCRI is more than 1, it is elevated risk. If it only one of the parameters is present, it is a low risk. If more than 1 parameters are present, it is considered elevated risk. So this is one important table wherein, so low risk over here shows less than 1% of MACE, and MACE being major adverse cardiac events, and elevated risk is more than 1% of MACE. So emergency of the surgery takes precedence over need for additional workup. So now, if the patient has unstable clinical factors and is posted for a low risk surgery and has a low risk of MACE, they might need further evaluation, right? Or both low risk or elevated risk, they have to have further evaluation if they have unstable clinical factors. So the unstable clinical factors are unstable coronary syndrome, significant dysrhythmias, valvular diseases, and decompensated heart failure. Now, if the patient has stable clinical factors and have a low risk of perioperative MACE, then they can proceed for surgery. But if they have an elevated risk, then we have to see the functional capacity. If it is more than 4 METs, we can proceed to surgery. If it is less than 4 METs or the functional capacity cannot be determined, we have to undergo further evaluation. Right, so these are the various risk scores and calculators which can be used to predict perioperative MI. Although many scores are there, but the data is lacking to support one risk index over the other. Right, so before I proceed to the ACC guidelines, I would like to just tell you about the algorithm, how to approach the preoperative, how to do a preoperative cardiac assessment in such patients. Right. Okay. Just a second. So if the patients have any cardiovascular risk factors, now these cardiovascular risk factors being hypertension, smoking, diabetes, or a family history of CAD, females more than 65 years of age, or men more than 55 years of age. So any of the risk factors are present and they're scheduled for non-cardiac surgery. If these risk factors are not present, we can proceed for surgery. If these risk factors are present, we have to see if it's an emergency surgery. If it's an emergency surgery, we have to proceed for surgery. With the limited time allotted to us, we have to optimize the patient. Now, if it's not an emergency surgery, we have to see if the patient has any unstable clinical factors, like acute coronary syndrome, decompensated heart failure, severe valvular disease, or unstable cardiac arrhythmias. If the patient have all these, then we have to manage the acute cardiac condition, and we have to take a multidisciplinary discussion for deferral of the surgery or palliation or non-invasive treatment. If these factors are not present, we have to estimate the perioperative risk using the risk calculators like RCRI or the Goldman Risk Index or the ACS NSQIP. Now, if the patient has a low calculated risk meaning that RCRI is less than 2, or RCRI is just 1, and there are no risk modifiers present, we can proceed to surgery. Now, if the patient has elevated cardiac calculated risk, which is RCRI more than 1, but they do not have any risk modifiers, we can consider 12 DCG in such patients and consider guideline directed management therapy for reducing long-term cardiovascular disease risk, right? And if there is risk, there is elevated risk, RCRI more than 1, along with the risk modifier present. So we have to get a 12 DCG done and echocardiography in cases which has new onset dyspnea or there is worsening of the ventricular dysfunction, right? So we get these things done, then we assess the functional capacity of the patient. As I mentioned, the cutoff is 4 for METs and 34 for DASI. So if the functional capacity is adequate, we can proceed to surgery. If it is not adequate, then we see if further testing is going to impact our perioperative care or not. So this is the new thing that is added in 2024 guidelines from 2014. So if this if it is going to impact if it is not going to impact our perioperative care, then we can proceed for surgery, and we can consider deferral of the surgery or non-invasive treatment. Or if it is going to affect our perioperative care, we can go in for a pre-op biomarker risk assessment, which includes the brain natriuretic peptide and the N-terminal pro B-type natriuretic peptide, or we can consider troponin also. If these are normal biomarkers, we can proceed for surgery. If it's an abnormal biomarker, we have to take a multidisciplinary team discussion for benefits of additional cardiac evaluation, in which we can get a non-invasive stress testing done or a CT coronary angiography done. If these tests show low risk findings, we can proceed for surgery. If they reveal elevated risk findings, then we have to consider alternative strategies, or we can defer the surgery or consider non-invasive treatment. And if the patient does undergo surgery, we have to consider for post-operative troponin surveillance, right? So this is one important algorithm that we should know about before approaching such patients for pre-op evaluation. Now, continuing with the presentation again. So approach to the preoperative cardiac testing. Now 12 DCG routine is before this, I would like to say that I would use in color coding for all the recommendations of 2024. Red, the green will be class 1 recommendation. Yellow would be class 2A recommendation, where the benefits will outweigh the risk. Class 2B recommendation is moderate, wherein the risk and benefits are equivalent and it depends on the physician's discretion. And red will be class 3 recommendation, where it is more harm than benefit, right? So 12 DCG, routine pre-op 12 DCG is not recommended in patients undergoing low-risk surgery, as discussed in the case, and it may be considered in patients for both elevated risk or patients undergoing high-risk surgical procedures, right? Then LV function assessment, again, routinely, it is not recommended. It may be considered in patients with new onset dyspnea or worsening of the LV dysfunction or any new symptoms that are arising. Again, exercise stress testing or the pharmacological stress testing, as I mentioned in the algorithm, not routinely recommended in patients undergoing low-risk surgery or who have a good functional capacity. It may be undertaken for patients who have an unknown METs or undergoing high-risk surgery. Again, CT coronary angiography is not recommended routinely for patients undergoing low-risk surgeries, and it may be considered in patients undergoing elevated risk surgery with poor functional capacity, right? Then preoperative coronary revascularization, routinely it is chronic coronary disease, right? In patients with acute coronary syndrome or chronic coronary disease planning for elective non-cardiac surgery, it may be considered and deferral of surgery is reasonable. However, it does comes with its own problems of because the timing of surgery and the antiplatelet therapy, thrombosis, and the risk of bleeding may limit the our proceeding with the surgery, right? So the perioperative medical therapy, beta blockers, as discussed, should be continued throughout the perioperative period, should not be initiated on the day of surgery. And if there is an indication to initiate the beta blockade, should be done at least 7 days prior to the surgery to assess the tolerability and see if drug titration is needed. Similarly, for ACE inhibitors, If patients have controlled BP and they are undergoing elevated risk surgery with major fluid shift and increased blood loss suspected, it should be omitted 24 hours prior to the surgery, but it should be restarted in the post-operative period as soon as possible. ACC gives no recommendations regarding the calcium channel blockers, and also regarding the nitrates, there are no fixed guidelines for this. Alpha-2 agonist, ACC recommends not to initiate low-dose alpha-2 agonist to reduce the cardiovascular risk. Now, statins, it's a class 1 recommendation to continue taking statins in the perioperative period, and it may be started in the preoperative period for patients undergoing elevated risk surgery because of its long-term effect. So if the patient has undergone a percutaneous intervention prior to the surgery, so this slide is a little congested, it is better displayed over here in the flow chart, wherein if the patient has undergone only balloon angioplasty, the surgery can be delayed for more than 14 days. It's a class 1 recommendation. If the patient has undergone bare metal stenting for PCI, it should be delayed for more than 30 days. Again, a class 1 recommendation. Now, for drug-eluting stents, depends if the patient has undergone DES for acute coronary syndrome or chronic coronary disease. So, if the patient has undergone for ACS, it is better to delay the surgery by more than 12 months. It's a class 1 recommendation. And if it's a time-sensitive surgery, it should be at least delayed for more than 3 months. However, the dual antiplatelet therapy should be continued in the perioperative period, right? And if it's an emergency surgery and has to be done within a month of drug-eluting stent placement, it should actually not be performed, right? It's a class 3 recommendation. And then for chronic coronary disease, the difference lies in the time duration. So the non-cardiac surgery should be delayed for 6 months only if it is for chronic coronary disease. And the rest of the recommendations remain the same, class 2B and class 3, if it is more than 3 months or less than 1 month. Okay. So again, discussing the antiplatelet therapy post PCI is beyond the scope of this lecture. However, I would just like to focus on the class 1 recommendations, wherein patients with prior PCI, it is recommended to continue aspirin to reduce the risk of cardiac events. And in patients with the chronic coronary artery disease who require time sensitive within 30 days of PCI with bare metal stenting or within 3 months of drug-eluting stenting, the dual antiplatelet should be continued unless the risk of bleeding outweighs the benefits of prevention of stent thrombosis, which is what I mentioned over here. If the patient has to undergo surgery within 3 months of drug-eluting stent, dual antiplatelet therapy has to be continued. And in patients with prior PCI in whom oral anticoagulant monotherapy was going on, it should be discontinued and aspirin should be substituted for it until the oral anticoagulant can be safely initiated in the postoperative period. However, in patients with CAD but without prior PCI who are undergoing elective non-cardiac surgery, routine initiation of aspirin is not beneficial. This is a class 3 recommendation. Okay. Now, the choice of anesthesia in such patients, it can be either general or regional anesthesia, can be chosen alone or in combination as required by the patient and planned by the anesthesiologist. Intraoperative monitoring, as we said, discussed in the case, ECG with 3 leads is extremely important. The sensitivity of detecting ischemia is 80% with lead 2 and lead V5 and 96% with leads 2, V4 and V5, right? We have non-invasive blood pressure, ETCO2, SpO2 temperature and urine output. Now, invasive arterial pressure monitoring is more useful in patients who are undergoing elevated risk surgeries with major fluid shifts or increased blood loss suspected. And now central venous catheters may be inserted again with major fluid shifts to guide our fluid therapy. Now, transesophageal echocardiography. So routine use is not recommended, but patients in whom there is unexplained hemodynamic instability, TEE may be employed, or either transesophageal echocardiography or the focused cardiac ultrasound focus may be also used in such patients but only it's a class 2 recommendation in unexplained hemodynamic instability. Right, intraoperative management as adequate analgesia, adequate depth of anesthesia should be maintained. Avoid hypoxia, hypercarbia, acidosis, normothermia should be maintained. And the choice of muscle relaxation you should avoid atracurium because it causes instrument release and can cause sudden decrease in the cardiac output, and pancreatium causes vagolytic effect. Vagolytic effect. Now, laryngoscopy should be reduced with less than 15 seconds. And other agents discussed during the case can be used for reducing your laryngoscopic response to intubation. ACC recommends the use of either volatile agents or TIVA, with the choice being determined by factors other than prevention of perioperative MI. And use of nitrous oxide is not associated with increased risk of cardiac morbidity or mortality. So nitrous oxide may be used unless there is an evidence of pulmonary hypertension or other features of pulmonary vascular resistance. There is no contraindication of using nitrous oxide in such patients. So as I said, avoid hyperventilation or hypoventilation, prevent hypothermia, good analgesia should be maintained, prevent hypovolemia. So yes, this was also discussed that they do not give, ACC do not give any cutoff value for initiating blood transfusion, but HB levels should be maintained more than 10 grams per deciliter. Right? Reversal and extubation, you should have drugs like lignocaine or beta blockers should be present to reduce the sympathetic response associated with extubation. Now, I would like to focus on the perioperative surveillance for myocardial injury and infarction. In patients, I think this was also discussed during the case that in patients with known cardiovascular disease undergoing elevated risk surgeries, it may be reasonable to measure cardiac troponin at 24 and 48 hours after surgery to identify the myocardial injury. But the routine postoperative screening with cardiac troponin levels is not indicated. It is a class 3 recommendation. Okay. And now in patients who do develop myocardial injury after non-cardiac surgery and who did not have any cardiovascular risk factors, an outpatient follow-up should be reasonable. And it's a class 2A recommendation. And in patients who do develop myocardial injury after non-cardiac surgery, antithrombotic therapy may be considered. So again, this is a class 2B recommendation. It may be considered to reduce the thromboembolic events. In patients who develop STEMI or non-STEMI should be considered for goal-directed management guideline-directed management and therapy, including consideration of invasive coronary angiography, balancing the bleeding and thrombotic risks. And post-operative management, as discussed during the case again, the risk of perioperative MI is very high within the first 24 to 48 hours, and 90% occurs within 7 days post-operatively. So continuous ECG monitoring should be there with us. Serial 12 ECG and troponin levels discussed earlier. Routinely, it is not recommended at 24 and 48 hours in patients who are undergoing elevated risk surgery and they have high risk factors can get their troponin levels done at 24 and 48 hours. Supplemental oxygen to be given, blood transfusion if it is indicated, and normothermia to be maintained. Analgesia should also be maintained adequately. So this summarizes the topic coronary artery disease, patients undergoing a non-cardiac surgery.
Thank you, Dr. Shreya, for summarizing it so well. And I would like to tell the students that a lot of things are there which you have to read yourself, because everything cannot be covered in 1 hour lecture or in this presentation. So we discuss regarding this case. So you may get different cases in your exam. So you have to mold your discussion according to that. And whatever guidelines are there, they are for helping you. These recommendations are there for helping you, but it will not replace your clinical judgment. And all your management should be tailor made, individualized for that patient. So you cannot use one set of the investigations and anesthesia care in one patient and you can replicate in the other patient. So each patient is different and you have to tailor made your management according to that patient. And post-operating, as Dr. Shreya said, that post-operating shivering is detrimental in these patients. So the management of hypothermia should be started right from the beginning, from the pre-operative period, so that the patient are not cold at the end and they shiver in the end, and which increases the oxygen demand drastically. So this may lead to ischemia. You have managed the case so well, but the patient is shivering in the end, so the patient may have ischemia in the end. So thank you very much. And if any questions are there, we will be happy to answer them. Are there any questions? Will you see in the chat box?
No, ma'am, there are no questions in the chat box. We don't have any questions. Thank you so much.
Okay, thank you. Thank you
Really
so much.
very, very comprehensive coverage of a very difficult topic. PTCAs, we are usually confused when to, stop antiplatelet agents, when to begin them, when to put epidural. So this was really very nicely presented, and I hope it has cleared a lot of confusion in the minds of our young budding anesthesiologists. So now we'll move ahead with the next topics. We have with us Dr. Zulfikar Ali sir.
Thank you, ma'am.
Thank you, sir. So, Sir is additional professor in the Department of Neuroanesthesia, SKIMS Srinagar. He is in charge Neurosciences ICU and post director DNB, post coordinator DNB, Neuroanesthesia and Critical Care. He has received ISA President Appreciation Award for the year 2015, ISA Proficiency Award 2021. He's section editor, Indian Journal of Anesthesia. He's executive committee member of Indian Society of Neuroanesthesia and Critical Care and All India Difficult Airway Association. And he has, to his credit, 223 national and international publications. He's co-editor of the textbook of Neuroanesthesia and Neurocritical Care. His areas of interest are neuroanesthesia and neurocritical care. We welcome you, sir. It is really a pleasure to have you with us. And I would request you to kindly introduce our speaker for the next topic, sir. Thank you so much.
Thank you, ma'am, for making a part of me a part of this academic event. Our first speaker in this session will be Dr. Mani Kiran. Dr. Mani is an assistant professor at AIIMS Mangalgiri, and his areas of interest are pediatric and neonatal anesthesia, pharmacology and drug interactions, airway invasive lines. He has a special interest in regional anesthesia, intensive care, and workplace environment. Dr. Mani, he will be speaking on blood and blood products. Over to you, Dr. Mani.
Hi, good evening, everyone. I hope my presentation will help everyone. Hello, good evening, everyone. I am Dr. Manikiran. I'm working as an assistant professor in AIIMS Mangalagiri, Andhra Pradesh. Today, I am going to speak about blood and blood products. The overview of my presentation will be like how we process the collected blood and how we separate the various components, and what are the various components and how they are, when and how they are used. I will speak a few words about massive blood transfusion, and I shall discuss in detail about various transfusion reactions. Blood is acquired from donors in CPDA bags. CPDA stands for citrate, phosphate, dextrose, and adenine. Citrates chelates calcium and prevents the blood from clotting while storage. Phosphate acts as a buffer and prevents wide fluctuations in pH of the collected blood. Dextrose is a source of energy for the RBCs while storage, and adenine is used to resynthesize the utilized ATP for energy purposes. And this storage blood is screened for HIV, HBsAg, hepatitis C, syphilis, and malaria. Apart from CPDA, there are various other solutions in which blood can be collected and stored, which includes Optisol and Nutrisol. So, the whole blood which is collected in CPDA bags is centrifuged to separate packed red cells and platelet-rich plasma. This platelet-rich plasma is centrifuged at 20 degrees Celsius to separate platelets, and we get platelet-poor plasma as other product. This platelet-poor plasma is freezed at minus 20 degrees to create fresh frozen plasma. But instead of freezing at minus 20 degrees, if we freeze it at minus 70 degrees and again thaw it, we get cryoprecipitate. We shall discuss about all these various components in detail in further slides. Coming to PRBC. So actually it is difficult to gauge the organ perfusion and oxygen delivery, which we should be doing actually, but as it is difficult, we generally pick a cutoff hemoglobin and transfuse PRBCs when we reach that cutoff hemoglobin. So while a patient is undergoing a surgery and he is having blood loss, how much blood loss should we allow? That we calculate allowable blood loss is equal to estimated blood volume, which is 70 ml per kg in an adult male and 60 ml per kg in an adult female, into initial hematocrit minus target hematocrit by initial hematocrit. And the ongoing losses can be estimated either by visual method or gravimetry method. Gravimetry method is the method of weighing the gauzes and other drapes soaked in blood. The initial weight, the difference between the initial weight of those gauzes and the weight after getting soaked in the blood gives the amount of blood which is lost. Whereas visual method, there are various rough estimates, like a normal gauze piece, if it is completely soaked in blood, it means 10 ml of blood is lost. Whereas a normal size sponge, if it is completely soaked, it means roughly 100 ml of blood is lost. One of the main reasons for transfusion related reactions is ABO incompatibility. So we will be checking ABO compatibility and also doing cross match before transfusing a blood. We must be knowing the which group blood to be can be transfused to which group patient. We as all of us know, O negative is universal donor, whereas AB positive is universal recipient. So O group can be given for any patient, whereas group A blood can be given either to group A recipient or group AB recipient. Group B blood can be donated to either group B recipient or AB recipient, and AB blood group can be transfused only to AB group recipient. When the blood is stored, there will be a lot of biochemical changes occurring in it. Because there is no supply of energy and oxygen, the RBCs in the stored blood will utilize the present substrates present within the blood in a anaerobic fashion, and they produce lactate and hydrogen ions. This causes fall in pH of the stored blood. It will be roughly 6.9 in the stored blood after 20 days. Similarly, there can be oxidative damage occurring to the lipids and proteins in the stored blood. As there is no supply of energy, the ATPs will be reduced. There will be reduced in 2,3 dpg. As there is limited energy supply, the ion pumps starts to fail. So sodium leaks into the intercellular compartment and potassium leaks out of RBCs into the extracellular fluid. Because of this pump failure, there will be increased osmotic fragility and decreased deformability of the cells. Because of decreased deformability, the cells cannot travel through microcapillaries, which can cause microocclusive events. As there is decrease in 2,3 dpg levels, the ODC curve shifts towards left. So after transfusing the blood to the patient, the oxygen carrying capacity is still less compared to the normal RBCs, which takes some time, roughly 2 to 3 days after transfusion, to regain its to replenish its 2,3 dpg and regain its oxygen carrying capacity. So strategies to reduce blood transfusion. A patient presenting for elective surgery should be evaluated around 1 or 2 months prior to the planned surgery date, and if we found that the patient is having any anemia, we should provide nutritional support and iron supplementation. If the patient is severely anemic and is posted for major surgery, then we can think of giving IV iron supplementation and erythropoietins. Hemostatic agents like tranexamic acid, ECA can be used to decrease the blood loss. Normovolumic hemodilation, where the patient blood is removed during the time of induction and it is replaced with crystalloids or colloids to maintain the volume. And once the major losses are done, if the patient is hemodynamically stable during major losses, the collected blood can be reused to the same patient. This decreases the number of RBCs lost during surgery. That collected blood should be stored at temperature less than 5 degrees Celsius and it should be used within 24 hours. Other method is autologous transfusion, where the patient himself donates blood for his future surgery. The prerequisites are the patient hemoglobin should be more than 11. Then only we can collect the blood from the patient. And we can collect 1 unit of blood at an interval of 1 week from the same patient. And before going to the surgery, the last donation should be 72 hours prior to the surgery. One more technique of reducing the blood transfusion need is cell salvage. It is a machine which collects the blood from the surgical site, filters it from debris and other tissues, and gives us the blood RBCs in a packed form. There are some issues with this cell salvage, that it can cause air embolism if we use any betadine or chlorhexidine or any hypotonic fluid in the surgical site that can enter into the patient circulation. And also, even though this cell salvage contains filters, sometimes some tissue fragments can enter into the patient circulation. Coming to platelet concentrates. Generally, two types of platelet concentrates are available. One is random donor platelet concentrate. Another one is single donor apheresis platelets. Platelets are stored at room temperature and the half-life is around 5 days. And these platelets should be stored with gentle agitation to prevent clumping. There are high chances of bacterial contamination, and also platelets are known to cause maximum febrile reactions compared to PRBs and FFBs. While transfusing platelets, we need to check for ABO compatibility and RH typing. No need to do any cross matching. Roughly, a single RDP increases 5,000 to 8,000 of platelets in an adult, whereas a single HDAP increases 30,000 to 40,000 of platelets. Coming to transfusion triggers for platelets, while we are planning to place a central line, it is ideal to have a platelet count of minimum 20,000. And if we are planning to do a central neuraxial blockade, it is ideal to have a platelet count of minimum 80,000 to 1 lakh. For major surgery, the cutoff is 50,000, and for neurosurgery and ophthalmic surgery, it is 1 lakh. Fresh plasma. It is stored at minus 20 degrees Celsius and the half-life is more than 1 year. The indications for transfusion of FFP are when INR is more than 2, to treat warfarin toxicity in conditions of disseminated intravascular coagulation, and while the patient is receiving massive transfusion. While transfusing FFP, we need to look for ABO compatibility. RH typing is not required. Each unit of FFP raises clotting factors by around 3 to 6%. FFP contains high concentration of citrates, so they cause greater hypocalcemia compared to platelets and PRBs. Precipitate. This is obtained when FFP thawed and the precipitate is reconstituted. It contains factor 8, 1 Willebrand factor, fibrinogen, factor 13, and fibronectin. The indications of cryoprecipitate transfusion are fibrinogen levels less than 100 mg per deciliter, or in a patient with 1 Willebrand factor deficiency who is not responding to the desmopressin therapy, or also while the patient is receiving a massive transfusion. Similar to FFP, even cryoprecipitates needs ABO compatibility. Arch typing is not required. Once after thawing the cryoprecipitate, it needs to be transfused as soon as possible, possibly within 3 to 4 hours, and it has to be given as a rapid transfusion. I will be defining what massive transfusion is, but I won't be explaining what are the protocols to be followed and how to evaluate the patient and what are the logistics needs to be provided, because that is a very huge topic, and it takes more than 1 hour to explain complete massive transfusion. So to define massive blood transfusion, if one total blood volume is being transfused within 24 hours, it is called massive blood transfusion. As other definitions are more than 50% of the total blood volume transfused within 3 hours, or more than 4 PRBs within 1 hour, or transfusion support to loss of blood which is more than 150 ml per minute. These all definitions are for adults. In pediatric patient, the same definition, first definition is also applied in pediatrics. That is transfusion of more than 100% total blood volume within 24 hours, and more than 50% of total blood volume is replaced within 3 hours, and if the ongoing blood loss is more than 10% of total blood volume per minute. I insist every one of you to go and read about massive blood transfusion. There are a lot of points to read and discuss. It is a important question. Next, let's discuss about coming to acute or intravascular hemolytic reactions. It occurs mostly because of ABO incompatibility, and as small as even 10 ml of transfused blood can lead to this reaction. In a awake patient, the clinical features includes chills, rigors, fever, nausea, and chest pain. But when the patient is under anesthesia, we don't notice all these chills and rigors. Rather, we see rise in temperature, tachycardia, hypotension, hemoglobinuria, and oozing from the surgical side. These are the two important things which draws our attention. In some patients, the reaction can be so severe that it can lead to shock and DIC and acute renal failure. To prevent acute renal failure, we should maintain urine output more than 75 ml per hour in an adult patient. And the role of alkalinization of the urine using bicarbonate is equivocal at present. The data is a bit ambiguous. Many people still prefer alkalization in the urine by giving some bicarbonate. As the patient can develop DAC, a baseline platelet count, prothrombin time, and activated APTT should be sent immediately once we notice hemolytic reaction. Coming to delayed or extravascular hemolytic reactions, it mainly occurs when there are partial antigens in the donor RBCs. In this condition, the antibodies from the recipient are coated over donor RBCs, but it does not cause hemolysis immediately. Rather, these RBCs are sequestered in the reticuloendothelial system, and slowly they get hemolyzed in the reticuloendothelial system. The clinical features include malaise, fever, jaundice, and failure to increase the hematocrit. It is more commonly seen in pregnant women where because of their exposure to the fetal RBCs. Coming to febrile reaction, this is the most common type of transfusion associated reactions. It occurs because of the WBC sensitization of donor blood. Patients with history of febrile reaction should receive leukodepleted blood products. Coming to anaphylactoid reaction or urticarial reaction, it occurs due to sensitization by the foreign plasma proteins. It is presented as arrhythmia, hives, and itching. There won't be any fever. Management includes antihistaminics and corticosteroids. The guidelines suggest that we can continue the transfusion, but practically speaking, it is difficult to differentiate whether it is a urticarial reaction or an anaphylactic reaction. We don't have in most of our setups the tests necessary to rapidly differentiate these kind of reactions, so better we should stop the transfusion. Coming to anaphylactic reactions, it occurs in a IgA deficient individual receiving blood from IgA rich donor. It can be severe. It can cause laryngeal edema, dyspnea, and hemodynamic instability, shock. The management includes supportive care along with corticosteroids and antihistaminics. In a patient who has history of anaphylactic reactions, should receive IgA free blood in future if required. Coming to transfusion associated acute lung injury, this is the most common cause of mortality associated with transfusion reactions. It presents as acute hypoxia and non-cardiopulmonary infiltrates, which is similar to ARDS in picture. It occurs within 6 hours of the end of transfusion, and FFPs are mainly incriminated, followed by platelets and PRBs. It is related to the amount of components transfused. The more the amount of products transfused, the more the chances of TRALI are. The pathology is that high levels of interleukin 8, which is present in a multiparous donor mostly because they receive multiple transfusions and they are highly exposed to various blood groups of the fetuses, so they develop very high titers of interleukin 8. So if a multiparous donor donates blood and it is received by a patient who has liver disease or who is hemodynamically stable or has renal disease, who cannot uh, metabolize and eliminate these high levels of interleukin 8, develop uh, lung injury, immune mediated lung injury. The management includes oxygen support or ventilatory support as required depending upon the severity of the condition, and if we initiate the supportive management timely, TRALI resolves within 4 to 5 days, unlike ARDS where the prognosis is a bit poor. The other transfusion reaction which is similar to TRALI but the pathophysiology is entirely different is TACO, transfusion associated circulatory overload. Nowadays the incidence of TACO is increasing and the incidence of TRALI is decreasing because people are screening the donors and mostly they are avoiding multiparous women as donors. This occurs when we transfuse a huge amount of blood and blood products which is in excess of the patient loss, and also sometimes what happens is intraoperatively if the patient is having massive blood loss, initially we give a lot of crystalloids and colloids, Then we start giving PRBs and other blood products. So what happens, initially we gave a lot of IV fluids, then no blood and blood products. So all these things gets causes overload, circulatory overload. In these patients, we have lung infiltrate similar to trolley, but we also have features suggestive of heart failure, which include raised central venous pressures and pro BNP values, and also when you do echocardiography, you can see the changes of heart failure. Another important reaction is graft versus host reaction, which has very bad prognosis. It is a rare reaction, but it has very bad prognosis. It occurs mostly in immunocompromised patient. This occurs because of engraftment of donor lymphocytes on the host tissues, and once the donor lymphocytes engrafts on host tissues, it leads to activation of complement and destruction of the host tissues. The presentation is usually rash, leukopenia, and thrombocytopenia. As the condition progresses, the patient might finally land into sepsis and death can occur. Other adverse effects of massive transfusion are the metabolic complications include hypocalcemia because of citrate, which is present as a chelator in the collected blood and blood products. The citrate is generally metabolized in liver. So, in patient with normal liver and normal hemodynamics, a slow rate of transfusion generally doesn't cause hypocalcemia unless if you are transfusing 1 unit of blood within 10 minutes or faster, or if the patient has liver injury, liver failure, or any hemodynamic instability, or any other serious condition, then only hypocalcemia generally occurs. Also hyperkalemia, as we have discussed, there will be pump failure which can cause excessive potassium in the extracellular fluid of stored blood. So if you are transfusing at a very fast rate, this potassium tends to cause hyperkalemia in the recipient. And also acidosis, because a lot of lactate will be released and the pH of the stored blood is very low. And also the blood is stored at temperatures less than 5 degrees Celsius. So if you're transfusing the blood at a very faster rate, that cold blood enters into the patient's circulation and can cause hypothermia. Other adverse reactions include dilutional coagulopathy, because initially we tend to transfuse only PRBCs. So for the plasma and coagulation factors might not be adequately replenished, causing coagulopathy. Also, although we screen the blood for few infections, there can be other infections which uh, can be transmitted to the recipient. In patient receiving multiple transfusions over a long time, they can have iron overload. Also, air embolism can occur, and there are some case reports and data about immunomodulation caused by transfusions. Like the patients who are receiving greater amount of transfusions are prone more for infections, and in cancer patient the tumor recurrence rate is high. And also in a patient with some viral infections like cytomegalovirus virus, if the virus activity has become dormant, it can get reactivated. There are some case reports, the data is inconclusive at present, but yes, there are some notion that blood transfusions can cause all this immunomodulation and other leading to increased rate of infections and virus activation and recurrence of cancers. Thank
Thank you, Dr. Mani, for elaborate talk. I don't feel there are any questions in the chat box so far. Any questions in the chat box?
No questions in the chat box, sir.
No.
I guess.
Dr. Mani,
No questions.
for the benefit of the postgraduates, could you just throw some light on the role of the synthetic oxygen carriers?
Yes, sir. Now there are some synthetic oxygen carriers in the market, which actually are so handy that they can be transfused to any blood group patient. There is no need for any cross matching, so we can immediately get them and transfuse them. Rather, for a normal blood from the blood bank, we need to wait till the cross
Have
matching is complete.
some clinical trials somewhere where we can use them, because of late they have been associated with use in the military medicine mainly, and not much of the clinical use because of the toxicity and excessive vasoconstriction. So do we have some use in clinical medicine where we are using them?
Sorry, sir, I have no idea where we are. I mean, using them, but
Mainly also what I have come across is that they are mainly used for experimental purposes. So I am not aware whether they are used actively in clinical medicine. One more question I had for you, commonly, because blood is one of the most common things that we use in our clinical anesthesia practice. And many a times, particularly in resource limited settings, we do not get blood which is maybe less than 21 days old. So what is your take in such a situation? How should we proceed in such a situation? Is it safe to transfuse blood which is older than 3 weeks, or is it associated with some deleterious effects which can
sir,
for a period?
yes, sir. Sir, transfusing 1 or 2 units of older blood, I don't think it causes any harmful effects. But if the rate is so fast and if we are transfusing huge amounts of blood, we should be watchful for the changes in the metabolic parameters like hyperkalemia and all those things, because there are chances that more number of RBCs are hemolyzed in those bloods. So we should be watchful, and I think we can transfer, sir.
Fine. Thank you.
Thank you,
I
sir.
will go to our next speaker, Dr. Jyoti Singh. She is our next speaker. Can we have ma'am's CV? Dr. Jyoti Singh, she is a professor at ABV IMS and RML Hospital, New Delhi, and she has numerous publications in various national and international journals, and she has authored a chapter in the anesthesia instructor for BCLS and CCLS courses for cardiopulmonary resuscitation. Her areas of interest are difficult airway management, transplant anesthesia, pediatric and neonatal anesthesia. And Dr. Jyoti, she will be speaking on the low flow anesthesia. Over
Good
to you.
evening, sir. Good evening, sir. Thank you, sir. Hello, everyone. Today I will be talking about low flow anesthesia, which is a need of time and also an important question in postgraduate. Uh, definitions for this. Low flow anesthesia is not new, but it started long back when John Snow in 1850 recognized that only a small fraction of inhalational anesthesia get metabolized and most of it exhaled unchanged. Effect of the volatile anesthetic could be prolonged by re-inhaling these unused vapors. Ralph Waters in 1924 introduced to and fro system, the rebreathing technique with carbon dioxide absorption. Carl Gauss in 1875 to 1957 published his clinical experience of the successful use of a circle absorption system, which is very important part of low flow anesthesia and which proved to be a milestone. Brian C. Sword in 1930 introduced the circle system. This is a circle system or closed system. Consists of two ends, one for patient and the other for machine, for fresh gas flow, two limbs, expiratory and inspiratory limb, with unidirectional valve to avoid mixing of inspiratory and expiratory gases with CO2 absorbent canister in between. The expired gases travel through the expiratory limb of circle system and go through the CO2 absorber chamber into the inspiratory limb, where fresh gas is mixed and delivered to the patient. In this way, the volatile anesthetics, oxygen, nitrous oxide are recirculated and also the heat and humidification is also maintained. But in 1933 onwards, with cyclopropane, it became essential to use closed system to avoid danger of explosion. In 1954, halothane came to clinical practice and gave rise to high-flow system. Halothane had high anesthetic potency but narrow therapeutic index. It was easy to measure the concentration of halothane with high flow system with no or minimal rebreathing. In spite of the fact that most anesthetic machines were equipped with circle systems, but it became clinical obligation to use high flow for patient safety. In 1980, isoflurane gave way to renewed interest in low-flow anesthesia and closed circuit. Ozone depletion and the greenhouse effect further strengthened the use of low-flow anesthesia. Bound and Atkin had in 1995 renovated the low-flow anesthesia by imposing important benefits from both environment and economic aspects. These fresh gas flow can be categorized as described by Baker into the medium flow, which is 1 to 2 liter per minute, low flow 500 to 1000 ml per minute, minimal flow is 250 to 500 ml per minute, and metabolic flow is about 250 ml per minute. What is the aim of low flow anesthesia? So the aim of low flow anesthesia is to replenish consumed gases with similar composition of gases at minimum fresh gas flow. After absorption of CO2, the basic constituent of low flow anesthesia should remain the same. The theoretical aspects of low flow anesthesia, and for calculating the constituents of fresh gas flow in low flow anesthesia, we should know how to calculate the gas consumption in the patient. So for that, few formulas are used. They will help us in understanding that what is happening in fresh gas flow under low flow anesthesia. First of all, under anesthesia, patient is consuming oxygen, and how we calculate is with Brody's formula. In simpler way, it is volume oxygen consumptions is equal to 3.4 into body weight, and virtually the oxygen consumption is constant and roughly around 250 ml per minute is essential in healthy patients. Next in is nitrous oxide uptake, which is inverse of time. As time increases, the amount of nitrous oxide taken up starts to fall and it is not metabolized. Consumption of volatile anesthetics depend on factor of MAC and blood gas coefficient and cardiac output. It is also inversely proportional to time. It decreases with increase in time. In this graph, the white part is oxygen, which remains constant throughout, while nitrous oxide and volatile anesthetics are higher in beginning and with time starts falling. It is the pictorial representation of mathematical formula for three components of fresh gas. The factors that can influence the buildup of alveolar concentration should all be considered while trying to reach the desired alveolar concentration, the MAC. Factors affecting the inhaled tension: one is breathing circuit volume, two rubber gas solubility, set inspired concentration. Factors which affect the rise in alveolar tension are concentration effect, alveolar ventilation, and uptake by the blood is affected by cardiac output, blood gas solubility, and ALV venous gradient. What are the effects of expired gas? So when gas is expired from the patient body, CO2 is absorbed by soda lime, and oxygen, nitrogen, nitrous oxide, exhaled volatile anesthetics are some amount are absorbed and others are expired in the exhaled gases. And this concentration is mixed with fresh gas flow, and when it is mixed with the fresh gas flow, it is further diluted with fresh gas flow and the concentration decreases, and it is called the hypoxic mixture, as when we are mixing the expired gas with the fresh gas flow and we are fixing the amounts or the concentration which we want to deliver the patient. So if we are fixing 50% of oxygen which should be delivered to the patient, ideally it is not delivered to the patient, because in the expired gases it is like less than 50% which was expired after absorption in the body. When it is mixed with the fresh gas, so the fresh gas is mixed with expired gas, and from the higher concentration, the oxygen goes to lower concentration. So now at this moment, the fresh gas is not containing 50% of oxygen, it is diluted and it is lesser amounts. So same way, dilution of volatile anesthetics also take place. So while using the fresh low flow anesthesia, we should take care that how much we want to deliver the patient and how much is delivered. So for this, we should know the time constant. What is time constant? When doing low flow anesthesia, if I change my concentration at machine end, then in how much time will it be changed at patient end? The time constant is a measure for the time it takes that alterations of the fresh gas composition will lead to corresponding alterations of the gas composition within the breathing system. So the convey formula is for calculating the time constant. The time constant equals to the volume of the system divided by the volume of gases delivered minus volume of gases utilized. So the time constant, if the volume of the system, if like circle system is 6 liters, and if the fresh gas flow is at the 1 liter, so if we divide 6 by 1 equals to 6. So time constant is 6 minutes. If I deliver some gas, so it will be delivered in 6 minutes. So one time constant reaches to 63% of the concentration what I want to give. So in 6 minutes, while using the low flow anesthesia, it is reaching the concentration is only 63%. Then in 2 time constant it becomes to 83.5%, and 3 time constant is 95%. So if I'm using low flow anesthesia, the time taken to reach the concentration is much more. It is almost 3 times. So T is inversely proportional to fresh gas flow. Faster change in composition of anesthesia mixture is required, so we need to increase the fresh gas flow. There are certain requirements or prerequisites for the use of low flow anesthesia. Requirements for the use of low flow anesthesia are flow meters, which should be at least 50 ml per minute, can reach a leak-proof circle breathing system and airway devices, gas monitoring, providing inspired and end-tidal concentrations of agent. Nowadays, we have gas monitoring in almost all the new machines. So it is very helpful for us. We don't have to use all the formulas which we have gone through till now. We can be vigilant and do good monitoring of the gas monitors on machine. Then we need vaporizers which delivering high concentrations and calibrated to be accurate at low flow fresh gas flow. The breathing system, minimal internal volume to minimize the reserve volumes. And what are the advantages of low flow anesthesia? So the advantages of low flow anesthesia are divided into the physiological advantages, economical, ecological, environmental advantages. Physiological advantages are that it preserves heat and humidity of inspired gas, thereby conserves body temperature and reduces water loss. Improves the flow dynamics of inhaled anesthetic gases, increases mucociliary clearance, improves airway epithelial health, and reduces accumulation of dried airway secretions. In economical advantage, it reduced anesthetic gas consumption, significant savings of the order of 60 to 75% with regard to volatile anesthetic agents. Ecologically, it reduced overflow or fluorocarbons and nitrous oxide which damage the Earth's ozone layer, reduced greenhouse effect due to nitrous oxide and volatile agents. In environmental advantages, it reduced operating room pollution since less exposure to anesthetic vapors during filling. As we nowadays we are talking about the green OTs, so it is very useful in green OTs to produce lesser volatile anesthetics to the environment. So how to conduct low flow anesthesia? Like in all other patients, we have to do the pre-medication, pre-oxygenation, induction, which is as usual. It is usual practice as we do in other patients. Concerning adjustment of fresh gas flow, anesthesia can be divided into three phases: the initial phase, the maintenance phase, which is low flow, and the recovery phase. Initiation phase is of the primary aim of the initiation phase is to achieve an alveolar concentration of anesthetic agent that is adequate for producing surgical anesthesia, that is 1.3 MAC, in which 95% of patients can tolerate the surgical incision. And denitrogenation is also done while by pre-oxygenating the patient. What are the methods to achieve desired gas and agent concentration? So first method is use of high fresh gas flow for initial period, and then we can use of pre-filled circuits. The circuits can be pre-filled by blocking the patient end with reservoir bag and filling the circuit with concentration of volatile anesthetics, nitrous oxide, oxygen, whatever we want, and then it can be attached to the patient, so it can be delivered directly to the patient. And injection of volatile anesthetics. In this, you can inject like 0.2 to 0.3 ml of volatile anesthetics into the circuit, and while the gases flow through it, the vapors are formed and can be delivered to the patient. Initiation phase of low flow anesthesia is sufficient. We need sufficient denitrogenation, avoiding gas volume deficiency, rapid washing of the desired gas composition into the breathing system, and establishing of the desired anesthetic concentration is the initial high flow phase. The following settings of the vaporizers are used routinely during the initial phase. Halothane 1 to 1.5 volume percent and fluorine 2 to 2.5 volume percent, isoflurane 1 to 1.5 volume percent, sevoflurane 2 to 2.5 volume percent, and desflurane 4 to 6 volume percent. In maintenance phase, fresh gas flow is 500 ml and FiO2 is 50%. Isoflurane is kept 0.8 to 1.2 depending upon the MAC of the patient, and aim is monitor FiO2 and volatile anesthetics. We should be vigilant throughout low flow anesthesia. And in the emergence phase, high fresh gas flow and rapid washout with decreased time constant is done. And costing switching of vaporizer 18 to 20 minutes prior to surgery with low flow, and charcoal filters are placed into the circuit so they can absorb the volatile anesthetics and other gases so patient can be awakened fast. Low flow anesthesia techniques are not suitable in the following settings. Anesthesiologist not familiar with the low flow anesthesia, short term anesthesia with a face mask, procedures with imperfectly gas tight airways, use of technically unsatisfactory equipment with a high gas leakage, inadequate monitoring. Low flow anesthesia techniques combined with a significant overpressure of potent volatile agents should not be applied in situations when other clinical issues like hemodynamic instability require the attention of the anesthesia provider. And there are disadvantages also of low flow anesthesia. Whenever there are advantages, disadvantages also follows it. The lower flow rate and long time constant leads to slower induction and emergence. Quick alteration of inspired concentrations is not possible while on low flows. Continuous vigilance and frequent flow adjustments are required. Higher consumption of CO2 absorbents and risk of hypercarbia and CO2 rebreathing with frequent exhaustion of absorbers is there, and possible accumulation of undesirable trace gases in the system can be seen. The United States Food and Drug Administration recommendations limit sevoflurane exposure to minimum alveolar concentrations, hours at flow rates of 1 to 2 liter per minute of fresh gas flow rates. Fresh gas flow rates less than 1 liter per minute are not recommended. And then there are some pros and cons for use of nitrous oxide. So, while using the low flow anesthesia, what are the positive aspects of using nitrous oxide? So, rapid wash in and wash out and shortens the induction time, and it there is reduction in the opioid anesthetic agent requirement. And cons for using a nitrous oxide are high initial uptake and minimal uptake in later phases, make flow control adjustments more complicated, ozone depletion potential and greenhouse effect, increased incidence of post-operative nausea, vomiting, and it increases gaseous distension of bowels, cavities, and closed spaces. Effects like immunosuppression, bone marrow suppression can be seen with nitrous oxide. Low flow anesthesia without nitrous oxide reduces incidence of hypoxia, and low flows can be initiated early 5 to 7 minutes prior, and vaporizer settings during initial phase are isoflurane 2.5%, sevoflurane 3.5%, desflurane 6%. With low flows, increase dial concentrations to 2 to 3 MAC, isoflurane 5%, sevoflurane 5%, and desflurane 8%. The staggering amount of environmental pollution due to anesthetic gases during the present day practice virtually mandates every anesthesia provider to take that extra bit of effort to use the available facilities to implement low flow anesthesia. Thank you.
Thank you, Dr. Jyoti, for a wonderful, insightful talk on low flow anesthesia.
Thank you, sir.
You have aptly covered the various aspects of low flow anesthesia, the technical ways as how to proceed with the low flow anesthesia, the environmental advantages, the environmental dimensions, and the clinical pros and cons. If there are any questions, would like to take any questions from the chat box. I think there are no.
Sir, we don't have any questions. No, sir.
Dr. Jyoti, can you just add some dimensions once we are practicing low flow anesthesia in infants? How to proceed with infants?
Sir, exactly. We are not using that low flows in our hospital, but I think because in adults in long surgeries we are using, but not in infants. So maybe we will start in the same way like the adults, like initially we will keep the flows on higher side to achieve the concentration. Definitely, I will not go for the pre-filled circuits or the volatile anesthetics injected into the circuits. I will not go because I have never seen this and I've never practiced this. So maybe with the high flow, I will achieve the concentration. Then if the surgery is for the longer duration, then only I will prefer the low flow anesthesia. So the child can be maintained on low flow, and then before like extubation, maybe it is recommended like 18 to 20 minutes prior to end of surgery in adults, but in infants I would like to stop the low flow minimum half an hour before the surgery ends.
Fine, and I think it's better to use volume slightly on the higher end because of the high metabolic rates in the infants. And
Yes,
any
sir.
special precautions once we are dealing with the patients who are having chronic obstructive pulmonary disease or
Yes, sir.
obstructive or restrictive lung
Yes,
diseases?
sir, because CO2 is not washed out properly in them. So like maybe they retain CO2.
So
Yes.
we would just play with the expiration and all
Yes,
that.
sir.
And just
Yes, sir. Then we have to be like very vigilant with the monitors, and maybe ABG need to be done in between arterial blood gas examinations so to detect how much is there. In infants, I'm not that much confident, sir, to use the low flow anesthesia.
Thank you. Thank you so much for your insightful talk.
Thank you so much, sir. Thank you.
Over to organizers.
Thank you, sir.
Sir, I would request you to kindly stay. Hello?
Yeah, yeah.
Yes. So because the next session we have with us Dr. Anjali, who will be speaking on opioids, including urexil opioids. So kindly introduce her, sir. Thank you so much.
Okay, thank you. Our next speaker is Dr. Anjali Singh, and she is assistant professor in the Department of Anesthesia at ABVIMS and RML Hospital, New Delhi. Her areas of interest are the regional anesthesia, airway, and pediatric anesthesia. And she's today speaking on the opioids in the neuroxyl blockade.
Good evening, everybody. Myself, Dr. Anjali Singh, Assistant Professor, Anesthesia Department, Dr. RML Hospital. And today we are here to discuss about opioids, the table viva and the various questions which are asked in table viva for opioids. So I have with me Dr. Dhanush and Dr. Adiba, who are postgraduate 3 and 2nd year students, 3rd and 2nd year students. So to start with, Dr. Adiba, can you please tell me what you understand by opioids?
Yes, ma'am. Opioid refers to all exogenous compounds, both natural as well as synthetic, which bind specifically to a subgroup of opioid receptors and exert their agonistic action of analgesia without loss of consciousness, touch, and proprioception.
So how will you classify them?
Based on the structure, opioids are classified into endogenous opioids, which includes enkephalins, endorphins, dynorphins, natural opioids, which include morphine, thebaine, codeine, semisynthetic opioids, which are obtained by a slight modification modification of the natural opioids, and these include heroin, folcodeine, oxycodone, synthetic opioids, which are synthesized with the phenanthrene nucleus rather than just being a modification of natural opioids. These include fentanyl, alfentanil, sufentanil, pethidine, methadone. Based on the chemical structure, they can be classified into phenanthrenes and benzyl isoquinones. Phenanthrenes include morphine, fentanyl, morphine, thebaine, and codeine, whereas benzyl isoquinones include papaverine and noscapine. These do not have any analgesic effect. Based on their action on receptors, they can be classified into pure agonist, agonist, antagonist, and antagonist. Pure agonists have an action on the mu receptors. These include morphine, fentanyl, alfentanil, sufentanil, pethidine, etc. Whereas agonist and antagonist, they have an action on the agonistic action on the mu receptors and an antagonist action on the kappa receptors. These include buterphenol, pentazocine, and nalbuphine. Whereas antagonists are naloxone, naltrexone, and nalmefene.
So, Dr. Dhanush, how do these opioid receptors act in the body?
Opioid binds to specific opioid receptor present in presynaptic and postsynaptic sites in brain and spinal cord. The opioid receptors are 7 transmembrane G protein coupled receptors. On binding, opioid binding to these receptors, they undergo a conformational change, thereby they produce GTP from GDP, which in turn blocks the adenylate cyclase intracellularly, which in turn reduces the calcium conductance and increases the potassium efflux, causing cell hyperpolarization, thereby reducing the neuronal conduction.
Neurotransmission. Okay.
Yes, ma'am.
So, what all types of receptors are present in the body?
There are 4 types
What
of
all type of opioid receptors?
There are 4 types of opioid receptors: mu, kappa, delta, and nociceptin. In mu, there is mu1 and mu2, where stimulating mu1 will cause analgesia, euphoria, urinary retention, and stimulating mu2 will cause analgesia, physical dependence, and constipation.
Depression of ventilation, which is
Depression
a
of
major
ventilation.
side effect of this mu2 receptors. Okay. Then kappa.
Kappa, on stimulating kappa, there will be analgesia, diuresis, dysphoria, diaphoresis, and diuresis. And stimulating delta receptor will cause analgesia, hypoventilation, sedation, urinary retention, and constipation. Nociceptin is mainly involved in patient's basal pain sensitivity and tolerance to opioids.
Okay. So, what are the various uses of the opioids, Adiba?
Opioids can be used to produce sedation for analgesia, can be used as a part of balanced anesthesia, can be used as a part of total intravenous anesthesia, can also be used as a part of opioid-based anesthesia in cardiothoracic vascular surgeries. It can also be used as an adjuvant in neuraxial anesthesia, can be used for palliative pain management.
So, what are the side effects of these drugs?
All opioids will have some side effects similar to the prototype drug morphine. As in central nervous system, it causes, in the absence of hypoventilation, it causes decrease in the cerebral blood flow and decrease in ICP. But whereas in patients with head injury who have a depression of ventilation, there can be increased PCO2. So in such cases, there can be raised ICP. So in patients with head injury, it has to be used in caution. And also the integrity of the blood-brain barrier is damaged, so the sensitivity to opioids can be increased.
Okay.
In cardiovascular system, it causes bradycardia because of increased action of the vagal neurons. It can also cause hypotension, which can be either bradycardia induced or histamine induced. Also, it has a direct depressant action on the SA node, as well as it decreases the conduction of cardiac impulses and thereby decreases the risk of arrhythmias.
Other systems?
In respiratory system, it causes a dose-dependent depression of ventilation. This ventilation can sometimes be very severe, leading to apnea as well. And it manifests as decrease in the respiratory rate and increase in tidal volume. In the gastrointestinal system, it causes increased contractility of the smooth muscles of the biliary tract, thereby causes the contraction of sphincter of Oddi and can lead to biliary colic. and it also decreases the gastric peristaltic movements, delays the gastric emptying, in turn can cause increased absorption of water and can lead to constipation. In the genitourinary system, it will cause increase in the tone of the detrusor muscle as well as increase in the tone of the urinary urethral sphincter. So there will be a difficulty in voiding.
So any drugs which we can use to relieve this biliary colic?
Yes, ma'am. Glucagon 2 mg intravenous route can be used.
And
naloxone can also be used, but it will also reverse the effect of analgesia.
Okay. So any other side effects apart from the systemic side effects, Dhanush, which you are aware of,
Ma'am, cutaneously,
which are significantly seen also?
ma'am, cutaneously it causes pruritus by directly stimulating the cranial nerve 5 nucleus, and in spinal cord it blocks the dorsal horn impulses, ma'am, and it also causes erythema and urticaria on site of injection. It causes nausea, vomiting by directly stimulating the chemoreceptor trigger zone, and it also decreases the gastric emptying and increases the gastric secretion. So the incidence is very high, and it also causes cough suppressions by suppressing the medullary cough center. Dextromethorphan is a good example where it is widely available as a over-the-counter drug which produces cough suppressions but has a minimal analgesic effect. The fentanyl and remifentanil given in high doses and rapid boluses will cause generalized muscle rigidity, especially in chest wall and abdomen, called wooden chest syndrome, which can be counteracted with giving muscle relaxants or an naloxone. Patients can also develop meiosis, can also have post-operative respiratory depression, all those things, and they have high incidence of addiction and overuse, ma'am.
Abuse.
Ma'am, abuse.
So what is the most frequently used opioid by you at your workplace, Dhanush?
Ma'am, fentanyl citrate, ma'am. Fentanyl citrate.
Can you explain about fentanyl?
Fentanyl citrate is a synthetic phenylpiperidine derivative, a highly lipophilic drug, which comes in 2 to 10 ml vial ampule has a fentanyl citrate salt. And it also comes as a transdermal patch, buccal soluble films, and transnasal spray also.
Okay. So vial का क्या concentration होता है?
It comes as a 50 microgram per
ampule. Sorry,
ampule. It comes as 50 microgram per ml concentration.
It's available in a 2 ml ampule.
2 and 10 ml
ampule. So 50 micrograms per ml. Okay. So how is it metabolized in the body?
It is a highly protein bound drug and highly lipophilic drug. When given IV, 75% of the drug will go and settle in lungs, where from there it will be slowly released into plasma as the plasma concentration decreases. Its main metabolism is from hepatic route, which is ND methylation, which converts the fentanyl into norfentanyl, a major metabolite. It is excreted by a kidney up to 72 hours after ingestion. There are other metabolites like hydroxypropylene, fentanyl, hydroxypropylene, norfentanyl, and 10% of the fentanyl excreted.
Hydroxypropionate fentanyl. Hydroxypropionate
norfentanyl. And 10% is excreted unchanged.
Okay. So what various uses we can make of fentanyl? What all different uses we can use, and what are the side effects I think we have discussed? Can you elaborate on the uses?
Fentanyl can be used for sedation in monitored anesthesia care in 25 to 50 microgram intermittent boluses. It can also be used for analgesia and patient controlled analgesia in doses of 1 to 2 microgram per kg, maintaining 1 to 2 nanogram per ml in plasma concentration. And it also can be used for balanced anesthesia and part of total intravenous anesthesia with propofol in doses of 2 to 10 microgram per kg initial bolus, followed by 0.2 to 0.02 to 0.2 microgram per kg per minute infusion. And it is also used in eye opioid induction in cardiothoracic surgeries in dose of 5 to 75 microgram per kg in adults, and it is also used in children with 25 to 50 microgram per kg. It can also be used for as transdermal patch in chronic pain management can be used for as a soluble buccal mucosal film. It can be used for pediatric preoperative
Preoperative.
sedation.
Early preoperative.
It can also be used as intrathecal adjuvant for local anesthetic to prolong its action. For
What dose?
intrathecal, it can be used in 10 to 25 microgram at bolus, or in epidural, it can be given with 20 to 100 microgram bolus.
Any specific significant side effects of fentanyl?
Fentanyl causes postoperative nausea, vomiting, pruritus, and it also has incidence of opioid-induced hyperalgesia in the postoperative period. It also
That is
causes,
with all opioids.
yes, ma'am. It also causes postoperative respiratory depression, sedation, and urinary retention, constipation, and
So what
intraoperative.
is opioid-induced hyperalgesia?
It is a paradoxical increased sensitivity to pain in the patients giving high opioids intraoperatively, which is caused due to increased sensitization of spinal cord to glutamate and substance P, and and NMDA receptor plasticity, which can be counteracted by using multimodal analgesia with various other drugs and like an NMDA antagonist like ketamine intraoperatively.
So multimodal analgesia is preferable to reduce the incidence of opioid-induced hyperalgesia.
Yes, ma'am.
So Dr. Adiba, any other opioid which you've used apart from fentanyl in your workplace?
Yes, ma'am. We use morphine sulfate, ma'am. Morphine.
No. Elaborate on morphine.
Yes, ma'am. Morphine is a hydrophilic. It is a phenanthrene derivative. It is a weak base. It is dispensed as morphine sulfate, sulfate being the salt, in 1 ml ampule consisting of 15 mg per cc, ma'am.
So what are the various routes of administration of morphine and the various uses?
Yes, ma'am. It can be used as a part of balanced anesthesia, wherein it is given intravenously in doses of 0.05 to 0.1 mg per kg. It can also be given intramuscularly in doses of 0.1 to 0.2 mg. When given intravenously, the peak onset
kg.
mg per kg. Yes, ma'am. When given intravenously, the onset occurs in 15 to 30 minutes. The peak effect is seen in 45 to 90 minutes, and the duration of action lasts for around 4 to 6 hours. It can also be given orally in a dose of 5 to 40 mg every 4 to 6 hourly. It is available as tablets of 5, 10, 30 mg tablets. It is especially given for cancer pain management.
Palliative.
And all palliative management. And also in lung cancer patients, it can be inhaled as an aerosol and relieve the cancer pain.
Again for palliative care as a nebulization also. Any other?
It can be given intrathecally in doses of 50 to 200 micrograms, and in epidural bolus in dose of 1 to 5 mg, ma'am.
1 to 5 milligrams.
Milligrams.
So how is it metabolized in the body?
It undergoes hepatic metabolism into morphine by glucuronidation into morphine 3 glucuronide and morphine 6 glucuronide. Morphine 3 glucuronide is a larger metabolite accounting for 70 to 80%, and it is an inactive metabolite, whereas morphine 6 glucuronide accounts for almost 10 to 15%. It has an analgesic effect. Both these metabolites are excreted in the urine. So hence in patients with renal failure, the metabolites can accumulate, leading to prolonged action. So it has to be taken care in hepatic and renal diseases, dose modifications.
Right. So, okay. So, okay. Any other opioids apart from morphine and fentanyl you've heard of, Dhanush?
Remifentanil, alfentanil, sufentanil.
These are the newer, more
Yes, ma'am.
newer opioids. Okay, so can you briefly tell about remifentanil?
Remifentanil is a synthetic phenylpiperidine derivative, a highly lipophilic drug, which comes as a remifentanil hydrochloride salt. It comes as a lipophilized powder with glycine, and it should be reconstituted with sterile water to maintain its pH. And it has a very 15 to 20 times more potent than fentanyl, and it is rapidly degraded by plasma, blood, and tissue esterases. So its contact sensitivity half-life is 3 to 5 minutes, and that it can be used in daycare surgeries, and it can also be used for sedation in monitor anesthesia care at a dose of 0.05 microgram per kg, and can also be used for balanced anesthesia and as a part of TIVA at the dose of 1 to 2 microgram per kg bolus, followed by 0.5 to 1 microgram per kg per minute infusion, ma'am. And side effects of this include nausea, vomiting, almost similar to the fentanyl, and it has less incidence of histamine release, so less hypotension. But it is very poor for post-operative analgesia, as its action is very less, ma'am.
Sure, Dad.
Yes, ma'am.
Because of the low context sensitivity half time, as soon as if you're giving an infusion, you stop it, the analgesic action goes away fast.
Yes,
So you need to give a little opioid with a longer duration of action if you got to cover the post-operative analgesia.
Yes, ma'am.
Okay. So Adiba, can you
Yes.
just enlighten us about the important points regarding sufentanil and alfentanil?
Yes, ma'am. Sufentanil is again a synthetic lipophilic phenylpiperidine derivative. It is 5 to 10 times more potent compared to fentanyl. It is dispensed as sufentanil citrate in ampules consisting of 50 micrograms per cc. It is used in doses of 0.1 to 0.4 micrograms per kg for balanced anesthesia. Its advantage is that it is more cardiostable compared to fentanyl and also has a rapid onset and rapid emergence, ma'am. And it undergoes the metabolism by hepatic metabolism by dealkylation. And yes, ma'am. Alfentanil is again a lipophilic phenylpiperidine derivative, but it's less lipid soluble, but it still crosses the blood-brain barrier efficiently because of its non-ionized fraction, which exists at a higher amount in physiological pH. Its advantage is that it has less post-operative nausea and vomiting and has a rapid onset of action. It is given in doses of 150 to 300 micrograms per kg.
As a part of balanced anesthesia.
Balanced anesthesia.
Is it approved for intrathecal administration? Can we use it?
Ma'am, sufentanil has been approved, but alfentanil has not been approved.
Is it available? Are these drugs available in India?
No, ma'am. As of now, sufentanil and alfentanil are not available in India.
Remifentanil is available.
It is available in private setups, ma'am, not in our administration.
Okay. So, Dr. Dhanush, there are so many opioids, earlier opioids, old opioids also, which we used to use, but now we have stopped. Can you briefly tell about other opioids which you are using in your work practice?
Tramadol hydrochloride, ma'am.
Tramadol is one. Okay. Any other opioids which you use?
Pethidine, buprenorphine, pentazocine we are using.
Okay. Can you just briefly explain about these?
Yes, ma'am. Tramadol, it comes as a tramadol hydrochloride salt. It is a synthetic phenylpiperidine derivative. It acts on mu receptors causing analgesia but doesn't cause respiratory depression. It also inhibits serotonin and noradrenaline reuptake in the nerve terminals, ma'am. It is used for analgesia in 1 to 3 milligram per kg, and for post-operative shivering, it is given as 1 milligram per kg, ma'am. And it should be cautiously used in patients who are on MAO inhibitors and other antidepressants.
Why?
As it can precipitate serotonin syndrome, ma'am.
And what is serotonin syndrome?
There will be increased serotonin in the nerve terminals, causing agitation, irritability, tachycardia, hypertension in patients, and with nausea, vomiting, and diarrhea if tramadol and other opioids like pethidine is given, ma'am.
So how do you manage that?
Usually we should stop administering the drug and give IV fluids to the patient, and if the symptoms doesn't alleviate, we have to give benzodiazepines to the patient.
So other opioids apart from
Ma'am.
tramadol which you are using or have used or can use?
Pentazocine, it is
Pentazocine,
a mu opioid antagonistic action with kappa agonistic action, which is used for DNC procedures and sedation, and it in doses of 30 to 40 milligrams. But its unique feature is it causes increase in heart rate, increase in BP.
Contrary to the other opioids.
Yes, ma'am.
Okay, so these are basically used in your wards.
Yes, ma'am. And
apart from the operation theaters.
Yes, ma'am.
And other,
Buprenorphine comes in 0.4 milligram per ml vial and as a patch. It is used for acute pain relief and the patients who are on opioid use disorders, ma'am. Along with naloxone, it is approved as a fixed dose regimen. Buprenorphine.
pain management.
Yes, ma'am.
So, okay. Opioids have a very significant tendency of tolerance and dependence.
Yes, ma'am.
So, can you just explain what is tolerance with opioids and dependence and how to deal it?
Opioid tolerance is a decrease in pharmacological action of a known dose of opioid, where there is need of increasing the dose of opioid to obtain the same analgesic effect. It is due to receptors and desensitization, downregulation of the receptors, alteration in the secondary pathways intracellularly, and there is NMDA receptor increased activity. So we should use the opioids in along with the other anti-analgesic agents, and we can counteract this by using ketamine, ma'am, which is NMDA antagonist.
And what is dependence?
Dependence is a physiological state where the patient's body adapts to the drug, ma'am, where the patient will feel withdrawal symptoms once the dose is reduced or where the abrupt cessation of the drug is there.
So, how do you deal with these withdrawal symptoms? What can you do?
Short-acting opioids for the initial stage, and to subsequently reduce the opioid use, we can give longer-acting opioids like methadone or buprenorphine with naloxone is approved in these patients, ma'am.
So, in withdrawal patients, even a very small dose of the opioids can help control the symptoms.
Yes, ma'am.
Okay. You need not give the doses which the patient was originally taking or was
Yes, ma'am.
used to. Okay. So, Dr. Abiba, have you seen patients with opioid overdose? How do they classically present, and what is the management of opioid overdose?
Yes, ma'am. Opioid overdose patients classically present with a triad of depression of ventilation, meiosis, and coma. Some patients can also present with flaccid muscle paralysis, with seizures, with hypotension, and upper airway obstruction as well. We primarily manage the patients by mechanical ventilation and with an administration of an opioid antagonist.
Okay, so what opioid antagonist do you use?
Ma'am, we use naloxone commonly, ma'am.
Naloxone. So what doses and what is naloxone and in what doses can you use?
Yes, ma'am. Ma'am, naloxone is a non-specific opioid antagonist which binds to all the opioid receptors. It is given in doses of 1 to 4 micrograms per kg for the reversal of depression of ventilation. But its disadvantage is that it also reverses the analgesia. Also, it has a shorter duration of action lasting for 30 to 40 minutes. So when a prolonged action is required, supplemental doses have to be provided. Also, we can use continuous infusion of 5 micrograms per kg per hour, such that and titrated such that only ventilation, depression of ventilation is reversed and not analgesia, ma'am.
So apart from naloxone, any other opioid antagonist you are aware of?
Yes, ma'am. We have naltrexone and nalmefene as well. They have longer duration of action, ma'am.
As
Lasting
compared to
for naloxone, lasting for almost 8 to 12 hours.
Okay. So, Dr. Dhanush, nowadays from opioid-based anesthesia, we are moving towards opioid-free anesthesia. So, can you just enlighten us about opioid-free anesthesia? What are the advantages and what all scenarios can you use opioid-free anesthesia?
Yes, ma'am. Opioid-free anesthesia is completely eliminating the use of opioids in perioperative period while using multimodal agents to provide anesthesia, analgesia, and sympathetic suppression, ma'am. The rationale of using this is opioids causing post-operative respiratory depression, post-operative nausea, vomiting, urinary retention, delayed gut motility, and use chronic use resulting in overuse and overdose. So to prevent
to prevent all these things.
Yes, ma'am.
So any subset of patients where opioid-free anesthesia is really helpful or can help us?
The patients who are known to use or using or abusing the opioids and are susceptible to opioid side effects like patients who are having OSA, obesity, elderly patients. And ambulatory surgeries, we are avoiding opioids, ma'am, because it is causing delayed gut motility and all those things. And it's also
Oncosurgery, patients
oncosurgeries.
undergoing oncosurgeries, patients with respiratory insufficiency. These are the appropriate patients wherein we can use opioid-free anesthesia.
Yes, ma'am.
Also, since ERAS protocols are being adopted day by day, surgeons are moving towards that. So it's really helpful for us to adopt opioid-free anesthesia. So what all drugs you can use for this?
NMDA antagonists like ketamine, alpha 2 adrenergic agonists like clonidine and dexmedetomidine, lignocaine infusion, and in NSAIDs, NSAIDs like acetaminophen, ketorolac, and they can also be used. Magnesium sulfate can also be used. Gabapentin and its analogs, and yes, ma'am, beta blockers to suppress the intraoperative sympathetic stimulations.
So basically, with opioid-free anesthesia, we have a goal to avoid opioids so that the hemodynamics are also not compromised, along with providing nociception and post-surgical pain.
Yes, ma'am.
So, okay, opioids, any non-opioid drug which you know which can provide analgesia to the patients. Non-opioid, newly discovered drug. Yeah. Dr. Diva,
Yes, ma'am.
any non-opioid, recently FDA-approved drug used for moderate to severe pain, which can actually replace your opioids. Okay, so this is a new drug, suzetrigine. Okay, it's a sodium channel blocker and it's used for moderate to severe pain. And it's metabolized again by the liver by enzyme CYP3A4. So any drugs which interact with the same set of enzymes, they can have drug interactions. Okay, approved for moderate to severe pain recently in 2025. So this is a newer drug. Please go have a look in case it's asked.
Yes, ma'am.
Okay, sure. So now let's to wind this up. Thank you everybody for listening so patiently. Thank you, Dhanush. Thank you.
Thank you, ma'am.
Excuse me.
Yeah, Dr. Anjali, can you listen? Can you hear? Are you done?
Ma'am, can I have one question? Means not a question. Dr. Ishri, ma'am.
Yeah.
Am I audible, ma'am? This is Dr. Nityanandan.
Hi, Dr. Nitya.
Ma'am was telling about one drug recently approved by FDA in 2025 for the analgesic action.
This is the last drug जो उसने discuss किया था अंजलि. ये पूछो अंजलि से. अंजलि.
Dr. Anjali, are you there?
Okay. 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 Fine, ma'am. No issues. If it's not there, no issues, ma'am.
No. I'll get back to you.
Nitya.
Yes. We'll get back to you.
Nitya.
Ma'am, yeah, ma'am.
Beta, just drop that question in the faculty group.
Okay, fine. Okay, ma'am.
ठीक
Yes,
है?
ma'am.
We'll get Anjali to answer back to you.
Okay, fine. Thank
Yeah.
you, ma'am. Yes.
Thank you, Nitya.
Yeah, ma'am. Thank you.
It is done.
हाँ, तो अभी बस वो announce कर दो, सबमिट कर दो.
So, thank you, Dr. Anjali, Adiba, and Dhanush for such a comprehensive review on opioids. And now we are winding up for the day. Thank you to all the delegates for being present here, listening to the lectures. It has been really a very exhausting day for all of you. But I'm sure the lectures today, they were excellent. This was an excellent academic fiesta, and you would have gained immensely from whatever has topics that have taken place. They were taken by the stalwarts in anesthesia, and you would have definitely gained something new. So as being done in the previous days, we have again prepared 10 questions for you to answer. So they'll be posted in the chat box as well. That has already been posted in the chat box, as well as they'll be sent in your WhatsApp group. Google form will also be activated within 5 minutes of this. You have to fill that Google form and answer back 2 entries that would answer all the questions right. First, they would be given a prize tomorrow. In fact, the prize is that they would be reimbursed back whatever the registration amount has been. So we'll be waiting for your answer, and I hope you enjoy answering them back. We also have posting a Google form for for a feedback, and we would like to know from you about the lectures, the speakers, the topics that were covered, the technical issues also, and so that we can improvise further in our presentations. Thank you so much to all of you for being here, and see you tomorrow again. Thank you so much.
आप लीव करो, लैपटॉप को शट डाउन